Check, check, check. Check, 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 check. Check, 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 check. Check, check. Check, 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 check.
கில்ல 3D செக் பண்ணியிருக்குல்ல. கில்பர்ட் கேமரா ஒரு இது பண்ண பேன் பண்ண சொல்கிறாங்க. த்ரீ டி செக் பண்ணிக்கோங்க. ஃபர்ஸ்ட் கேஸ் வந்து 2D தான், செகண்ட் கேஸ் தான் 3D. கில்பர்ட் கேமரா ஒரு பேன் பண்ண கில்பர்ட் அப்படியே. அப்படி ஒயிட் பண்ணி விட்டுரு கில்பர்ட். ஏன்னா அங்கே கேஸ் ஸ்டார்ட் பண்ண போகிறாங்க 5 மினிட்ஸில். அப்படி ஒயிட் பண்ணி விட்டுரு. ஆடியன்ஸ் வர்றதை பார்த்து அவங்க இது பண்ணுவாங்க.
Good morning, everyone. We'll start our surgical potpourri session. I welcome the moderator and chairperson for today's session, Dr. Vinay Sultanpur and Dr. Vijay Sajjanar and Dr. Ravindranathan. Dr. Ravindranath, uh,
Just in another 5 minutes, we will be ready with the audio visual from the live streaming from the OR3, and we'll go live in 5 minutes.
the first surgery will be done by Dr. Shilpa. Within 2 minutes, we are going live. Dr. Shilpa is ready with her case.
Make it.
கில்பர்ட் ஸ்க்ரீனை ஃபோக்கஸ் பண்ணிக்கோ. ஸ்டார்ட் பண்ணுறாங்கண்ணா.
Okay. So welcome everyone. So I invite Dr. Vijay Sajjanar and Dr. Ravindranath, Dr. Vinay Sultanpur to moderate the first session of the second day. So again, starting with our live surgeries, we will be having both 2D as well as 3D displays, which is happening alternatively. Dr. Shilpa Male, our cornea and refractive consultant from M. Joshua Institute, Hubli, will be now starting her cataract surgery on 2D. And simultaneously, Dr. Guru Prasad from his 3D display will be ready to demonstrate a scleral fixation of the IOL. So first we'll start with Dr. Shilpa. Dr. Shilpa, are you ready?
Yeah, good morning, sir.
Okay, Shilpa, how far the things have come? Are you ready to?
Yeah,
Yes, sir. We
ready
will
to...
present the case history, sir.
Yes, sir.
So this
Okay,
is a
okay.
brief
Then I hand over the mic to the chairpersons.
So this is a brief case history of the present case. It's a female who is 60-year-old will be operating on the right eye with a best corrected visual acuity of 6 by 60 with a lens grading of NS2 with PSC with a biometry reading of a difference of astigmatism of one diopter with the axial length of 21.55 millimeter with IOL power of plus 25 diopters. We'll be inserting a CT Lucia, sir.
Okay. One diopter you're not planning toric, madam?
No, sir.
So you're planning your incision at the steeper axis or what?
Ma'am, your mic on, ma'am. Silpa, ma'am.
Yeah, I will be planning it on the axis. And she has a little bit of pterygium, so we have not planned the toric IOL, sir. So let me start. Good morning to one and all. I start with my side port incisions. I prefer my incisions to be limbal, almost 3 clock hours away from the planned main incision. Light baga. So I injected intraocular oculant. Now I am replacing the fluid into the anterior chamber with the viscoelastic substance, and the end point will be complete fill of the anterior chamber with the viscoelastic substance. So I am of a thought that I do my rhexis through the side port incisions. Because the patient is under topical anesthesia, I prefer using a stabilizing suture tire forceps through the other side port incision. I start in the center, make a 1 to 2 millimeters of a linear cut, and then I invert the flap on itself. And I completed my rhexis. So here one more point I wanted to tell you is that CCC, it has to be continuous, of different shape is okay, but a size is what matters. Whenever we are doing any hydro procedures, it is very important for us to take off the anterior capsule out so that it does not stick to the corneal endothelium. A little bit of decompression by washing off the visco so that no sudden increase in the anterior chamber pressure. I did an hydro dissection first, tap the nucleus, go to the another site and do one more round, tap the nucleus again. A little bit of shifting of the nucleus anteriorly gives you a feel that your hydro dissection procedure is complete. I really do not rotate the nucleus as I am very confident about my hydro procedures. Is it well centered, Dr. Vinay?
Almost.
Okay. So
Now it's fine.
okay. So I enter irrigation off into the anterior chamber always, and then I switch it off, switch it on. This is my chopper. I prefer using a sharp chopper. Light palm, halunaka. So the loose cortical matter is aspirated so that I can have a bare view of the nucleus. I am going to demonstrate a direct chop. You see this, you are hearing the machine sound. This is where you are supposed to chop, holding the foot pedal position in the same position. Leave, regrasp, repeat the procedure. So this is how we get different multiple pieces. You can see a complete separation of the nuclear fragments. You can make light baga. You can make as many fragments you want. This is an early NS3 cataract. So I start emulsifying. So attacking the fragments one by one. A little It is
Shilpa,
very important that we stay in the center safe zone. Yes, sir?
can you just share your settings, please, there?
Yeah. Can you just
Asking machine settings, not mind setting.
light baga? Okay.
Mind setting is very good.
Thank you.
Oh, yes.
So I
Vacuum
prefer
550,
visco.
flow rate 38.
At this stage, I prefer refilling the viscoelastic substance so that I push back the posterior capsule.
Do you switch off the irrigation when you inject viscoelastic?
Yes, I definitely. Otherwise, you won't be able to.
Feel the
And I
anti-rage.
take advantage of moving the pieces again to the center, and I'm good to go.
For the benefit of the postgraduate, was it a horizontal chopping or a vertical chopping that you did?
It is a combination technique, sir, what I do.
I mean, do you really cross the rexis margin and go to the equator of the nucleus?
Uh, for harder cataracts, I really don't. But if I have a very softer cataract, yes, I do that.
It's oblique chop.
No, what was the need for filling the viscoelastic while you withdrew the probe?
Sudden collapsing of the globe, I really didn't want it to. When I learned, I was emphasized it on my mind that whenever you refill the anterior chamber and doesn't let the chamber collapse, it reduces the chances of post-operative CME. So I prefer filling it, and it gives me time also to load the lens. Can I get the lens, please? So here I am going to implant a Zeiss C2 Lucia lens, which is an aspheric lens, a preloaded lens. It is heparin coated. So this is how the lens comes in. We are just going to take this off. You can see the lens sitting nicely there. All the preloaded lenses I prefer after injecting viscoelastic substance, I just nudge the lens a little bit so that I know it is mobile and it is not stuck anywhere. Just close it. Look for the lens to move. The movement of the lens is checked. And then you are good to go. I hope it was appreciable.
You want to do a hydro implantation or
I prefer doing hydro implantation, sir, for all single piece lenses. For a little bulkier cataracts, the cortex will be very little. So with the irrigation, I am just polishing the PC a little bit. I don't use the vac mode of the machine, but I believe in manual polishing of the PC.
Dr. Shilpa, do you use any adrenaline in the irrigation bottle? Irrigation
No,
fluid?
sir, no, sir.
In spite of almost after the completion of surgery, your pupil remains the same. Means your manipulations are excellent.
We really don't. I prefer not to inject many things into the anterior chamber. I am of a little older school thought. So I started injecting the lens. The beauty is that the lens does not open with a snip. It opens very slowly. It gives you time to inject the lens into the bag.
C2 Lucia loops are very lengthy. Almost they touch each other at the opposite end.
Yes, so you have to give a little more time for them to open up. So in this time, meanwhile the lens opens up, I hydrate my side ports. Light baga, light paha. So after hydrating the side ports, a little bit of viscoelastic substance that is there will be washing off. The globe is neither too tight nor too hypotonous. At the end, I prefer using intracameral moxifloxacin. I hope you appreciated the surgery.
Dr. Shilpa?
Yes, sir.
You injected intracameral moxifloxacin.
Yes, sir.
Do you prefer preloaded or the vial format?
Preloaded one, sir, because that is the one which is preservative free.
Why not the vial?
So I feel that even taking it out from the bottle and injecting it again into the antechamber, chances of infection might be a little more, or we have to really keep a check on to when did we open that bottle. If someone has kept yesterday's bottle today, that becomes a difficult for an busy setup. So what happens, intracameral moxifloxacin, it's on table and everything that is available on table is thrown at the end of surgery. So I really don't have to bother. It does not spoil my peace of mind.
Cost-wise also quite a significant difference is there.
Definitely, but I think that safety and a surgeon's peace of mind is more important than cost. I guess we can recover the cost than having endophthalmitis.
Okay. Thank you, Dr. Shilpa. That was a wonderful surgery which you have displayed.
Thank you, sir. Thank you.
Thank you, Dr. Shilpa. That was a very excellent demonstration of a very clean surgery. Now I think it's time to shift to the 3D format in OT2. Dr. Guru Prasad must be ready with the case. Can I have the audio from the OT2?
Yes, sir. Just a minute, sir. We will present the case history first.
Okay. So that was Dr. Shilpa Malaj showing you a dense cataract. It was almost nucleus grade 3, and she did a combination of a horizontal and vertical chop, and effortlessly she could eat it up. And I think now it's time for the case from the vitreoretinal OT. Can we have the case presentation?
Yes, sir. Good morning, everyone. I request everyone to have your glasses on. So this is a case of a 70-year male who presented with us with diminished vision. He had a posteriorly dislocated IOL and will be doing a vitrectomy with SF-IOL with a 4-flange technique. It will be done by Dr. Guru Prasad, sir. So we'll be showing you the initial parts, after which we'll be proceeding with the SF-IOL part. Thank you, sir.
Sir, your mic on, sir.
Dr. Guru Prasad?
Yes.
Good morning, sir.
Good morning.
So Dr. Vijay Sajjanar and Dr. H.M. Ravindranath and Dr. Vinay Sultanpur are here as moderators.
I am honored.
So we are very happy to see you all ready for the case. So can you just give your idea about what is going to be the demonstration today, sir, and what exactly the points that we are going to learn today from your surgery?
Thank you, Dr. KP. So what I am going to show is an IOL explantation, because it is subluxated, probably dislocated in the lying down position. You won't be able to see it. Maybe it will float up after the infusion cannula being put. But in any case, it has to be removed by vitrectomy, because I don't want to just drag it out from the pupillary plane with all the vitreous attachments in place. I don't want to jeopardize the vitreous base area and cause iatrogenic retinal complications. So I'm going to do a proper vitrectomy, meaning 3-port vitrectomy, and explant the lens. And I'm going to put a scleral-fixated lens by the 4-flange technique, innovated and popularized by Sergio Canabreva of Brazil. So that is the technique I have learned from his videos. So let me start. Maybe as I am doing the tunnel and flaps, after that we can probably switch over to some other surgery.
So the plan is OT3 will be chipping in, so we just show the, shows the eye, And then we'll be switching to Dr. Shilpa again.
Correct, correct.
She will show in a quick phaco and again we'll come back to you. So we'll be visiting you between our cataract cases, sir.
Sure, sure.
So we make sure that you won't leave the OT.
So that is the aphakic eye. ಹೆಸರೇನು ಪೀಟರ್ ಪೀಟರ್ ಆಪರೇಷನ್ ಶುರು ಮಾಡ್ತಾ ಇದ್ದೀನಿ ನಾನು ಡಾಕ್ಟರ್ ಗುರುಪ್ರಸಾದ್ ಅಂತ ಸೊ ಇನಿಷಿಯಲಿ ಐ ನೀಡ್ ಟು ಮೇಕ್ ಎ ಟನಲ್ ವೆನ್ ದ ಐ is still firm. I don't want to have a soft eye and try to that's the tunnel I'm going to make.
So this is a phaco emulsification case, sir? Like what was the...
This was actually, yes, it was done long ago in our own institute, maybe 10 years ago, and now it has got subluxated, probably because of zonulopathy that was there inherent.
So what are these conjunctival openings are for?
The superior one is for the SICS wound, which I'm going to use for the IOL implantation. I'm going to put a rigid Scleral-fixated IOL. So I need a 6.5 mm incision at least in order to pass the IOL. So I will be opening these conjunctival areas for making the flaps. The side flaps are actually for the Hoffman's pouch. I am very particular that the knob caused by the flanging is covered properly. Come, flush this. By the flaps. Many times if they are exposed, so this is a step for the SICS wound. Actually, I don't need to cauterize much here at the sides because I'm going to make a Hoffman's pouch, but sometimes what happens is the blood gets into the pouch, flush sister, and that makes it difficult to locate the area where you want to actually pass the needle.
Guru sir, HMR.
Yes, I can.
Sir, what is,
Your
what
voice
is
is
the cautery, sir, you're
unmistakable.
using? You're ordering bleeding to stop with that probe?
That is the cautery. Ordering?
No, I'm seeing for the first time which cautery it is, sir. So it looks very, very elegant and.
That's a cautery which we use in the retina, which I am using it here also, that's all. So I'm going to make a frown incision here also in order to reduce the astigmatism.
So you're around 5.5 millimeters, sir?
No, actually it should be 6.5. I'll extend it later.
Okay, sir.
This is only to sort of explant the lens. The lens is a foldable one, which needs actually about 3.5 to 4 mm incision only to get it out.
So for later, for the next implantation.
Is it centered?
Yes, sir, it's fine.
Okay, so I'll put in an infusion now because I don't want a soft eye for the rest of the surgery. Can you see the infusion cannula inside?
Yes.
Can you see the infusion cannula and the trocar inside in the pupil?
Yes, sir, we can see clearly.
I'll just focus it now.
No, sir, you can see, sir.
Yeah, so that's important to ensure because we don't want any choroidal effusion. That's the basic principle of any vitreous surgery.
So what about where the pupil is not relenting, like you have a small pupil, bound on pupil where you can't
Then
really
I will
see it?
probably put an iris pupil expander or an iris hook.
So that is non-negotiable. You need to see it before you connect it.
Yeah, it's important, sister. No, Hoffman pouch, first knife. So I'll make a Hoffman pouch here. So I have the habit of holding the muscle to sort of stabilize the eye. This is the circumferential incision. A very thin flap I'm going to raise here. Actually not raise, but it's going to be a pouch. Just about 3 millimeters deep and about 4 millimeters wide to cover the, actually cover the flange. Flush here too now. So this has to be at the limbus because our measurements are important. 1.5 millimeters from the limbus is where we pass the needle with the suture. So this landmark is very important. I'm using my left hand now to make the pouch. Flush. Keep flushing. I think this is not deep enough. So
Dr. Guru Prasad,
Yeah.
very soon we will be shifting to OT3 with the 2D, where Dr. Krishna Prasad Kudlu will be demonstrating a cataract.
Okay.
Is that okay with you?
Absolutely. So
Yes.
once I am done with my vitrectomy and I am about to explant the lens, I will come back.
Yes, sir.
Allow me to come back so that I can show
please
that.
do it slowly, sir, because
Yeah, I am doing it purposely
don't finish
slowly.
it off.
So this is the problem with the left hand if you are not an ambidextrous surgeon. It takes a little longer for the temporal flap for the right eye.
Sir, can we switch?
Okay. So I'll present the history for Krishna Prasad Kudlu, sir. He's a male, 75 years old with BCVA 612 partial. Lens status is NS2. Biometry, axial length is 24.41. He'll be putting one Zeiss trifocal lens for the patient with the IOL power of 17.5 diopter.
Can we have the audio from OT3? Good morning, Dr. Krishna Prasad Kudlu.
Can you hear?
Yes, very clearly. You are visible as well as very clearly audible. Please go ahead, sir.
Guru Prasad sir, Satyamurthy sir, and my KP sir, and my younger brother Srinivas for this wonderful opportunity. But what an opportunity for me, because first time I am doing under Centurion Phaco, supposed to be one of the best Phaco in the world. So after coming here, the OT staff said that Zeiss Phaco machine is not working.
KP, Centurion is Alcon people are lucky to have you now. This is HMR.
Sir, good morning HMR sir. So I am just doing today a trifocal intraocular lens, model number 839, which is a dual, that means it is with the hydrophilic with the hydrophobic surface. So normally, as we all know, that Rexis has to be done almost like around side port, around 5.5. Since HMR sir is here, I just wanted to tell him that I am using the same side port of Shah distributor. I am finding bit all these entry blades are very good, but only problem is with them is most of the blades, every alternate blade tip is bent. So when I discussed with Shah, they always say that we need to refine with HMR sir. I think this is not the right place to talk about that.
No financial interest disclosed in this.
I do.
No, yes, I actually I have also been talking about this inconsistency of the sharpness, but over the time their quality has really improved, and that is one of the best Indian blades available now.
Yeah, definitely, sir. If you ask me, that is probably the best available blade. So I'm just doing the hydrodissection. It's just grade 2 nucleus.
So what is the plan, sir? What exactly is your method of nuclear emulsification that you're planning?
I'll go for a direct chop only, sir.
Okay. Can you slightly center it for the benefit of the audience? And we welcome Dr. N.S. Molidhar,
Nailor.
the immediate past president of KOS and a vitreoretinal surgeon from Bangalore.
Fine. Chopper. Blunt chopper.
Can it be better centered? Yes, thank you.
Is it okay now?
Yeah, perfect.
Yeah. Just wake up. Chopper, blunt chopper. What? Just foot control. No, that's okay.
Is it a ballpoint chopper, sir?
Yeah, ballpoint chopper actually for soft nucleus I started doing with ballpoint chopper.
Excellent. So perfect 2 halves. Excellent surgery, Dr. Kodlu.
Actually,
KP?
this machine KP,
Yeah.
Dr.
I
KP?
purchased initially. Due to some unavoidable circumstances, I am not having, but it is a fantastic machine. As you all demonstrating now, I could able to see.
I think it means a lot to Alcon coming from you, Dr. Kodlu.
Yeah, and the person who is assisting me, I should be really thankful to him for that. He said that, sir, you are
Dr.
doing for
KP?
the first time. So what he told me, only one word that,
KP, sir.
sir, you just keep doing the surgery.
Only good.
See, most of the, I think
The
all,
machine will do everything.
machine will do everything. You are right only, sir. And all genius surgeons are around here.
No, it's like sticking in the crease and runs will come on its own sometimes.
Yeah.
Just
Just-
like that.
Inverter, please.
No, sir,
Please
like,
be here.
But
new-
KP, it doesn't appear you are using that machine for the first time.
No,
So
sir.
fluent.
But an excellent demonstration.
happy aqui. Because most of the time when we do with Visualis 100, I always operate with the Zeiss microscope, and what happens is with the Zeiss microscope, with the same mode only we tend to finish everything.
No problem. Now it's not required.
So Zeiss microscope, Zeiss machine and Zeiss lens. Huh?
I just wanted to tell that.
No, today
Mulidhar is
I'm really happy. Thanks to once
Ask
again
the
Alcon for wonderful assistance. The machine is fantastic. I think a side.
Can we call that surgery as pan Zeiss surgery, KP?
No, sir. Sir, just a minute, sir. They are centering, sir. Satyamurthy sir is here to help me out for. Banta, sir.
Can it be centered,
No,
sir?
center.
Can somebody help
Banta,
us in
Banta,
getting it
sir.
centered all the time?
Now?
Yes, sir. Perfect.
Yes, sir. Thank you, sir. Just I'll take another hardly 5 minutes to just to finish. Always new pitch is always new pitch only. But I still remember
this is
that
not
day.
new pitch. I still remember few years ago you did a fantastic job on Visualis 100.
Yeah.
I still remember your surgery in your early formative years, long back.
But every time our elder brother Satyamurthy sir keep helping me for doing live surgery. I am so much thankful to him.
Can you just tell us something about the lens that you are using, Dr. Kudlu?
Yeah, it is actually hydrophilic with a hydrophobic surface. It is a trifocal lens from Zeiss. I have used more than 1,000 lenses so far. I think now, if you ask me why I always tell about this lens, for two particular reasons. One is because of, if you ask me, I always think about the hybrid lens. The lens has got both nature of hydrophilic with a hydrophobic surface. So that
You have the flexibility advantage of
of both hydrophilic and
lens.
hydrophobic, because water content like hydrophilic and the property like hydrophobic.
Yeah,
In the
best of
coming
both of
days, Dr. KP, Visco, I always feel that I think these lenses are going to be stay forever, because most of the companies nowadays even thinking about getting their models in a hybrid lenses.
Yeah.
That is the reason I've been using this lens. We did one small comparison between a hybrid lens and the pure hydrophobic.
External camera, can you zoom it on the lens, please? External camera. Zoom it on the lens. Zoom it on the cartridge. Zoom in.
Yeah. Yeah, actually, I will do it under microscope only.
Yeah, also, but let him zoom from outside.
Dr. KP, can you see me? This is a blue mix injector.
Yeah.
Just go to the slot. Now, I got a one click. Now, I'm just removing the cap of the cartridge. You can see the lens.
Yes,
With,
that's
I
a plate
think
haptic.
It's a plate. I can say it's a 4 haptic lenses. This has got a two focal points. One is for the near and the one more is for the intermediate. That is near at 3.33 centimeter and intermediate at 1.65 centimeter. So the basic concept is most of the professional nowadays want their lifestyle straight away set it for intermediate vision, especially computer professionals and also so many even driving. But I have compared these lenses especially for a couple of things. One is amount of glare and halos with this particular lens is much lesser compared to any other lens available in the market. See, you can see how I am almost, it is centered, the Purkinje image is almost centered in the center of the IOL. That means I need not have to do anything with this.
Yes, perfect. Very nice overlap of the capsule also. And a plate haptic always fills the entire bag, I think, for the long-term stabilization and non-rotational stability.
Once again, thank you so much. KP is also moderating, and Satyamurthy sir really helped me, and initial guidance from Deepak Megur also helped me to do this surgery quite well. I think.
Congratulations, Dr. Krishna Prasad Kudlu, for an excellent demonstration of a trifocal from Zeiss and an excellent surgical steps demonstrated. Thank you so much. We'll be soon leaving you to join Dr. Guru Prasad in from the 3D
Thank
OT.
you so much. Thank you so much.
Dr. Guru Prasad, can we just switch to 3D now? Because he has already done the initial steps, probably has explained the lens also by now, and he's ready for the SF-IOL. Dr. Guru Prasad?
Yeah.
We are on to you.
Simco.
Yeah. Can you just explain, sir? People please can put on the glasses again.
Can you see the streaming?
Okay.
Okay.
Sir, can you explain us what exactly you are doing?
What exactly I am doing is passing a 6-0 suture, threading a 6-0 suture through the bore of the 26 gauge
What
needle.
suture, sir, it is?
6-0 polypropylene.
Okay, Prolene. Okay.
Non-absorbable.
Looking like snake swallowing one more snake.
Simco.
Yeah. So I bring it out till the other end reaches the bevel. Okay. So I have kept 2 such threads ready. That is a IOL which I have kept purposely there to show you that.
So you did vitrectomy, sir, for that?
I have done vitrectomy, removed all the adhesions and separated all the adhesions from this IOL. explanted it with forceps, and the final explantation from the wound
Identify the
is happening
landscaping.
now. That's it. So I've done the vitrectomy, so there's no fear of any vitreous adhesion or vitreous traction happening now. So now is time for the SFIOL. So what I'll do is the SFIOL ready?
So it was a single piece acris of IQ lens which had dropped down.
Correct, correct. So what I'm doing is I am raising the Hoffman's pouch here and 1.5 millimeters behind the limbus. On, sister, on. Yeah. I am passing this needle and entering the vitreous cavity.
With the suture in the bevel,
Suture in the bevel, you can see that.
Yeah.
And now I'm going to push it to make me, to help me to hold on to this and pull it out. So you can see that it is out now.
Yes, sir.
Just holding, pinch the infusion.
Yes, sir. Finished.
So with the vitreous forceps, which I use very liberally in all anti-segment surgeries as well nowadays, I bring it out. And then, so we have one loop of suture between the Hoffman's pouch and the main wound. So here what I do is, I cauterize the end of the suture to create a bulb or a flange. Some people call it dumbbell, some people call it flange. You can see that it is flanging. This is to prevent its slipping into the vitreous cavity. So you can see this flanging, right?
Yes, sir.
Okay. I just keep it at a comfortable length, both inside and outside. The other needle I'm going to pass from this side. I'm just going to, I've not marked it exactly 180 degrees apart, but I use this technique of keeping the needle there and finding out the longest diameter in order to sort of identify the place where I'm going to puncture the sclera. So on this side it happens to be here. I'm going to pass it again 1.5 millimeters behind the limbus inside the pouch. One has to be very careful in this particular steps because if you let go of the needle, it can easily damage the retina, or if it strikes the retina, it will cause. Sorry, the suture has come off.
Yes.
The suture has come off. So I'll do it again. Suture illi ಕಾಣಿಸುತ್ತೆ ಎಲ್ಲದು. I think I lost the suture. ಕಟ್ ಮಾಡಿ ಭಾಳ ಉದ್ದ ಮಾಡಬೇಡ್ರಿ. ಎಷ್ಟು? ಹಾಂ, ಇನ್ನೂ ಉದ್ದ, ರೈಟ್. So I'm sorry, I was trying to save time when Dr. KP was operating, but it actually ended up with losing more time now. Forceps. All right. So, fortunately, it was fast. Flush. So, this is what I was saying. Here, you have to be careful not to direct the needle towards the retina, and yeah. Now I push this into the pupillary area. Okay. Now for the ILM forceps. I'm sorry about the bubbles which are obstructing the view.
So if this were to be not a case like this, maybe just an aphakia without a capsular support, Still some vitrectomy is required, sir, for this?
Not a total vitrectomy, at least clearing the vitreous from the pupillar area and the retropupillar area to create a cup of fluid, a fluid compartment, which is unlikely to cause vitreous traction in the vitreous base area.
So what is this cautery that you are using?
This is called Bowie's cautery. Probably the person who devised it or designed it is Bowie. So that has to be big enough so that it doesn't slip into the vitreous cavity. So we have two sutures now. I am sure you are able to imagine the rest of the surgery, but I will show it to you.
Sir, two questions. One, this is 60
Now
Pro.
the IOL. Wait. Ready to go.
We have used 50 Prolene also in the past. Why did you stop using 50 Prolene?
50 Prolene tends to be stiffer, and there is a chance of a lens tilt because of its sheer stiffness. It is not so malleable, and it causes a little stiffness, and the centration of the lens doesn't happen as well as with the 60.
Suppose the Bowie's cautery is not working or somebody doesn't have, what alternative method do you use to make a flange?
Well, you can use a ballpoint cautery. The ballpoint cautery which we used in the previous day, maybe when I started practice in 1980s, we were using the ballpoint cautery. So this is another flanging. So this is actually the 4-flange technique. It's another flanging that is happening here. And here it's very important that this flange is big enough not to pass out through the eyelet of the IOL. So I am going to check it for the size. I am going to pull it and see whether it slips out. So this step is important. I have the habit of sort of fixing the IOL in the wound. Infusion off. Put a lot of visco on the lens sister. Yeah. So I will keep it there. So that's the importance of an optimum incision size just to fit the IOL, because if it's too large, then the IOL can slip back into the vitreous cavity. Yes, so I am going to cauterize this end also, make it a bulb. Yeah. Now I will check it again for its size. I am going to check that it is not going to come out from this eyelet. So now both the haptics are fixed. I am just going to pull them, make these short so that it is not messy and doesn't get entangled. I am going to make sure which suture goes which way, the right one going to the right side and the left one going to the left side. Otherwise they can cross each other inside the vitreous cavity and create problems again. Many times we have had to, in the learning curve, we have had to explant the lens by cutting out the sutures and do the entire procedure all over again. So now we will have the infusion on. Yeah. So visco, sister, lot of visco.
I think for anterior segment surgeons, maybe an anterior chamber maintainer would do the job of the infusion that he has gone into the pars plana here.
Off. 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 So there it goes. There's a lot of air bubbles in the AC which I want to remove because I want to have a clear visualization of the sutures. I don't want any entanglement at any cost. Sister, visco.
Dr. Guru sir, what is the secret of having such rock steady hands at this young age, sir?
I'm sure you're being sarcastic.
Sir.
They're not rock steady anymore. So thank you for the compliment.
It's the muscle memory, you know.
Yeah. So I didn't make a side port. Sister one go. Dialer pottery. Oh, I'm sorry, there is some iris.
I think iris getting dragged with that.
One loop has gone into the iris.
So can you do this side and then come back to that?
No, the iris has to be separated. Yeah, it got separated now. Yes, I'm just going to check whether that's of the right side. Yeah. And then this side, this is the suture.
I think ambidextrity is the key here probably, which is probably the hallmark of all vitreoretinal surgeons.
Infusion on. Dialer. Yeah. Okay, so now I will cauterize this wound, this thread here. Sister, iron forceps, sister. I'm going to hold it very close to its exit from the vitreous cavity with a forceps like that, and that is the vitreous forceps. Cut this off and then cauterize to make a bulb.
I think this is a very crucial point because this will decide how the lens finally stays.
A little amount of sagging is allowed here. Cut scissors, hold this. Tire. Yeah. So get that suture out. Get that suture out. So now the best part of the Hoffman suture is that it is possible to bury the flange. It's very important that even when we do a sutured 90 sutured IOL fixation, it's very important that everything is covered because that can create a wick or act as a wick for.
Perfect, sir. I think he
future
needs an
ceremonies.
applause for this. Very well demonstrated, sir.
Wonderful
Excellent.
surgery, Guru. Wonderful surgery.
Thank you, thank you. So
only one question: have you ever had the knot kind of exteriorize or erode through sclera?
In the beginning, yes. Can you suture or give me 10-0 suture? I know the nimisha. Yeah,
okay.
So I'm going to suture the wound and then go in and examine the periphery of the retina.
Okay.
For any iatrogenic complications.
So if you don't mind, can we finish Dr. Deepak Meghur's surgery and come back to you on this?
Please.
Yes, sir. I think over to OT3, where Dr. Deepak Meghur is ready with his case. Can I have the audio feedback from the OT3? Dr.
Yes,
Deepak
sir.
Meghur?
Yes, sir. I'll present the brief history of the same.
Yeah.
So he'll be operating on a male 60 years, female 60 years, with a BCVA of 1/60, lens status NS3/4. Biometry, the axial length is 24.17 and IOL power will be 20 diopters. He'll be putting Clarion lens for the same patient.
Dr. Deepak?
Yeah.
Good morning, Deepak.
Hi HMR, hi KP. Thank you again for the privilege to operate here in this operation theatre. So patient has a small scar here, corneal scar. The nucleus appears to be slightly dense and the plan is to stain the intercapsule. So I'm using Oculan.
Yes.
Okay. So I'm using Oculan under air. I prefer to use it that way. And this will be followed by staining of the intercapsule. Am I clear, KP?
Yeah, very clear.
Sure.
In fact, we all have marveled at your videos and the kind of the surgery that you have shown and available in the YouTube. So there's I think an opportunity to see you live in flesh and blood operating in our OT. Thank you, Dr. Deepak, for agreeing to do this. And please go ahead.
KP, it's my pleasure. Thank you. Why are you being so formal? You're putting under me stress now.
No, for others he is being formal. Afterwards he'll talk separately to you.
Okay, what's the plan like? What exactly is the surgical
now
plan?
the plan is I'm going to inject Viscoat. This is a patient with the nucleus, the cataract is slightly mature. So I'm going to do my rexis under Viscoat itself. And so I've made 2 side port incisions, stained the capsule, put in Viscoat. I'm going to create the main incision now.
Normally you do rexis to the main port or the side port?
In mature cataracts like this, I'll be using forceps. Then I'll be using the 15
What is this
number blade.
Crutchfield tongs? What is this contraption?
Deepak Meghur's fixator.
It's just a globe fixation ring. So I prefer to make a posterior limbal groove first and then create a 2.8 incision. This is a bibevel blade and so you have a nice valvular effect. We
In
don't
a topical surgery, does the patient feel the discomfort with this? No.
No. No, forceps. Rexis forceps.
You use a ultrata, you don't need to use a needle.
Saldipurkar forceps ittella. So I'm trying to puncture the capsule also with the same forceps. Let's see. Bimanual cannula kodri. Stabilize madake.
You do it under hydro.
Bari cannula kodri. Aspiration cannula. Tagdu biಟ್ಟು.
Oh, that's like a fixator.
Yeah, I just want to use
You have a
some
cross,
device.
I believe. You've been
Yeah,
using-
yeah. I usually have multiple instruments, but not got it, I think, here. So I'm using some device.
Planning for little larger axis, Deepak?
Yeah, yeah.
But man proposes, God disposes sometimes. But with
Yeah,
Deepak
planning
Mega-
was, because the nucleus is slightly denser. So I was hydrodissection, good, hydrodissection. So just planning a slightly bigger axis in this case. So hydro is going to be very gentle. I'm going to decompress the chamber a little bit before I do that.
I think this is a very important thing, because if you have a viscoelastic like, like viscoat or a premium viscoelastic, if you do a vigorous hydrodissection without removing the viscoat, decompressing the AC, it can lead to some problems with the PC. Because
So
the fluid has to come back to the anterior chamber after the hydro. So you cannot pressurize the anterior chamber without...
So now I'm using HPMC underneath the viscoat. So this acts like a modified soft shell technique. I don't want the viscoat to be present in the vicinity of the bag where the energy is being delivered. So
Near the tip of the probe.
yeah, because it's thermogenic.
Yes.
So I'm just trying to ensure that the lens is loose enough before producing to do...
Quite a compact nucleus, quite a hard nucleus. You normally use Centurion?
Yeah, I use Centurion and Infinity both, and sharp chopper. Sharp chopper. So in this is slightly denser cataract. So what my strategy is to first, always work in the epinucleus mode to just get the flow running. Epinucleus mode. Is it epinucleus
Just zoom
mode?
it down a bit. Zoom it down.
Okay,
slightly.
sorry.
Okay.
Is it okay?
Yeah.
So first is always, start with the epinucleus mode just to clear off some of the viscoelastic and epinucleus, which is not much. This is just to ensure that the flow is running in the machine. That's important. This is a slightly dense cataract, so my strategy is to create a small trench and then I do a vertical chop. Can I have a sculpt setting, please, now?
Yeah.
You can just tell the sculpt settings, which I'm using now.
Yeah, it's on screen. So you're creating a burrow-like thing.
Yeah, it's just a crater, sort of a crater.
To get a better hold?
Yeah. Because this is bulky nucleus, so I want to hold the nucleus at its core, center. So this gives me access to that. So it's about 50% depth when it goes, then I'll be changing to the chop mode. So important point to now tell is that in chop mode, I'm going to use only the longitudinal energy. Can I have continuous irrigation on, please? Okay. Zoom down, huh? Okay.
Slightly zoom out.
Yeah.
I usually work a slightly higher zoom. Okay. Chop setting, please. So the chopper which I'm using is about 1.5 millimeter long sharp chopper. I'm using just longitudinal energy set at 30%, and then I'll see if it's all right or not, then I can decide.
For the better hold, you are using only longitudinal?
Yeah, only longitudinal. So the posterior plate is slightly thick, no problem. You don't have to go in to ensure a full thickness crack at the first attempt.
You want to get a pie out first to decompress the bag?
No, I would not do that. In direct chop, I usually prefer to do it all in situ. So lateral separation maneuvers a couple of times are important when you're dealing with a denser cataract like this, because you don't get a full thickness crack in the single go. So in your chopping, I think the key is to just lift up the nucleus a little bit, and then you do the maneuvers. By this, you're not pushing anything posteriorly. The common version against the vertical chop is that it's argued that it's going to cause stress on the posterior capsule and all those things. But if you can able to lift the nucleus just a little bit and then do a vertical chop, go down and then laterally separate, it is not going to be inducing any stress to the okay, now can I have quadrant settings now? Now moving on to the quadrant settings, the settings have changed here. So here I'll be using only torsional. So the settings have changed. What is the power, please? Power you used?
Power is just 40% in linear mode,
Okay,
torsional.
it looks all right. If it is taking some time, I'll increase. Otherwise, it should be fine. So
I think this is a wonderful thought because he has used very minimum power usage. I think for a very hard cataract like this, he has never, expended a lot of energy. An absolute, economization of the power usage, so that you have very minimal wound burn or any intraocular damage.
So the second part now, when you're trying to emulsify the fragments, the endothelial damage happens at this stage itself because you're trying to emulsify at a much more anterior level. So I usually use my second instrument obliquely so that it acts like a guard, sort of a guard, and prevents these fragments from jumping around and hitting the choroidal endothelium. So what is the ideal level of emulsification? My preference always is to emulsify them at the level of the rhexis margin. Although today, I think it's slightly anterior. I'd just like to tell the 3 indications where you would want to emulsify much more anteriorly. One would be whenever you have a rhexis which has gone off. Second would be when your posterior capsule is compromised and you still have a fragment to remove. And third would be something like an IFIS, where if you work anteriorly, viscoat please. If you work much more posteriorly, there will always be going the iris billowing happening and the pupil comes down dramatically. So these are the 3 indications. And there is a 4th indication, there's a secret indication, which KP has taught us. Actually, KP has told it to HMR. HMR has shared to me. And that is live surgery. So these are the 4th indication. So because the iris was just coming out, I put in a little bit of viscoat and then I'm nudging the nucleus back and...
You slightly tilt the probe a
Sir,
bit so
ಸ್ವಲ್ಪ
that
light
you go
ನೋಡಿ
little
sir.
obliquely, right?
Light ನೋಡಿ sir.
The bevel is slightly turned.
Yeah. I usually prefer it like this, horizontal, because this gives us a maximum exposure of the surface area of the tip to the quadrant to be aspirated. So that's the reason I prefer to do it like this. So not much of a cortex is there as because this was sort of a mature cataract. No, I want saline.
Mayank?
I'm just going to flush the posterior capsule just to clean off some of the fibers. This is an easy way to clean the PC. I prefer to use this, especially some of these mature cataracts, the cortex would be very much adherent and it will be difficult for us to remove it. Can I have polish mode, please? Okay. Can I have Pinocaine? Pupil has come down a little bit. Okay. I'm just using Pinocaine just to dilate the pupil a little bit. Viscoelastic lens.
Deepak, have you used Phenocaine in otherwise also, like initially, without dilating pupil?
Yeah, I have used. It works. How do you do this? Rotate it. It works well when the pupil is not rigid. Okay. So the pupil is rigid, then it is unlikely to help you. So this is the Clarion lens which I am expected to implant, and we have this notch which has to be removed. But before that, the lens is loaded inside here. Before that, I'll be filling the cartridge with the viscoelastic. They've given a hole for this. And then this has to be unlocked. And we see this lens here. And I prefer to always push in some more viscoelastic through the nozzle. This helps to push the haptic down. And then we have a better chance of it folding when it comes. So I'm pressing this device, and the plunger is moving side, and we can see that the haptic is folding. Just stop here once we reach this mark. That's the guard here.
Dr. Deepak,
yeah.
What are the advantages of this clearer lens over IQ lens apart from being preloaded?
Yeah, of course, the preloaded gives us a lot of benefit as far as the sterility is concerned, ease of use is concerned. The material is supposed to be different. The presumed advantages are less glistening compared to the IQ material. By look-wise, it just looks like an IQ which is preloaded. But I believe there are some changes, fundamental changes in the material itself. It's supposed to cause less glistenings. It has got a rating of better clarity. And of course, it is supposed to create lesser PCOs, and it's better for PCO control. I have been using this lens for the last maybe 6 months. 6 months is too early a time for us to comment on PCO, but that is what the claim by the company is. And the control delivery is quite good. Viscoelastic.
Which is a better material for handling? Is it the Acryso IQ or Clarion?
Handling, because we don't handle this lens, I really can't comment on this because we hardly touch it.
The way it goes into the bag? Or
yeah, of course, this is more elegant, definitely. And it is one of the better automated delivery systems because we have viewed multiple preloaded lenses. Among them, I think this is one of the better ones which I have experienced. And I have not had any surprises. One surprise would be the leading haptic. Sometimes what happens is it doesn't, is it too zoomed in or something?
It's okay.
First case I injected outside the eye. That was a surprise.
Yeah. It is possible, you know, because as KP will keep on reminding me, my first case with another lens was I broke it in a live surgery.
No, that was, I think, that was the plan, I thought.
That was the plan.
To show how to handle a dismembered lens.
So it does happen, and it takes some time for most of this thing, preloaded lenses to be there. Can I have the vacuum to be less and flow rate to be less a little bit? Make it...
Any queries and questions from the audience, please? Deepak is doing surgeries.
I just want to lift up the lens and wash out some of the OVD which is behind. Because we just use HPMC, you just have to just irrigate it, that's all. You don't have to have any aspiration or anything.
Have you implanted under the irrigation this Clarion?
Yeah, I have done it. Usually I do it, But as KP says, live surgeries, be a little bit more safety first. I must appreciate the patient cooperation. He's been extremely cooperative. Surgery was done in topical. Sir, operation ಆಯ್ತು ನಿಮ್ಮದು ತುಂಬ ಚೆನ್ನಾಗಿದೆ.
Thank you very much.
And thank you for being so cooperative. Okay? No ಆಯ್ತಾ sir?
Excellent demonstration, Dr. Deepak.
Thank you KP, thank you HMR, thank you everybody. And thank you the entire team of MMJ for giving me this opportunity. It's a privilege.
It was actually a difficult case, Deepak, and a hard cataract with a little corneal opacity, and you did it very nicely as usual. And sealing the wound, Deepak told one sentence, "Bala chanagagide," the patient. I think it's always better to end the note with this word to patient. After sealing the wound, it seals the mind of the patient.
HMR's one-liner can't be beaten, you know, you are superb. Is this antibiotic? So, I'm using intracameral moxifloxacin it is? Yes, sir. Okay. Just, sir, light ಕಾಣಿಸ್ತದೆ ನಿಮಗೆ ಎಷ್ಟಿದಾವೆ ಲೈಟು Okay, thank you. Just important to check that we are not over-pressurized the eye. Okay, yeah. The lens appears to be very well centered and it's covered well by the rexis. So that's it. Thank you.
Excellent, Deepak.
Thank you, thank you.
Any questions from the audience regarding this?
Kan muchkoli, sir.
The next surgery is waiting in the other this thing. This is the next case, huh? Anybody from OTO, which is the next surgery there?
So, Dr. Giriraj is going to give a brief on intravitreal bevacizumab, and then we'll be going over to the OT to see a live demonstration of the same.
Hello. HMR?
Yes.
Now,
so the next
Suresh Babu will be giving intravitreal injection.
Okay, sir.
Okay, so we are to...
This is Razumab.
Yeah.
Next injection will be by Dr. Suresh Babu, sir, our home faculty from MMJI. It will be Razumab injection from Intas, safe, time-tested, safe and effective anti-VEGF. Next slide, please. It is a biosimilar of ranibizumab, recombinant humanized IgG1 monoclonal antibody fragment. It is DCGI approved and being cost-effective, you can expect better patient compliance. So with that, I request Rajeshri to inform us about this patient.
Yeah, so coming back, this is a 66-year-old male patient and he was diagnosed with both bilateral choroidal neovascular membrane for which the right eye has already been injected, and today we are giving a left eye intravitreal Razumab injection for the same. The injection would be given by Dr. Suresh Babu, sir. Over to you, sir.
Good morning. Am I audible? Am I audible?
Yes, sir, you're audible.
Hi, so like Rashti gave instruction, so I will be injecting intravitreal Razumab. Intravitreal injections are the second most commonly performed procedure of cataract surgery. Although it's a simple procedure, any complacency can lead to the dreaded complication endophthalmitis. So first we put a drop of paracaine and then we put a drop of betadine, 5% betadine. Wait for a contact period of 2 minutes. Then make sure you flush out all the betadine before you inject. And then you can either use a caliper. Actually, there is a trocar, so it's pseudophakic, so I will be injecting at 3.5 mm. So it's 3 mm for FX, 3.5 mm for pseudophakics, and 4 mm for phakics. So you can prefer any quadrant. So I prefer the inferior temporal quadrant. So after you inject, just make sure that you plug that point with a bud, and then the sister is injecting topical antibiotics. So like Guru sir actually has given us a mnemonic ABCD. So just A is for asepsis, B is for betadine, C is for after you put betadine, make sure that the concentration of the drug is perfect. Example, for example, amikacin, which can be macrotoxic. And then D is the distance from the limbus and the direction of the needle. So the distance from the limbus I have mentioned already, and direction, don't point it towards the lens, so it should be directed towards the mid vitreous. And after you inject, you can tell the patient to assess the vision by himself every day. We call it SAVE, save actually, self assessment of vision every day. So the patient can close one eye and then he can see how much he is seeing through the eye through which we have injected. Any drop in vision or any redness or pain, the patient has to report immediately. We don't regularly give topical antibiotics, so one drop of antibiotic at the end of the injection will suffice. Thank you.
Very nice demonstration, sir. And yes, for all PGs and everyone else to remember, ABCD and SAVE. Main important SAVE, you can explain after cataract surgery also. Self-assessment of vision every day. Thank you for the excellent demonstration, Suresh sir. Anybody has any questions for Suresh sir? He can take. Or any doubts? Same technique of injection can be used for giving intravitreal antibiotics also in case of suspected endophthalmitis or anything. And it is always better to refer a patient of endophthalmitis after giving the injection if that's possible.
Okay,
Any comments?
so if there are no questions.
Yes, sir, your mic on, sir.
Yeah.
Any comments?
No, sir. No, sir.
Okay, thank you.
So we'll move over to OT2 where Dr. Cyrus is preparing to perform a 2D surgery, phaco. Dr. Cyrus, can you hear us?
Yes, sir. We'll present the history for the same. So,
Yeah, let us know about the history.
Dr. Cyrus Mehta will be operating 60 years old male, right eye, with a BCVA 636, lens status NS3 nuclear sclerosis, biometry axial length is 23.53, IL power 21. He'll be putting VVT lens for the same patient.
Hi everyone, can you hear me?
Yes, sir. Yes, sir.
Yeah, hi. So, good morning everyone, and it's a great pleasure to be here at the world famous MM Joshi Eye Hospital, which I had visited as a postgraduate in 1998 first time. I was in Belgaum at JNMC. So this gentleman, I don't think he has a very dense cataract. This looks more like a RLA to me. And Siruta. Yeah, that's fine. Yeah. So we're just getting it ready and draping him. Chal. Can we start now? Drape lagao. Give my drape. Single gauze. बड़ी आंख खोलो, नीचे देखो, या अभी आंख खुला रखो, बंद मत करो. Elevate the table, please. Where is it?
Sir, can you say a thing or two about the lens that will be used in
Yeah,
this
so
patient?
basically, while I'm just setting this up, can we just turn this and make the microscope axial to the eye? Where's the setting switch? Turn it. Turn. फिराओ उसको, फिराओ. हाँ, चलो. Keep going. जाओ. Bas, that's it, yeah. Is this sterile? Yeah. Let's see. Where is the red glow adjustment on this microscope? क्या ज़्यादा है? Anxiety. हाँ, relax. कुछ नहीं होगा. So patient says, and very rightly so, that he feels a little anxious. आप आँख खुला रखो, डरो मत. इधर पैराकेन डालो प्लीज आँख पे, स्पेक्युलम. बड़ी आँख खोलो, लाइट में देखो. हाँ, ये लाइट में देखो, लाइट में फोकस करो. बड़ी आँख खोलो, आप लाइट में देखो. Hi, where is the red glow adjustment on the microscope? Parakin. Who's here from the microscope? Red glow. Yeah. Yeah, better than before. Is that full red glow?
No, it is not yet, and
Yeah.
need to be centered actually, Dr. Cyrus. Yes, that's fine.
Is that better? You all can see now?
Better, but red glow is still not visible from here. I don't know.
Yeah, it's not visible here either.
Somebody.
Right. This is sterile?
Microscope.
I think this will do the job now. All right. Well, when you don't have enough red glow, you use trypan blue. That's what it was invented for.
That's fine.
Yeah. Chalo.
No, it's better. Red glow is better with the fluid coupling there.
Yeah. So I haven't used this microscope in a long time. I'm normally using a Lumera 700. Abhi hilo mat please. Which basically has perfect red glow. Well, it's a question of time, I guess. Everyone will get one and then...
You got, Cyrus, I'm Kudlu here.
Yeah.
Diamond blade from Mumbai.
Yeah. Because the metal blades now we use only to eat and things like that. In the eye we use diamond. 2%. Also, never forget that you're operating a live human being and he may feel stuff, and also better to use 2% or 1% oculine in the eye with every case. We are centered, no?
Yeah, perfect, Cyrus, perfect.
Yeah. All right, so now we do a little bit of washout with the thin cannula. Yeah. So we depress the posterior lip of the little side pot and wash out your trypan blue. So some red glow, some trypan blue, and now we are set. So we can start now. Inflate the anterior chamber. With viscoat. And let's do a main tunnel now. 2.2. 2.2. Yeah. So this is not a toric case, and so I have the freedom to do my entry here or wherever I feel like what is more ergonomic for me. Let's try to increase the magnification a tad. I think that's
Just
better.
a little bit center right, Cyrus. No, just opposite direction.
The other way?
Yeah, it's perfect, perfect.
Yeah, all right. Rexis forceps. Yeah. Are we well focused now?
Yes, sir.
All right. So let's start. And as I said, some red glow and some trypan blue makes everything easier. And if you have no red glow also, like in the good old microscopes that we had 20 years back, you could still do the procedure. You just needed more trypan blue.
Excellent Rexis, Cyrus, fantastic.
So I don't like to make a very large rexis. It should overlap the IOL a bit. Burp out some viscoat. That's your fluid wave going across. Push the lens back down. Hydrodissect from the other corner. You can see the lens come up. Push it back down. And when you do it the third time, it should pop out from capsular bag, like this. So the lens should be very well behaved, and within 3 attempts at hydrodissection, it should come up like this. Phaco. So show the parameters, chopper, blunt chopper. Yeah.
So Cyrus, I think half the nucleus you get it into the pupillary area and you chop it, no?
Yeah, always. That is much safer in the long term, especially when you do a lot of hard cataracts. So right now I'm just using vacuum, using 700 vacuum to aspirate all this. And about 25% longitudinal. And that's chop 1. Chop 2. Yeah. Now this is semi-torsional with a little bit torsional and a little bit longitudinal, so the tip doesn't get choked. And it's pulse, because I find the cornea looks better that way. Go back to 1, and again longitudinal to embed and chop. And again back to 2 to remove the piece. So piece is always removed with semi-torsional. And when it becomes really nice and soft towards the end, you go to pure torsional like this and get rid of it. So the machine has something called active sentry. And all these big terms means what? It means that you get less surge basically. The sensor is in the handpiece and not in the machine. So the reaction time is faster. So I can use absurd number of vacuum like 700 and things like that and not have any surge, as you can see here.
Fantastic surgery, Cyrus.
So now
just
I'll...
effortless, you made it great. Grade 3 nucleus.
So now we'll do an eye. So the lens I'm going to implant is basically called Vivity. And this lens was launched a few months back. I used a few, I liked it. Basically, it's like it's an extended depth of focus lens. They use something called X-wave, or they stretch the wave front. There's a lot of technical explanation for it. But long story short, you don't get any glare and halos, unlike a trifocal. Otherwise, most of the time I end up using a panoptics, which I find is the best trifocal lens. Suresh, 1 minute, thoda tight lagega. Suction. So these are sandblasted bimanuals from Goider in Germany. They are very nice and give you very good control, because see, this port is small, and the smaller that port, the higher the vacuum you can effectively use and still not get any kind of surge. In any case, in these machines you don't get surge anymore. So this is what you never do. This is what you're not supposed to do. What you're supposed to do is switch hands, and that's why you use a bimanual. The whole idea of using a bimanual is that you can get into places where you earlier couldn't. And that should be the end of that.
Excellent surgery, Cyrus.
Nothing is, the no cortical matter also. I think now all set
Yeah.
for implantation of the lens.
Yeah, so let's do that. Now let's use Provisc or any other sodium hyaluronate to fill the eye. I don't use methyl cellulose at the end because it tends to get stuck inside the eye. I want it all to come out as a bolus to it.
Just center it, Cyrus.
Oh, sorry.
Oh, you cannot see the wound. Yeah.
Now
okay,
can you see?
Fine,
Yeah,
fine.
yeah. So you can see there is no wound burn or hydration or whatever because you hardly use any phaco energy anyway. I always prefer, rather than jamming the injector into the wound, that you extend it a little bit to about 2.5, 2.6 like this. So everything goes smoothly. I personally don't believe that you have to get the lens in through 2 millimeters, otherwise something will happen and everyone will say, "Arey, he didn't get in through 2.2. It's all nonsense. You can very well extend it a little bit to 2.5, 2.6 and do it comfortably. So let's have a look at the lens now. Can you see that?
Yeah, fantastic.
So that's the Vivity.
Yeah.
And it's a typical Alcon lens with a good old Acrisoft design, and that's the central area, the diffraction area. Can you see it there? Is it in focus?
Yeah.
Yeah, now you can see that. Yeah, all right. So let's tuck it into the cartridge like this.
Can you center it a bit? I cannot see the lens, Cyrus. Little bit up you take up. Yeah.
Yeah,
No,
now you
perfect,
can see
perfect.
it. All right, all
Perfect,
right.
perfect.
All right. So you tuck it in like this. Pusher. Then we use a thing called a pusher and push it. The job of the pusher is to push, load it up. So olden days we used to have those screw type injectors. I much prefer the push type. So let's get back to the gentleman on the operating table.
Little bit you center it. Okay, Anyan. We can see now. Perfect.
Yeah, all right.
Now not little bit of red glow. Most of the red glow you can see nicely.
Yeah. So the red glow was impeded by the, whoops. All right. Time to get it in there. Let's tuck this one in. Can you see that?
Yeah. Little bit out of focus, but it's going in. We can really.
I don't know if it's centered.
Yeah. Opposite direction. Yeah, this perfect.
Yeah,
Now,
all
now
right,
you
all
put
right.
it in.
Because my centration and the TV is little different. Okay. So you just rotate it in there. Make sure the haptic is sat down inside. So these extended depth of focus or trifocals are very sensitive to decentration. So we can't afford one haptic being out and things like that. Patient won't see and you'll have to redo the surgery.
Excellent demonstration, Cyrus.
Yeah, you can see the lens is sitting nicely in that capsular bag over there.
Dr. Cyrus, how do you compare PanOptics and VVT in terms of near vision?
So the near vision of the Vivity is not as good as PanOptics, I'll agree with that. But then there is no glare and no halos.
That is the main point, is you don't have
So
glare
when
and
so when I counsel the patient, I tell them, I say, see, how much do you drive at night versus how much do you read? So if you have an 85-year-old, 83-year-old lady, you are pretty sure that she's not going to be driving at high speed at night, but she wants to read. So PanOptics would be a better bet for her. But you have a 53, 54-year-old scuba diver or an adventure sports junkie, and he's got early cataracts and he wants to remove his spectacle number as a bonus, then Vivity would be the lens for him or her.
Do you advise bilateral implantation within a short span of time, or because
Vigamox.
the quality of near vision will be better if you implant both eyes together?
So,
Vivity?
okay, so generally I try to do two eyes together for everyone.
Okay.
unless they are really finicky, and I try to dissuade them from this habit of doing one eye at a time, which I think is silly anyway. So I much prefer to, most of the surgery I do today is bilateral.
Okay.
Suresh, ho gaya.
Good. Excellent surgery, Dr. Cyrus.
Okay,
Well
thank
done.
you so much. And it's a great pleasure to come here and operate in this wonderful hospital. Aankh band karo. Aankh band karo, Suresh. Bas ho gaya. Chal.
Dr. Cyrus,
Yeah.
we have three options in front of you. One is panoptics, one is VVT, and one is EDOF. Other EDOFs earlier we were
Yeah.
there.
Yeah.
Extended depth focus.
Yeah.
So your guidelines for using those lenses is same as you said. Only one is night driving, and second is the near vision requirement for the patient.
Absolutely. So these are the only two basic parameters. The old EDOFs and all I don't use anymore. I don't see the point. So I just would either end up using a panoptics or then a Zeiss trifocal. Otherwise, one of the really new and good Indian brands if the patient can't afford any of the really expensive lenses. And as far as the EDOF lens technology goes, there's a lens called a Rayner EMV, which basically is a surface modified monofocal like an eye-hands. And the person will be about +1, 1.25 for near. So I tell them you'll have small specs for near, but your night vision and intermediate vision will be okay. So some of them opt for that. Most of them will end up opting for VVT or for panoptics. And the advantage of putting the panoptics or the VVT is that Alcon's calculation and lens measurement is spot on. So once you get used to that and everybody is ±0.25 with no cylindrical residual, then that patient acceptance and happiness is better. And as I said yesterday in my talk, one happy patient sends another, but one unhappy patient tells the whole colony, then no one comes. So, yeah. So then better not, suppose you have access only to really cheap multifocals and they're toric, they write anything on the box, they write 2-cylinder, 3-cylinder. After you implant, patient still has 2-cylinder after the surgery. So then you understand that they're just writing something on the box and giving you, and their quality control is little dubious. So that's why with finicky and discerning people, I would just probably put a pantoric for most of these patients.
What is your experience of Indian multifocals?
Oh, very good. That care group has got a very nice triphobic now, which is exactly like panoptics.
Now, what is your percentage of using monofocal versus multifocal lenses in your surgery?
I would say 50-50. 50% of the patients want monofocal, and for their XYZ told them don't put a multifocal, or they had some relative had a bad experience and can't see properly or whatever. So they insist on monofocal lens technology. For all of them, I put a EMV or eye hands. I don't really use a plain monofocal anymore. So all of these lenses will give you a little bit of intermediate without any photic disturbances at night.
Eye hands, you think some intermediate distance is a bonus?
Yeah, a little bit. It's a little bit. The EMV from Rayner is actually better than the eye hands now. And the patient ends up with +1.25, 1.5 to read.
What are your contraindications for multifocal? Suppose these are the patients I don't want to just put multifocal for these patients.
Glaucoma, retinal disease, maculopathy. Otherwise, eye should be perfect. Anything wrong anywhere else in the eye, no multifocal.
No, other than that, like I know these are the very visible contraindications, but a normal eye, you have any something to do with the pupillary size or those?
No, not really. Because generally in Indians, all pupils are same. Unlike in Goras, where they all come, some of them will have 6 millimeter and 8 millimeter pupil. I never seen anybody in India with more than 4 millimeters.
So do you see the use of multifocals on the rise?
Absolutely. I would think so. I would think the multifocal share of the market will only go up with time because one person who has it will tell the next person and the next, and that kind of word spreads. It's like electric car technology. Eventually everyone will be driving electric car and that gasoline will be finished.
No, I think you are right because we think that tier 2 cities and tier 3 cities, we don't use multifocals just because
we must use.
Expensive.
No, we must use multifocals. They have to get into the habit of paying, you know.
Yes.
Basically, they're all stingy and they don't want to pay. They want to pay 10 lakhs for car and
Yeah,
1 crore for house and some
yes.
rubbish, some wedding they'll do 50 lakhs. But they don't want to spend 3 lakhs on their own eyes which doesn't really make much sense to me, you know.
No, like see, the cost of Centurion in Mumbai, cost of Centurion in Hubli are same.
Is same, yes,
So
absolutely.
I think the lens cost is same. So I
Yes.
think technology is same.
Because,
So-
sir, when the person in Hubli buys Honda City and he buys in Delhi or Bombay, also price is same. So there's no reason those people can't afford the same things that we use.
So basically, we have the barrier than the patient. I think first we should come out of
Yeah.
that.
So basically, we have to teach our patient population to remove all their mental blocks against spending money.
Cyrus Kudlu here. VVT is also coming in the toric platform?
Yes.
Yeah. So I just wanted to ask you, how you really consider, how much is the astigmatism really required for to consider if the patient for
So if the
toric
person,
implantation?
if the person is going to be left with more than 0.5 or 0.75, then definitely they will get a toric lens. Because having 1 or 1.25 cylinder after surgery blurs the vision. And then I'll have to end up doing LASIK on top, which means then I'll have to open a blade. Then of course you can't charge them, you can't tell them now you pay for this also, because you already charged lots in the beginning. So what happens is that just rather use a toric lens and then be left with minimal residual correction like 0.25 or 0.5 cylinder.
Thank you, Dr. Cyrus.
Thank
It
you,
was
thank you,
wonderful
sir.
having you at the
Thank
discussion.
you. It was wonderful to be here.
Can we have the lights on for a minute?
Yeah, before we start the next surgery, we'd like to honor our esteemed faculty and the Vice President of Karnataka Ophthalmic Society. I request KP sir and Guru sir to please come up on the dais. I request Dr. Krishna Prasad Kudlu, Founder, Chairman of Prasad Netralaya Group of Eye Hospital. He is the trustee of Netra Jyoti Charitable Trust, established Netra Jyoti Indian Red Cross Bank, Founder Chairman of Netra Jyoti College of Allied Health Sciences and Paramedical Sciences, is presently serving as the Vice President of Karnataka Ophthalmic Society, Member Scientific All India Ophthalmic Society, and former Chairman for Vision Committee, who have served for a period of 6 years. And over and above, a very humble, honest, down-to-earth and ever-smiling personality I have seen is none other than Dr. KP Kudlu, our future Health Minister in the time to become, and before our main minister comes, yes. So we are really honored to have you, sir. Thank you. Thanks for coming.
Thank you, Dr. Srinivas, respected Guru Prasad sir, KP sir and Satyamurthy sir. With blessings from Dr. M.M. Joshi sir. It's really great honor to be part of this wonderful conference. I think Karnataka Ophthalmic Society, it's, I think, which has been started by Dr. M.M. Joshi way back in 1983. And because of him only, we all ophthalmologists from in and around Karnataka going together. Now the Karnataka Ophthalmic Society has become the membership of around 3,500. The one great news is that we all proud to be our most youngest secretary of Karnataka Ophthalmic Society, Dr. Srinivas Joshi is here, and the one more good news is that we, under his leadership, I think we are all doing the Karnataka Ophthalmic Conference in December first week in the same venue. And other pillars of Karnataka Ophthalmic Society, of course, Guru Prasad sir is the past president of Karnataka Ophthalmic Society. Also Dr. Krishna Prasad, who has been, I think, probably the only few pan-ophthalmologists you can see in Karnataka. One is, I always Dr. KP, and one is Dr. HMR sitting down. Both of them, I think, from the Premier Institute, AIMS. I think we all learned from them a lot of things. I still remember yesterday, he was quoting about Dr. KP's performance. I still remember one day we had around 12 DCRs in my hospital one day. Then HMR has to operate within 3.5 hours. Then he was bit convinced. Then suddenly he called Dr. KP. KP said that I'm in Mangalore. One phone call, KP said that within 1 hour I am in Udupi. And he came within 40 minutes, 3 DCS. Can you imagine the skill of Dr. KP? He's been talking about multifocals, torics, but his even oculoplasty and even neurophthal and squint knowledge is amazing. I think this institute is probably I can say, Karnataka's pride institute. Is once again, I thank everybody from MMJ Hospital to give me this honor. Thank you, Ananda.
Thank you, sir. Thank you very much. I think we'll shift to the live surgery.
Light ನೋಡಿ 2 ಗಂಟೆ ತೆಗೀರಿ.
And between 11 to 11:30, we will have our inauguration program, and Honorable Union Minister Shri Prahlad Joshi ji will be gracing the occasion. So till then we'll continue with the live surgery and talks. And we have also the Oration Award, the Lifetime Achievement Award, and the Young Achievers Award, which is going to be awarded very soon. We'll start the session quickly. Over to OT, please.
Yes. Good afternoon again. So this is an NS1 PSC cataract posted for synergy lens. So
Can you change over to the OT input, please? Gilbert, 2D. Yeah. So it's a 2D, you can all remove your dark glasses, and Dr. Shilpa will be showing her another case of cataract.
mic on? Yeah. Good afternoon all. I guess I finished the surgery. It was a softer cataract.
1 minute, Dr. Shilpa.
Yes.
We are yet to receive the live feed of the surgery. Babu.
Okay, so Shilpa is very quick. Before the slide could come in, she's already removed the cataract. Shilpa, we will see it online.
Sir, after the master's operating, it's as good as...
Can you tell us about the lens that you are implanting?
Yeah, the lens I am implanting is Synergy. It is a combination of multifocal and EDOF technique by Technis. Can you hear me? KP sir, can you hear me?
Yeah, please, very clearly.
Okay.
Please go ahead. Continue the surgery, please.
Yeah, so get me the lens, please. So it's the lens negates the aberrations. You can see I am just injecting HPMC. It is a violet light field lens which helps to negate the glare and halos that we get with the multifocal or EDOF lenses. I am just putting the haptics over the optic.
It's something similar to the Technis lens platform?
Yes, sir, it's almost same. The technology only difference, the loading and the lens platform is same.
You are planning a hydro implantation?
Yes. Because already the pupil has come down. I had injected adrenaline. So I am just implanting the lens the usual way.
So you are using it as a guard so that it doesn't touch the...
It doesn't touch the cornea, and it gives me an advantage that it lets the lens unfold very slowly, and the first leading haptic rest in the bag.
Do you think hydroimplantation is risky sometimes?
Yes, it is risky. I wouldn't have done it on other occasion, but today I believe that we have a time constraint, one thing, and second thing is my pupil is coming down, so I really don't want to, maneuver much into the anterior chamber. So you can see the rings, you can see, I guess you are seeing the lens edge optic rexus overlap. The pupil has constricted. I don't believe that you are exactly as...
Yes. Yeah. So that was a great surgery, Dr. Shilpa, and thank you very much for demonstrating this case so effortlessly. I think with that we come to the end of this session, session 1. I thank profusely the moderators, Dr. H.M. Ravindranath, Dr. Vijay Sajjanar, as well as Dr. Vinay Sultanpur for moderating this session very nicely. And before the award and the inaugural ceremony, we would like to kind of prepone the session, that is the mixed bag session. So we would like to start off with the mixed bag session soon. And for that session, I would like to call the moderators, Dr. Chaitra Jaidev from Bangalore, Narayana Netralaya, and Dr. Hanumantappa, who is an alumnus of our institute and now a practitioner at Gangavati, and Dr. Darshan Lad, our own man, ophthalmologist from Haliyad, and Dr. Amay Kulkarni from Kulkarni Eye Hospital, Meeraj, to be the moderators for the session on mixed bag. Thank you very much, Dr. Chitra, Dr. Shilpa, and we will take off from the OT now. And I leave the mic to the moderators, Dr. Chaitra, Dr. Hanumantappa, Dr. Darshan, and Dr. Ameya for taking this. And the speakers in this will be the Dr. N.S. Mulidhar will be talking on the special lecture on cataract surgery and diabetic macular edema. Dr. Ravindranath will be speaking on DCR surgery made easy. And we have Dr. Chaitra Jaidev will be talking on the clinical perspective of DME management. And we have Dr. Ameya with PXA with phacodonesis. You want to ask a question, please? To Guru Prasad, please.
I want to ask one question to Dr. Guru Prasad.
Gilbert, connect the machine. Connect.
Dr. Guru Prasad?
No, he's here.
I want to ask you one question.
Yes, please.
First of all, I have to express that we were not fortunate enough to see your entire surgery of explantation and SF IOL. We missed some parts of it. Second thing, what I want to ask you is, instead of SF IOL, you could have also considered a iris claw lens.
So the answer to that question would be that in my experience, when I've done a total vitrectomy and implanted an iris claw lens, there is an increased tremulousness of the iris claw lens, and the tremulousness causes a little shaky vision in the patient's description. Patient says, I have shaky vision. This is the common experience I have when I've implanted a iris claw lens in a vitrectomized eye, which I used to do very frequently in the past. So I've shifted from iris claw to this SFIOL for vitrectomized eyes. Okay. For a non-vitrectomized eye, where the vitreous is there 90% at least, the vitreous will offer a support for the iris claw lens and it will not be that tremulous.
So during surgery, in case we don't have a good capsular support, we can always consider iris claw.
Yes.
But if you have to do a vitrectomy, then you would recommend SFIOL.
Correct.
Thank you.
That would be the answer in brief.
Thank you.
Yes, Dr. Chaitra, you can just, you are the moderator for this session. Please walk in.
I request Dr. NSM to please come on stage. He'll be speaking to us on cataract and diabetic retinopathy, my commandments.
Good morning, everyone. It's a great pleasure to be back in Hubli. And I think I'm one of the few fortunate members who have been coming to Hubli every time they do an eye fest. I think from the time they started the eye fest, I have been one of their invited faculty. And of course, it's like, it's a family, extended family in Hubli. Dr. Joshi, Dr. Guru Prasad, KP, Satyamurthy, they're all like family members, and it's like homecoming. So we jump at the chance to come to Hubli and be a part of this wonderful eye fest that MM Joshi Hospital is so well known for. And today I am going to talk to you about cataract and diabetic retinopathy, my commandments. This may sound basic to many of you. I really apologize for the content if it sounds too basic for many of you who practice this in your day-to-day life. But this I thought is more as a general kind of a talk on how do we manage a patient with diabetes and coexisting diabetic cataract and diabetic retinopathy. Because in my own practice, I have seen that whatever points I make are not universally practiced, in our profession. And especially for the people who are postgraduates or younger people who are going into starting their profession. So I thought some of these points would be very important for them too. So cataract and diabetic retinopathy, what are the challenges? That's not moving. Can you just check the technical problem? It's not moving on the screen. They often coexist, cataract and diabetic retinopathy. Move ಆಗ್ತಾ ಇಲ್ಲ ಇದು.
While the technical team takes care of the slides, must introduce Dr. NSM. He's the current president of the Vitreoretina Society of India, and he's also the past president of our state society. So privileged to have him here, and though he says it's a very simple talk, I'm sure he'll have a lot of take-home pearls with so many years of experience of handling patients with diabetic retinopathy, and most of them with cataracts being in the similar age group. Over to you, sir.
Thank you. Thanks, Chaitra, for the nice words. See, cataract and diabetic retinopathy often coexist. We all know that diabetes is exploding in our country, and therefore diabetic retinopathy, you're going to see more and more of it in the years to come. And they often coexist in the same age group or the same population. Presence of cataract may make the diagnosis and staging of retinopathy quite difficult because of the hazy view. Because of the same reason, it may be difficult to treat diabetic retinopathy in the presence of cataract. Now, having said that, this was perhaps true, about 10 years ago, when the primary treatment of diabetic retinopathy was lasers. So at that time, presence of a cataract was a great impediment to treat either the macular edema or the proliferative diabetic retinopathy. But today, with the intravitreal injections taking the front seat as the treatment for diabetic macular edema, we could treat DME effectively even in the presence of cataract. But if the patient needs laser treatment, there could be some limitations in treating the diabetic retinopathy. Thirdly, the diabetic retinopathy may progress after cataract surgery. This is a phenomenon which has been seen and felt, although many clinical studies have not really proven this to some extent. Some studies have proven that it progresses, but other studies have shown that it may not progress. But nevertheless, the diabetic retinopathy can progress and has to be kept in mind after the surgery. All this combination of diabetic retinopathy and cataract may make the visual outcome less than satisfactory. And we all know that the vision is the primary criterion by which the patient judges our surgery. Therefore, it's better that we optimize the visual outcome in this group of patients. So how do we manage doing that? So these are my commandments. Commandment number 1 is do a dilated fundus exam of both the eyes of these patients, both with indirect ophthalmoscopy and slit lamp examination. Now this may sound very basic to all of you, but to my great surprise, I learned that this is not universally done, in all patients. Let me again emphasize, this is not just for a diabetic patient. I feel every patient on whom you are contemplating cataract surgery needs these steps, on a universal basis. And I feel, in our own hospital, we do this for every patient who walks into the hospital. Every patient has a dilated fundus examination, otherwise his ophthalmic examination is not complete. But especially when you are confronted with the diabetic patient who is like this patient is a significant cataract. He has got, you can see, posterior subcapsular cataract and also cortical cataract, 65-year-old gentleman. And even with this much of cataract, you could have a reasonable view of the fundus with indirect ophthalmoscope to be able to grade the diabetic retinopathy. Of course, this is a fundus photograph through the fundus camera. Because of the cataract, it's very hazy, but still you can see this hard exudated ring there, which tells you that this patient has some amount of diabetic macular edema. So we are still able to appreciate and grade the diabetic retinopathy before advising cataract surgery in these patients. So this is an important step. All patients undergoing cataract surgery, not just diabetics, this is true of all cataract surgery, need to have indirect ophthalmoscopy with dilated pupils before you do cataract surgery. So once you have done this step, the key question that you need to ask, most important question in a patient in whom you are contemplating cataract surgery, whether he is a diabetic or a non-diabetic, is does this lens change explain his visual loss? What is the status of retina in this patient? Does he have retinopathy, and if so, what is the grade of retinopathy? So depending on the status of his retina, does the retinopathy need any treatment before cataract surgery or soon after cataract surgery? And is the retinal change likely to affect the visual outcome of this patient after cataract surgery? So these are all the key questions you need to ask and answer before you proceed and plan your cataract surgery. So the first question, does this lens change account for loss of vision in this patient? I believe this is a question we have to ask in every patient that you are contemplating cataract surgery. And if the answer is yes, you are able to explain the visual loss is commensurate with the extent of cataract, then of course you are safe to proceed with the cataract surgery. If not, please hold your knife, don't operate. First see what is the cause for defective vision. If it's not the cataract, what is the cause? And find the cause and explain to the patient. If the cause is treatable, treat it. If the cause is not treatable, explain to the patient that the visual recovery may not be optimal because of this reason. Question number 2, does this patient have any DR changes? If no, otherwise the retina is normal, you can treat and manage the patient in the usual way. But if the patient has retinopathy, you need to study and see whether it needs any treatment. And in this context, I would like to tell you that any patient with any DR with cataract, it is better to do an OCT on these eyes. I feel every patient who needs cataract surgery probably should have an OCT. We will discuss this in a few minutes from now. This is a 70-year-old gentleman who came for a second opinion because he had been told to have cataract surgery. He did have nuclear sclerosis grade 2. The fundus showed hardly minimal diabetic retinopathy changes, but as a protocol, we did a OCT and it shows an edema in the eye, which hardly has very few diabetic retinopathy changes. And the other eye of the same patient also had this surprisingly, showing the diabetic macular edema. So OCT can help you, overcome, avoid these situations where you treat the patient and then end up with increasing macular edema. So why do we need to do an OCT? For several reasons. Number one, because of the hazy view of the cataract, you may not be able to assess the macula very well. Number two, OCT is way more sensitive in picking up the changes compared to your examination. So therefore, I would say a protocol of an OCT before cataract surgery in every patient, or at least in patients who have any diabetic retinopathy, is a very good tool that you should start in your practice. Question 3. What is the stage of diabetic retinopathy and does it need any intervention before cataract surgery? See, both diabetic macular edema and PDR, which are sight-threatening retinopathies, they need to be treated before you do cataract surgery. You need to optimize and stabilize them before you do cataract surgery, if possible. So we could give injections to reduce edema. We can do laser as much as possible before the cataract surgery. And then also remember, after the cataract surgery, we need to continue the treatment. Diabetic macular edema does not end with one injection. We all know that. And the laser also may be inadequate because of the cataract. You may need to continue that. Please remember that and continue that. This is a 69-year-old gentleman who came again for a second opinion cataract surgery. Vision was 618 with some amount of lens change. We did suspect some new vessels in this region on clinical examination on slit lamp biomicroscopy, and therefore we did a fluorescein angiography in this patient, which showed the presence of PDR in both the eyes, in fact, in this patient. And patient, before cataract surgery, he underwent PRP, and then only we did phaco IOL for this patient. So we need to pick up and treat retinopathy before cataract surgery, ideally. So in the presence of diabetic macular edema, I would present 3 scenarios. One, when there is no DME, you can proceed with cataract surgery, but monitor closely post-op. In these diabetic eyes, pseudophakic CME is much more common, so you need to identify and treat. DME may also progress. So these patients need a close follow-up. In a case like this, NPDR, OCT shows no macular edema, clinically no macular edema, can go ahead with cataract surgery. What to do when the patient has a very mild diabetic macular edema? This is an example of a cataract with a mild DME. The OCT shows very few cystoid changes here. The foveal contour is normal. There is no thickening of the retina. So we made a diagnosis of a very mild DME and we proceeded with cataract surgery. Pre-op vision was 6/24 and post-op vision was 6/9. We've been following up this patient and there is a post-op photograph and DME has not really increased significantly and patient is maintaining good vision. So scenario 2, when you cataract with DME, with center involving DME. So we have 3 options. 1, treat DME before cataract surgery. So this I would like to do when the diabetic macular edema is moderate to severe, it is better to treat, and if the cataract is not that much, we would like to do this as the first step. Treat DME after cataract surgery. If the cataract is quite moderately advanced and it's difficult to see the fundus and evaluate well, you can actually do cataract surgery first and then treat the DME. Sometimes we do combine the two, treatment of DME and cataract. So here is a patient, example, vision is 6/60, there is cataract. He was having macular edema, as you can see here. The vision is 6/18, then cataract surgery. He was given anti-VEGF first. You see that the edema has decreased after the anti-VEGF, and then the cataract surgery was done. Patient vision improved to 6/12 with resolution of macular edema. So this, you can do the treatment before cataract surgery. On the other hand, this is an example of a patient who had cataract and DME, underwent cataract surgery. He did have some moderate macular edema preoperatively, which progressed and the vision dropped to 6/60. And you can see that the macular edema has increased here. And then after the cataract surgery, we treated with 3 intravitreal injections. It needed 3 intravitreal injections and then the edema subsided. So we can do both ways depending on the extent of cataract. And this is an example, another problem that we face. Patient was operated elsewhere. He came with a drop in vision, 4 weeks post-operatively. Vision was 6/12. Asteroid bodies were present, which did not allow us good examination. There was a CME, and we thought it was a pseudophakic CME, and we treated with topical steroids, but the response was not good. So we were not sure whether there is a DME component. A fluorescein angiography showed us that this is a pseudophakic CME with leakage around the perifoveal capillaries and the disc edema also. Patient was treated with steroids. So distinction between DME and pseudophakic CME is important because DME needs probably intravitreal injection. Pseudophakic CME can be treated with drops, steroid and NSAIDs, and sometimes even PST. So how do we distinguish? In a patient with DME, diabetic retinopathy changes are present, whereas in a pseudophakic CME may or may not be present. The features of diabetic retinopathy like hard exudates, microaneurysms, hemorrhages predominate in a DME, whereas these can be absent in a pseudophakic CME. Usually pseudophakic CME occurs 4 to 6 weeks post-operatively, and OCT shows predominantly cystoid changes on OCT, and FFA is confirmatory because in FFA in pseudophakic CME shows leakage from perifoveal capillaries and the disc. So it's important to distinguish between the two and treat appropriately. So when the cataract hinders the view and you can't really treat and assess the retinopathy, go ahead with cataract surgery. So this patient came with 3/60 vision. He underwent cataract surgery. We knew that he had some retinopathy and OCT showed some macular edema. But after the cataract surgery, we found that he also had NVE and central involving edema, and plan was left eye PRP at 3 sittings and focal laser. With that, the patient has settled down with 6/9 vision. You can see that the laser marks here, focal laser marks have been done because the edema was away from the fovea, we did not inject. So it's important to treat the patient soon after cataract surgery. We can even do laser 1 week post cataract surgery, with the 90D lens also. So sometimes we combine two. This patient was on a follow-up and was on treatment for diabetic macular edema for recurrent DME, and over a period of months he has developed a cataract. And in this patient we combined phaco IOL with an Ozurdex implant, and this is you can see that even in spite of the cataract, you can see the edema being present on OCT, which has resolved following surgery. So we can combine intravitreal injection with cataract surgery, but my preference is probably to treat before and then go ahead with cataract surgery. So if the patient has something like a macular scar, chronic DME, PDR, ischemia, which is going to limit the outcome and you cannot really treat, it is important to have a frank discussion with the patient and document in future. Also important to look for new vessels in the angle, new vessels on the iris, because this can be easily missed. So therefore a careful examination of the anterior segment in all these diabetic patients is important. So what type of IOL to be used? I don't think I'll go into details. Large optic, larger capsulorhexis, maybe a hydrophobic lens. Avoid multifocal lens if the patient has diabetic retinopathy. Meticulous cortical cleanup and frequent post-op checkup, and add NSAIDs topically. So finally, this is a flow chart that I will leave you with. Cataract in a patient, if the fundus is visible well, you are able to grade the retinopathy, no NPDR, no DME, you can do cataract surgery, but please keep the patient on follow-up for the diabetic retinopathy progression and treatment. If, however, the patient has significant DME or PDR, treat the patient with either laser or injections before you do cataract surgery, stabilize the posterior segment, and then do cataract surgery, for optimal results. If, however, the fundus is not visible very well, patient has, really hazy view, B scan is mandatory in this eye if you cannot see the fundus. Other eye also will give you a clue as to the stage of retinopathy in this particular eye. If there is no RD, no vitreous hemorrhage, you can proceed with cataract surgery, but again, immediate evaluation of the posterior segment within the first few days is important to plan the treatment. And if on the other hand, a B scan shows a coexistent significant posterior segment pathology in the form of a vitreous hemorrhage or a TRD, then better to do a phaco-vitrectomy in these patients rather than doing a cataract surgery and seeing that the patient does not have any improvement in vision. Better to plan for a combined surgery. So in conclusion, cataract and DR can coexist. It's important to recognize and evaluate each of them independently and manage them properly. I believe that OCT is a very important tool that has to be used in this scenario to tell us what is wrong with the patient and how we manage and how the patient is responding to intravitreal injections, etc. So with this proper management, we can definitely expect optimal outcomes in this group of patients, but with rigorous management. So therefore, I urge you to have your own protocols to avoid unsatisfactory outcome and have the optimal outcome in this group of patients. Thank you very much for your patient hearing. I'm sorry if I have overshot my time. Thank you very much.
Yes, sir. Thank you, sir. I think now we have a brief an award ceremony and a felicitation function. And we'll just break into this session for 3 minutes. Our founder chairman, Padma Shri Dr. M.M. Joshi has come, and we request him to kindly come onto the stage to give the
lights on, please.
Felicitation to all the guest faculty who have come from far and wide. And this program is only possible because of the commitment and the love and affection of the guest faculty who come, travel, leave their busy schedule and still exchange knowledge. So we are very thankful to them. As we call names, we request them to kindly come onto the stage and receive the memento as a token of love and affection from Dr. M.M. Joshi. Dr. Abhishek Baudekar.
Yeah, request him to come. So first we would like to honor our guest faculty who has come all the way from Delhi, Dr. Manisha Agarwal, Head of Vitreoretina Services and Clinical Research Services from Shroff Charity Hospital. She completed her Vitreoretina Fellowship from Shankar Nethalaya, Chennai, has more than 100 peer-reviewed publications, 7 book chapters, Secretary of UVIT Society of India and Secretary of Vitreoretina Society of India. So I now welcome Dr. Manisha Agarwal to please come up on the dais. Can we have the award, please?
Thank you.
Thank you, madam. Thank you so much. Now I request our another guest faculty, Dr. Harshul Tak. Dr. Harshul Tak, are you there? Dr. Harshul Tak is the director of Rawat Eye and Phaco Surgical Center from Jaipur, ARC member, Central Zone AIOS, Chairman Scientific Committee, Rajasthan Ophthalmic Society, Executive member of IIRSI and the Governing Council member of ISCARIS. Dr. Harshul Tak's award, please.
Dr. Harshul also enthralled us yesterday with his fine singing skills, not just the surgical skills in the OT as well as his scientific deliberations. He is a full package. Thank you very much for Harshul for again making it here.
Thank you so much. And I must tell that this is one of the best conference in India and we always look forward to come to Hubli. Thank you so much. Thanks for your blessings.
Thank you, Dr. Harshul. And next we have Dr. Cyrus Mehta. Dr. Cyrus Mehta is he doesn't need any much introduction. The king of Mumbai, son of a veteran ophthalmologist, Dr. K.K. Mehta, who is a cataract and refractive and glaucoma surgeon with an eye on future. So I would like to, MM Joshi Eye Institute takes pride in honoring Dr. Cyrus Mehta today. Thank you.
Thank you, Cyrus. Keep coming.
We have another guest faculty, Dr. Ameya Kulkarni. Dr. Ameya Kulkarni is a consultant ophthalmologist and refractive surgeon as Anil Kulkarni Eye Hospital, Miraj, Ameya Lasers, Kulkarni Memorial Eye Care Center, Atharva Netralaya and Research, Pune. So he has special interest in cataract and refractive surgery, community ophthalmology and trauma care. So I'd like to take the opportunity to honor Dr. Ameya Kulkarni as our guest faculty.
Thank you, Dr. Amay.
Thank you. Now I would like to call upon our dynamic chairman, scientific committee of Karnataka Ophthalmic Society, who is none other than Dr. Chaitra Jaidev, head of Vitreoretina Services, PhD from Maastricht University, Healthcare Leadership Program from Harvard Medical School in 2019, over 130 PubMed Index journals, Joint Secretary of AIOS and VRSI, and presently serving as the Scientific Chair of Karnataka Ophthalmic Society. It takes pride to honor our own Dr. Chaitra Jaidev. Thank you very much for coming.
Thank you, Dr. Chaitra.
I would next like to call upon Dr. Deepak Megur. Dr. Deepak Megur doesn't need any introduction. A man of pearls, of wisdom and the best videos. And I think he should start something like a YouTube, his own tube. That is Megur Tube. Because he is overpassing YouTube as well.
Dr. Deepak Megur is the son of Dr. Umesh Megur, who is the first postgraduate student of Dr. M.M. Joshi. So this is the second generation.
So you can see here the awards. C.S. Reshmi Overall Best Video Award, Best Paper for the Cataract, Best Free Paper, O. Gopal Krishna Young Ophthalmologist Award, M.M. Joshi Overall Best Paper Award and Best Video Glaucoma Society of India Award.
I think he has been banned from all the competitions from now.
That's why we are not keeping any more competition involving him in Karnataka Ophthalmic Society. So we have named a video award in his name itself so that he cannot compete for that award. I would next like to call upon another a very jovial, down-to-earth, ever smiling Dr. HMR. See, he gets up already. He knows it is him. HMR has not given any introduction or biodata because he says biodata in Kannadalli biodata anta. Adike Dr. KP, I think is the best man to introduce Dr. HMR.
See, वो मेरा पीछा नहीं छूटता. In MBBS he followed me, in MD he followed me, even in Karnataka practice he is following me. Okay, ಬೆನ್ನು ಬಿಡದ ಬೇತಾಳ.
A prolific surgeon, a pan-ophthalmologist. Thank you, Dr. HMR sir. We have Dr. Sachin Mahuli is here. Dr. Sachin Mahuli. We have Dr. Abhijit Kakandki, Dr. Abhijit, Dr. Shivaji and Dr. Sushil.
Yeah, Dr. Shivaji Padmuki.
Dr. Shivaji Padmuki.
An excellent surgeon practicing in Ilkal. He is one of the finest cataract surgeons and his videos are very, very, illuminating. Actually, they got a lot of teaching qualities. Even Abhijit also. Dr. Abhijit They both are practicing in Ilkal. I still remember Dr. Shivaji winning the first prize in the PG quiz. We used to have PG quiz in iFest earlier, and he was the recipient of that.
Dr. Paras?
Student of MM Joshi Institute. I learned lot from this institute. I still consider the student.
Thank you. Abhijit. Yeah. Thank you.
We had excellent deliberations yesterday, chaired and moderated by many faculties. To name a few, we have Dr. Manjunath BA here, Dr. Manjunath BA, Dr. Vishwanath Reddy, Dr. Rajshekar Dyaberi, Dr. Rekha Mudol, Dr. Vinay Dastikop. Yeah, Dr. Manjunath, please come up on the dais.
Dr. Manjunath trained his Vitreoretina, both secondary DNB and his Vitreoretina fellowship in MM Joshi Eye Institute. Still continues to be one of our favorites.
Thank you, Dr. Manju. Vishwanath Reddy. Dr. Vishwanath Reddy is not there.
Dr. Rekha.
Dr.
Please.
Rekha Mudol, madam, please come up on the dais. She is now the present head of the Department of Ophthalmology at BLD Medical College. Thank you, Rekha madam, for gracing the occasion. We have Dr. Sudhakar sir, Dr. Sudhakar Joshi, Dr. Manjunath BH, Dr. Girish Masurkar, Dr. Savita Kanakpur, Dr. Lakshman Dasar, Dr. Vijay Nagaraj,
Dr. Sudhakar, please step in. Dr. Sudhakar.
Dr. Sudhakar sir is a very eminent personality from Bellary, and his son Madan is now taking over him. He's been a fantastic surgeon during his fellowship days, and I'm sure that he's doing nice surgeries and bringing more laurels to his father.
Thank you, sir.
We have the head of the department from Karnataka Medical College, KIMS, Karnataka Institute of Medical Sciences, Dr. Savita Kanakpur, madam. Dr. Vijay Nagaraj is there. I now call upon another eminent surgeon from Bagalkot, Dr. Lakshman Dasar. Dr. Lakshman sir, please come on the dais. MM Joshi Eye Institute takes pride in inviting the other moderators, chairperson, our own Dr. Hanumantappa. Dr. Hanumantappa sir, please come on the dais. We have Dr. Shankar Gowda Patil.
He is the alumnus of MMJOSHI Eye Institute long back 20 years ago, and he is one of the first batch of DNB students of MMJOSHI Eye Institute, and he's been a very successful practitioner at Gangavati.
Dr. Milind Galgali. Dr. Satish Hallikeri. We have our president, of Hubli Dharwad Ophthalmic Association, Dr. Shankar Goda Patil sir. Dr. Milind Galgali, past Dynamic Secretary of Hubli Dharwad Ophthalmic Association. Dr. Satish Hallikeri, Treasurer of Hubli Dharwad Ophthalmic Association. I also would like to invite Dr. Saurabh Shah, Dr. Vinay Sultanpur, Dr. Vijay Sajjanar, and Dr. Sanjeev Kulkarni. Dr. Saurabh Shah is our own alumni, a very fantastic vitreoretinal surgeon from Gulbarga.
Thank you, Saurav.
Another nice person, a wonderful human being, Dr. Vijay Sajjanar, great surgeon from Gadag.
Dr. Sanjeev Kulkarni.
Our own man, Dr. Sanjeev Kulkarni, who is the director of MM Joshi Eye Institute, Dharwad. I welcome you, sir.
Yes, sir.
So, I'm sorry to interrupt you all. In another few minutes, we should start the scientific session. Before that, we all know that the trade participation has been very, very important in conducting any events, whether it's a city level event or a state level event or a national level event. So the trade has always been the backbone in conducting many of such conferences, and what we see today, the 3D Live, I would like to give a sincere thanks to all my trade colleagues who have done a wonderful job, who have been a part of our curriculum, who have supported us wholeheartedly. So each and every one of you I would like to thank. Few industry trailblazer awards. The first goes to Alcon. We have Mr. Amar Vyas. Mr. Amar Vyas from Alcon. Okay, Rajesh, you can come and collect it on his behalf. Venkat, I'd like to call upon the Alcon team to please come up on the dais. A 70-year-old company founded by Fort Worth by Robert Alexander and William Connor. Legacy of Alcon, the advances in the eye care for eye-related diseases, high quality, innovative products, and I don't think they need any introduction because they are definitely the leaders in the producing the ophthalmic equipments and the ophthalmic products. And Guru sir wants to add a word that they are ruling the market in the world.
I think it's very important to understand that this is a synergy between the trade and the practitioners. So unless they have products, unless the patients are going to be the final beneficiaries. So we take great pleasure in recognizing their effort and contribution to the eye care. Hello. I think these are all very familiar faces to you, both in surgical as well as in all the other aspects of the Alcon eye care. Rajesh. I think we need to clap for Alcon for their products and the kind of services they deliver to all of us, be it machines, be it IOLs, be it the other products.
So, and all these 3D shows have been successful. I would like to again contribute the part of it to Alcon. They were yesterday, I think day before yesterday, they were here till 2 o'clock to check whether the transmission is going out well or not. I think they have done a wonderful job. Thank you very much, Team Alcon. The next Industry Trailblazer Award goes to Team Microvision. I would like to call upon Mr. Ashok, the President of Microvision, to please come up on the dais.
So
Microlabs Limited is the makers of Dolo 650. Who doesn't know Dolo now? Even a common man, everybody knows Dolo. Not Polo, but Dolo. So Microvision's manufacturing units have been certified by US FDA, UK, is a recipient of IDMA Quality Excellence Award, guided and motivated by its R&D experience, has seen its success in developing different product portfolios, and they have therapeutic specialties in more than 60 countries across globe. So I request Team Microvision to please come up on the dais.
They all come, yeah. So they are called micro, but they are the real macro people in terms of their contribution to healthcare, and they have been always generous enough to support all
Team
the
Micro,
events.
please come up on the dais.
A very friendly bunch of people helping us in delivering our services to the patients. Microlabs.
Thank you. The next Industry Trailblazer Award goes to Entod. Team Entod. On behalf of Nikhil, whose sister he has delivered from UK, so he sent me a message that he has flown to UK. So I request Rakesh Yadav and Niranjan from the team Entod to please receive the honor on their behalf. Thank you very much. And I am really sorry once again for coming in the way of the scientific deliberations. Vinay Sultanpur.
Dr. Vinay Sultanpur, yeah. He is our own man, and who actually got trained at MMU Institute, has contributed for 10 years of very fruitful, practice.
Thank you. Thank you so much.
I think with this we continue with the scientific session. I hand over the responsibility to the chairpersons. I think now it's time to call Dr. H.M. Ravindranath, who has already been introduced, to his talk. Yeah. Till he comes, you can probably comment on the previous talk.
Yes, till Dr. HMR pulls up his presentation, just a quick discussion on Dr. Muralidhar's talk. NSM, sir. So we're just discussing, Dr. Muralidhar? So we're just discussing a couple of points from your presentation. So I think one common dilemma that everybody has when they're treating patients with cataract and diabetic retinopathy is whether to handle the diabetic macular edema before the surgery, during the surgery, or after, especially when we're planning intravitreal pharmacotherapy. So just a couple of pointers on how to go about it, whether we need to treat them pre or during surgeries.
Yeah, that's, I think I briefly touched upon that. Because of the paucity of time, we can't go into the details. Of course, you have to individualize each treatment. You cannot draw a general rule and apply it to everyone. My preference is to, as a retinal surgeon, my preference is to stabilize the retina first and then do the cataract surgery. We all know that we want to do the cataract surgery before somebody else can lay the hands on the cataract. But please try and treat and get the retina stable before cataract surgery would be my first line of approach. Now, having said that, if the cataract is predominantly the cause for decreased vision, then it makes sense to do the cataract first and then proceed with treating the diabetic macular edema. So if the cataract is mild and DME is predominant, treat the DME first and then plan the cataract surgery. If the cataract is really, causing the more amount of loss of vision, I would do the cataract and then proceed with managing this DME.
Any major issues with combining pharmacotherapy along with the cataract surgeries at the same sitting?
It's a purely a personal thing that I am extremely conservative when it comes to a patient. We have two things. One is cataract surgery, which can cause a risk of endophthalmitis. Other one is an intravitreal injection, which again has a risk of endophthalmitis. Somehow my conservative mindset does not allow me to do two things to the same eye and increase the chances of endophthalmitis. So that is one. Second, all cataract surgeons may not be comfortable in giving intravitreal injection at the end of their cataract surgery. If you are very comfortable, you are confident, maybe you can. But from a conservative mindset that I come from, I would like to schedule the injection a little later or a little before. How does it matter? Patient, can come back again to the theater after 15 days or a month after cataract surgery or 15 days before cataract surgery. It doesn't really make a difference to the patient. So saying that it's very convenient for the patient, I feel is not such a big factor. So I'm very conservative, therefore I don't like to combine the two. Yeah. And especially if you are giving Ozurdex and if you have an intraoperative complication like a PC rent, then Ozurdex is contraindicated in these eyes. And again, you'll have to abandon the Ozurdex and then give it some time later or change to intravitreal injection. So these all change of plan might be required. So if you're conservative, I would say split the two.
So I think those are good and strong points with regard to intravitreal pharmacotherapy. A week before or even 10 days before, bring down the inflammation and then plan the cataract surgery does work well. But in very, very rare cases where probably the patient is coming from out of town, they're not able to travel, in a short gap, then maybe with a lot of trepidation you can give it at the same time. Thank you so much, sir. I think we'll go over to the next talk by Dr. HMR. Again, like he doesn't like too many introductions, I'm not going to go into that. Over to you, sir, directly. He'll be talking to us on how to make DCR surgery simple.
Thank you.
Okay.
DCR is actually one of the gratifying surgeries, but with the increased glamour in cataract surgery, somehow DCR has lost its importance, and nowadays youngsters are hesitant to take up the surgery. But definitely I said this is one of the most gratifying surgeries in ophthalmology, and it's quite simple also. The goal is to make an anastomosis of the lacrimal sac and nasal cavity, that is nasal mucosa, the middle meatus, which functions for lifelong. This is the goal of DCR surgery. The key factors in doing DCRs, you should have a calm patient and a calm surgeon. You can use anxiolytic on patient if patient seems anxious. And analgesia is important because it's not like cataract surgery. Patient complains of pain, that may disturb you, the surgical course. And one of the common reasons why we don't take up DCR surgery is because of the bleeding. If you think bleeding is more with DCR, please go to labor room once or twice and come back and start your DCRs, and you will feel DCR is less bleeding than labor. So it's not because you are used to clear corneal phacofoldables, you think bleeding is more with DCR. Is not so, unless patient is on anticoagulants, which you should take care of. And knowledge of anatomical variations. It's not like you will have nasolacrimal duct and other lacrimal anatomy you should know. And bony opening of adequate size at appropriate place is more important. One of the reasons of failures is you do a bony opening at a higher place or a small bony opening. And good nasal and lacrimal flaps are key to have a good successful outcome after surgery. This I'll just run through a video. The incision can be at the medial or lateral to the angular vein, proposed angular vein. So it depends on how you are practicing this thing. I usually put it at the medial side so that I can retract the angular vein if it starts bleeding from my cat's paw. So the blunt dissection is done to open the orbicularis oculi muscle, split it, and this is the most useful instrument is gauze for me. I dissect everything with gauze piece so that it doesn't harm any vessels there. So identify and separate the periosteum from the lacrimal crest, and what you're seeing is a lacrimal fossa. This is the most important place for us. So here, usually I don't use any bare instrument, sharp instruments there, because sometimes nasal, like this lacrimal sac is very thin. So if you put any sharp instrument there, it can break and disturb your surgery. So that's why better not to use any sharp instruments naked there. So use, cover it with gauze and dissect. The first bony opening, I also make with that gauze piece only. You put pressure over there and it automatically opens up. You don't have to use any instrument for that because it is thinnest part there, lamina papyracea. So if you put force with the gauze, it will open. Once you open, take the bone punch. I think every instrument has changed everywhere, but this bone punch has not changed in DCR. This has been there for more than 100 years and still going strong. So this initially you can start with a little smaller bone punch, then go to the small size 2. This is the commonest size I use is 2. You should make an adequate bony opening size here. You should not make a small or very big. The boundaries are the posterior limit, you have broken that bone. Anterior limit you can, because you cannot insinuate your bone punch anterior to the, there is adherence of the nasal mucosa to the bone. So inferiorly, the frontal portions of maxilla should be cut. Superiorly, around 2 to 3 millimeters above the proposed site of medial Pepper ligament. And once everything is done, this is the opening of lacrimal sac. You adequately expose it and open it. This is very important because one of the common reasons of failed DCR is you don't open the lacrimal sac correctly. So once you open the lacrimal, you should get the good flaps out here. And once you get good flap, you can confirm that you have opened the lacrimal sac by passing Bowman's probe there in the lower canaliculus or upper canal, depends on your choice. Once you make a sac flap, this is a nasal mucosal flap. Again, nasal mucosal flap as big as possible you should take. Once, if it is bigger, you can trim it off. If it is small, you cannot increase it. So you can take a very adequate nasal mucosal flap. So once it is done, you can check whether you have entered correct cavity. You can take the nasal pack and see and push it back. So to confirm that you have entered at the right place. So once you feel it is bigger, the flaps, because you should not take a very long flaps and suture, because if they become loose, they'll fall backwards and may obstruct the bony opening, or even it may obstruct the common canalicular opening. So once both the flaps are done, suturing is done by 6O Vicryl. This only thing is you should make sure that they are taut, they are not sagging backwards, these flaps. So once this is done, you can close the muzzle in interrupted 6-0 Vicryl and skin with 6-0 silk. So this is what DCR surgery is all about. Only thing is, we are worried of bleeding. You take care that the patient is not on anticoagulants, and retractors and sutures will do other work. Second, if patient is anxious, use anxiolytic and make a bony opening at appropriate size at appropriate place. This will help in 95% of success in DCR is achieved by this method. Thank you.
Thank you, sir. So we'll move over to our next talk, which is going to be delivered by Dr. Ameya Kulkarni on PXF with phacodonesis.
Yeah, there's some time constraint, so I'll be rushing through my slides. At the outset, I would like to thank Dr. KP sir and Dr. Srinivas for this opportunity. I have been coming to MM Joshi as a resident and being mesmerized by Dr. KP's lectures, and then to be standing here is a great honor. Thank you for that. We'll just go through this. I'm not going to the etiopathogenesis. Everybody knows what a PXF is. The clinical manifestations, it produces a rigid non-dilating pupil, there are transillumination defects, Sampolysis line and deposits on the cornea, which reduce the endothelial cell count. There are weakened zonular apparatus, which could be a risk of subluxated cataracts. There's exfoliative material. It's called the target zone. Everybody knows this. Now, what are the challenges in cataract surgery with pseudoexfoliation? First and foremost, there's a rigid non-dilating pupil. There might be zonular weakness, zonular dialysis. There can be low endothelial cell count. Cataract with phacodonesis, subluxated cataract with angle closure, and cataract with pre-existing pseudoexfoliative open-angle glaucoma. Basically, with PXF, it's very hard to predict what would happen intraoperatively, even if you diagnose PXF preoperatively. If the anterior chamber depth is less than 2.5 millimeters centrally, it is an indication of zonular instability, which may pose a higher risk for intraoperative complications. Now we'll go to the first case. I'm going to show you a series of cases wherein this is a case with pseudoexfoliation and it's pretty well dilated pupil. And you'll see the first thing that I'm mindful of is whether there are any folds in the anterior capsule as I'm doing my CCC. You can see my CCC goes off well, so I know that there is stability of the bag. We'll not have much problems here. So this becomes a CCC, and while chopping, you have to be careful not to do huge movements in the AC because the bag can give way. This is a vertical chopping being done, and during chopping, you'll see that everything is not well. You will not have the same kind of counter traction that the bag generally provides you with in these cases, because no matter what, there is some amount of zonular weakness present when you're dealing with PXF. Once you've cracked the nucleus, I generally tend to prolapse the piece of the nucleus in the AC if it's a PXF, because I don't want to transmit my forces to the bag, as we expect the zonules to have some weakness. This is wherein we take out the cortex. It has to be done tangentially to not stress out the zonules. So the entire focus here is to not put stress on the zonules while we are operating. And at the end of surgery, you'll see that I'm putting a CTR. Now, there is no indication that there is much zonular weakness, but still prophylactically, I would like to place a CTR in these cases and then put in a lens. This is another case wherein, This is a case where you'll see that as soon as I go in with the cystotome, there is movement of the bag, and then you'll see the folds that were there on the anterior capsule. That folds means I cannot share my way through the CCC, and there has to be tearing done of the anterior capsule, and very carefully with the help of microforceps. Here the goal is to complete a rhexis. It might not be circular always, it might not be central, but the goal is to complete the rhexis. Once that is done, this is a case wherein I had to put a CTR in during the nucleus removal, as it was not moving, the nucleus was not moving. Once you put in the CTR properly, you will see that everything starts moving well. And things go well once you've stabilized the bag with a CTR. This is a case, another case of, this is a completely subluxated cataract, you'll see, and this is where you require capsular tension devices to be used. I'm just putting a dispersive viscoelastic to dampen the vitreous there. The CCC has to be centered on the, it should not be centered on the limbus or the cornea, it has to be centered on the lens. After that, you have to do very gentle hydro dissection in these cases. And then I'm stabilizing the bag with capsular hooks. This needs to be done because only CTR or modified CTR cannot be put at this stage in the surgery. This is where I'm putting a ceremonies ring to stabilize the bag. You'll see the eyelet there. The eyelet is hooked with a suture and then it is put in the bag. And you have to position the eyelet in the area of zonular adhescence. And then you end up, this is the handshake technique being used. Yeah, this is my last slide. So I'm fixing the bag here. Once the bag is fixed, the cortex can be removed and the lens placed. So this is what CTR, MCTR, and CTS. So take home is preoperative diagnosis and appropriate counseling is absolutely essential in a case of PXF. You have to expect the unexpected and adapt intraoperatively. Thank you.
Thank you, Dr. May Kulkarni. I think as our chief guest has arrived, we are going to start the inaugural ceremony immediately, and we'll continue with the scientific sessions after the inauguration. Can we have the lights on of the... and I hand over the mic to the masters of the ceremony, Dr. Deepti Joshi and Dr. Apurva Ayachit.
Stage light on, please.
Good afternoon, everyone. So we now request our Honorable Union Minister Prahlad Joshi sir, MM Joshi sir, SB Patil sir, Shankar Gowda Patil sir, Amulya Sahu sir, Debashish sir, Kaushik Murli sir, Santosh Honnavar sir, NS Murlidhar sir, and the host team, AS Guru Prasad sir, Krishna Prasad sir, Satyamurthy sir, Srinivas Joshi, and Abhishek Bavdekar to please grace the dais. Hello everyone. 3D is the way we experience life and 3D is the way we experienced iFest. On behalf of MM Joshi Eye Institute, we welcome you to one of its kind revolutionary conference which was experienced entirely in 3D for the past 2 days, the iFest 3D Live Wire 3.0. We now request Dr. Priya Shah to invoke the blessings of Almighty.
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि गणनायकाय गणदेवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशाणाय धीमहि गुणातीताय गुणाधीताय गुणप्रतिष्ठाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, Priya. So now I request Dr. K.V. Satyamurthy to welcome this august gathering and all the dignitaries.
Good morning, dignitaries on the dais, off the dais, and my dear friends. I hope I see you all in the best of health and high spirits. Gripped by pandemic, we were all restricted to the four walls. The words fall short to express our jubilation on having you all here after a hiatus of almost 3 years. Last iFest was in 2019, September. I hope you all had a blast yesterday, academic feast, and have gained insight from both the surgical demonstrations and intellectually stimulating scientific deliberations till now, and it will go on. On behalf of MM Joshi group of institutions, I take the privilege to extend a warm welcome to our chief guest, Honorable Union Minister of Coal and Mines and Parliamentary Affairs, our beloved Shri Prasad Joshi ji. He has been our well-wisher and friend since a long time, even before his foray into politics. We welcome you, sir, to grace this august occasion. I extend a warm welcome to Dr. Debashis Bhattacharya, who is the Director, Disha Group of Eye Hospitals, Kolkata, and former President of AOS. Welcome you, sir. I welcome Dr. S.B. Patil, who is the President of Karnataka Ophthalmic Society. I welcome Dr. N.S. Muralidhar, who is President of VRSI. I welcome Dr. Santosh Honavar, who is editor of Indian Journal of Ophthalmology. I welcome Dr. Shankar Gowda Patil, who is president of HD of OA, Hubli Dharwad Ophthalmic Society. And of course, I welcome our former chairman, Dr. M.M. Joshi, to this function. I welcome Dr. R.S. Mudol, who is the Vice Chancellor of BLDE University. Warm welcome to you, sir. I extend a warm welcome to Dr. Kaushik Murli, who is a recipient of Young Achievers Award. I welcome all the faculty, both the national and the state, for enlightening us and who are going to enlighten us in the scientific deliberations. I welcome all the delegates to this scientific extravaganza. I recognize the presence of Sri Vikamshi Tilak, is there? Yes. I extend a warm welcome to all the trade delegates and the recipients of Industry Trailblazer Award. I welcome all the media, both print and electronic, to this function. I welcome one and all. Thank you very much.
Asatoma Sadgamaya Tamasoma Jyotirgamaya. We now request our dignitaries on the dais to light the lamp as a tribute to Mother Saraswati, goddess of knowledge. I now request Dr. Srinivas Joshi to introduce our chief guest today, Union Minister for Parliamentary Affairs, Coal and Mines, Government of India, Shri Prahlad Joshi. Sir.
Prahlad Joshi sir doesn't need much introduction, but still, since we have various faculty across India, sir, I would just like them to give a glimpse about what our Honorable Union Minister is doing. It's a household name in his parliamentary constituency because of the dedication to the cause of poor, downtrodden, farmer welfare and his concern towards the region as well as the national issues. He has soon cropped up and become a most popular leader in our government of India. Joshi sir, he has been the member of the Parliament of Dharwad constituency for 4 consecutive times, and he has fought for a number of causes, some of which are the upgradation of Hubli railway station, which is going to be the longest railway station in the world. And all thanks to the efforts of Shri Prahlad Joshi sir for that. And also the crop insurance scheme, development of Hubli Dharwad city and upgrading Hubli Airport to the international standards. So these are the very few achievements which I have been telling about. But the main comes here is he has brought in a lot of changes in the mega mineral reforms and most importantly, removal of Article 370 from Jammu and Kashmir and reorganization of the State and Citizenship Amendment Act in 2019. So Joshi sir has also been a member of Delegation of Empowerment for Women and has addressed UN General Assembly in that capacity. So with his NGO, we have been conducting various eye camps. Almost every month he has been conducting various eye camps and he has been a strong support for many of our programs which are being conducted by Joshi Eye Institute. Apart from that, Joshi sir also enjoys Indian classical music and other forms of art. He plays cricket, badminton, and he is a voracious reader. With these few words, I welcome our Honorable Union Minister, who has been a very chosen man or the right-hand man of our Honorable Prime Minister, Shri Prahlad Joshi sir, to this august gathering. Thank you, sir.
Welcome, sir. We now request Dr. A.S. Guru Prasad sir to introduce our Joshi Oration awardee, Dr. Debashish Bhattacharya sir.
So for the last 4 years, it has been customary to identify, recognize and honor important achievers in the All India Ophthalmic Society and honor them in our annual CME gatherings. Dr. Joshi Oration Award is one of them. And this year, we have chosen a very, very befitting person, Dr. Debashish Bhattacharya. I want it here, okay. So, I have specially chosen myself to do this honor of introducing Dr. Debashish Bhattacharya, founder chairman of Disha Eye Hospitals in West Bengal, the largest eye care hospitals with services encompassing all subspecialties of ophthalmology, performing more than 1 lakh surgeries and examining 12 lakh patients. Okay, yes. 12 lakh patients yearly across its 17 hospitals with over 100 full-time consultants and 1,200 staff. He has served at the national level as the president of the All India Ophthalmic Society and has previously served as editor proceedings All India Ophthalmic Society for 2 terms, that is in 2005 and 2010, and also as chairman of the ethics committee 2010-11, where I was associated with him as a member. Next slide. Apart from his various areas of interest, cataract surgery and eye care hospitals management seem to be the most prominent. As a surgeon and ophthalmologist, he is greatly respected as a teacher of small incision cataract surgery and phacoemulsification in India and abroad. He has presented innumerable instruction courses, scientific papers, posters and video films on practice management, besides small incision cataract surgery in state, zonal, national and international conferences as well. Grounded as he is, he has a clear understanding of the basic requirement of every practitioner. His basic instruction courses on learning small incision cataract surgery and phaco have been very popular learning tools for every beginner and will continue to remain so for a long time to come. He has several publications in Indian and international index journals, which is his contribution to the world literature, widely respected for his affirmed philosophy of affordable quality eye care for everyone. He is also one of the prime movers of the group practice model in Indian healthcare. So while Disha is famed for its mission to provide affordable and quality eye care to all, Dr. Bhattacharya and his team makes every effort to indulge in research and innovate to make Western technology affordable for all sections of society. With this, I introduce Dr. Debashish Bhattacharya.
Thank you, sir, and thank you, Debashish sir, for gracefully accepting our invitation and the award. Now, I request Dr. Krishna Prasad to introduce our Lifetime Achievement Awardee, Dr. Amulya Sahu.
Right? Hello. So, Dr. Amulya Sahu, name suggests he is priceless. He is the founder and the chairman of the Sahu Eye Group Hospitals and the founder chairman of the most famed ISM SICS, which has made so much inroads into creating a knowledge about SICS to the world. He is also the secretary of Bombay of BOA and the former vice president of Bombay Ophthalmic Association and the president of BOA again, and he was the chief instructor to the multiple ISM SICS courses in the AOS that has been held, and it has really taken the center stage now. And he is the international master gold medal by the BOA in 2003, and he has of course been a very popular and a famous name and the face in all our national and international fora. And he has published a book on lens-based refractive surgery, and is an instructor at various international fora, multiple instruction courses, to name a few, ASCRS, as well as Indonesia, China, Philippines, Japan. He is now a global figure popularizing SICS to the world. And of course, he is the chairman of the World Conference, the first ever World Conference on MSICS, making India proud, and he is continuing to do the great work now. I think Dr. Amulya Sahu is probably the most well-known face in the fora which discusses SICS, a fabulous surgical technique which is probably very relevant to countries like India, especially in the community setting. Just like we popularize all other cataract surgery techniques, SICS still continues to be a very relevant form of cataract surgery, and Dr. Sahu has been instrumental in making this probably known to the world and to reclaim the fame of India back on the global scenario. I think he has made India proud and all of Indians proud. Thank you very much, Dr. Sahu, for making all of us proud that we are Indians and we are popularizing it to the world level. Thank you so much.
Thank you, Krishna Prasad sir, and thank you, Amulya Sahu sir. We now request Srinivas Joshi sir to introduce our Young Achiever Awardee, Dr. Kaushik Murli sir.
Dr. Kaushik Murli is a pediatric ophthalmologist and president, medical administration at the famous Shankara Eye Foundation, India. He completed his DNB from Shankara Eye Hospital, Coimbatore, and his fellowship in pediatric ophthalmology from Shankar Nethralaya, Chennai. He then completed his INSEAD Senior Leadership Program for Executives and Strategic Management for Non-Profit at Harvard Business School. He has collaborated with Harvard School of Public Health, University of Bonn, London School of Hygiene and Tropical Health, IBM, Microsoft, and several other organizations on various health research projects. So he's also the member of Scientific Committee of Vision 2020.
Thank you. So now we would like to introduce our Exemplary Service Awardee, Dr. R.S. Mudhol. Sir, please come up to the stage. It is really enlightening to know his journey. Dr. R.S. Mudhol is a well-known ENT surgeon and a very popular teacher. He completed his MBBS and MS ENT from KMC Hubli and has experience of over 35 years in various capabilities as professor, HOD, vice principal, medical superintendent, director, hospital administration, and dean faculty of medicine. He has over 52 publications to his credit, published in national and international journals with a high impact factor, and he is a well-known peer reviewer of reputed ENT journals. He received the fellowship in otology from New York University and Minnesota University, USA, Recently, he was awarded an honorary fellow by Karnataka Science and Technology Academy, DST, Government of Karnataka in November 2021. To his credit are many academic collaborations with national and international institutions like COS, Ear Clinic, Béziers, France, Vijay ENT Care Hospital, Bangalore and Mimar Institute, Pune. He was an external expert member on the Board of Studies in various state universities. He is a member of the International Otology Network at France. All of the above accomplishments have earned him his present post of Vice Chancellor of BLD deemed to be university. We are indeed honored to have you, sir, and it was really enlightening to see your journey in the field of medicine and ENT. Thank you so much.
So now it's the time for a special award, the Synergy Award, which is being handed over to the team denizens, the host, the place, second host may be the place donor where we have been sitting, who have collaborated synergistically with Joshi Eye Institute in all our endeavors and in our conferences.
Arun
We are
Arun
ever
Saudati.
grateful to them. Team denizens and Arun Sabdati and team.
Okay, next award.
Okay, so
now it's our utmost pleasure to introduce the faculty and call upon them to receive their faculty awards. First, I call Dr. Santosh Honnavar, probably the most illustrious ophthalmology in India and an inspiration and guiding light to virtually all ophthalmologists in our fraternity. Thank you for being here, sir, and thank you for all that you do. Right.
next we have a couple, a young and dynamic couple who have been joined by science and ophthalmology, very closely associated with Joshi Eye Institute family, Dr. Satyajit Sinha sir and Dr. Pooja Sinha ma'am.
Thank you, sir and ma'am, for all your collaborations with us over the last several years. Thank you for making the trip all the way to Hubli. I call upon Dr. N.S. Murlidhar, our beloved NSM sir, senior vitreoretina surgeon, a pioneer in vitreoretina surgery in this part of India. And it's my distinct pleasure to say that he is a very accomplished singer as well. Thank you for coming here, sir, and thank you for being associated with us for the last 2-3 decades.
We now call upon our next faculty, Dr. Anurag Mishra sir, to please come upon and receive the honor. We now call upon our next awardee, the President of KOS, Dr. S.B. Patil, sir. We now request our Honorable Chief Guest, Shri Prahlad Joshi, sir, to please address the gathering. We have our Synergy Award winner, Team Denizens here. Arun Savdatti and team.
पद्मश्री डॉक्टर M.M. जोशी जी, डॉक्टर S.B. पाटिल, डॉक्टर कंची, डॉक्टर भट्टाचार्य जी, डॉक्टर अमूल्या साहू जी, डॉक्टर कौशिक मुरली जी, डॉक्टर R.S. मुधोल जी, संतोष फन्नावर, डॉक्टर कृष्ण प्रकाश, डॉक्टर सत्यमूर्ति, डॉक्टर श्रीनिवास जोशी, and all other dignitaries of the dais, on the dais. इसमें तो आप सब लोग एक्सपर्ट लोग बैठे हुए हैं, तो मुझे क्या बोलना है, मैं तो अवार्ड दिया, मेरा काम भी खत्म हो गया। तो फिर भी एज ए मैटर ऑफ फॉर्मेलिटी कुछ मैं 2-3 मिनट बोलना चाहता हूँ। एक तो प्रैक्टिकल सर्जरी आप देख रहे हैं, 2 दिन से कॉन्फ्रेंस चल रहा है। इट इज वन ऑफ द यूनिक कॉन्फ्रेंस where 300-400 people have physically joined and more than 600-700 people virtually they have joined. I think there is one of the big conference or the big unique event which is being organized by Dr. M.M. Joshi and hospital and his team. Dr. M.M. Joshi Padma Nayanalaya, Hubli, is one of the renowned institute of the ophthalmological science. It is the pride of the North Karnataka region. I have a long association with Dr. Joshi ji, M.M. Joshi ji, from the days of my college days. And even in college days, तब भी हम नेतागिरी करते थे, इसलिए बहुत लोगों को डॉक्टर जोशी जी के पास हम भेजते थे फ्री ट्रीटमेंट के लिए, क्योंकि हमारा नेतागिरी चलना है तो इन लोगों के पास हमको भेजना पड़ता है, लेकिन हम गरीब लोगों को चुन चुन के भेजते थे। तब से डॉक्टर जोशी साहब सभी को आशीर्वाद दिया है। शायद उसी के कारण मैं समझता हूँ कि जनरली जो इंस्टीट्यूट बड़ा होता है, नाम भी बड़ा होता है, इंस्टीट्यूट भी बड़ा होता है, कमाई भी बड़ा होता है, लेकिन टायर 2 सिटी में रहते हुए अगर दुनिया में कम से कम देश में इन दिस पार्ट ऑफ इंडिया अगर अच्छे नाम कमाया है तो डॉक्टर M.M. जोशी हॉस्पिटल का नाम हुआ है। और उनके सभी जो सन इन लॉ हो, बेटा हो, बेटिया हो, सब मिलके ये अस्पताल बहुत अच्छे ढंग से चला रहे हैं। जिन्होंने जोशी जी ने एक सर्विस के मोटो भी इसके रख के काम शुरू किया था, टू सर्व द पीपल। तो डॉक्टर जोशी जी को मैंने पूछा एक बार, जब मेरा क्षमता, मेरा एक NGO है, हम भी थोड़ा कुछ काम करते रहते हैं, वो NGO के थ्रू हम फ्री कैंप जब हम ऑर्गेनाइज करते थे, जैसे श्रीनिवास जी बता रहे थे, तब मैंने पूछा आपको इतने बड़ी मात्रा में आप फ्री कैंप सबके साथ सहयोग से, सभी एसोसिएशन जो इधर अच्छे एनजीओज है, उनके साथ एसोसिएट हुए, कितने बड़ी मात्रा में डेली करते हैं। पहले तो बहुत होता था, ये इसमें थोड़ा कम हो गया अभी कोरोना कालखंड में। तब उन्होंने मुझे एक बात बोला, जब मैं आया था इधर, मुझे ऐसे तो डॉक्टर जोशी जी बहुत गरीब परिवार से आते हैं, इधर के जो लोग हैं जिन्होंने मुझे दिया, इधर के जो समाज है, द सोसाइटी एज होल, व्हाट इट हैज प्रोवाइडेड टू मी, I am trying to return little back to the society. That's why I am organizing this camp. This is what Dr. Joshi used to tell me. तो ऐसे काम करते करते आज बहुत बड़ा इंस्टीट्यूट बन गया है। जब भी मैं जाता हूँ इनके इंस्टीट्यूट हॉस्पिटल के लिए, कम से कम 300-400 लोग बैठे रहते हैं और एक्सप्लॉयटेशन नहीं होता है इस अस्पताल में। ये सभी लोग मुझे आके बोलते हैं। कभी कभी क्या होता है, आजकल डॉक्टर लोग, बुरा मत मानिए, ज़रूरत है या नहीं है, जब हम कुछ के लिए, कुछ छोटा मोटा समस्या के लिए डॉक्टर के पास जाते हैं, सभी टेस्ट कराते हैं, सब कुछ कराते हैं, ज़रूरत है या नहीं है। एक्सप्लॉयटेशन जैसे सभी क्षेत्रों में हो रहा है, पॉलिटिकल क्षेत्र पकड़ के, तो ऐसे इधर भी हो रहा है। लेकिन डॉक्टर एम जोशी अस्पताल में कभी भी नहीं हुआ, ऐसे एक शिकायत भी मुझे नहीं मिला है। The flagship motto of Dr. M. Joshi Eye Institute and its branches across the northern part of Karnataka state is a strong community ophthalmology serving the rural poor. It has many vision centers at the selected location in North Karnataka. Today I am very glad to know that this institute, along with the eye care services, it is organizing many academic events by which it is imparting the ophthalmological know-how among the eye care medical fraternity. One such event is Eye Fest of today's national conference on eye surgeries with live demonstration of the complex eye operation to the ophthalmologist of the South and West India for the 15 years. It is really interesting to know that 35 faculties consisting of 350 ophthalmologists attending physically and 700 online. ಭಾರತ ದೇಶದ ಕುರುಡುತನ ತಡೆಗಟ್ಟುವುದರಲ್ಲಿ, some sentence I would like to talk in ಕನ್ನಡ. ಭಾರತ ಸರ್ಕಾರ ಭಾಳ 2015ರಿಂದ 2019ರವರೆಗೆ ನಾವೊಂದು ಸರ್ವೆಯನ್ನು ಕಂಡಕ್ಟ್ ಮಾಡಿದ್ವಿ. ಅವಾಯ್ಡಬಲ್ ಬ್ಲೈಂಡ್ನೆಸ್, even in that we had associated with Dr. Joshi Institute, and the lot of work has been done in this. India was the first in the world to launch the national program for the control of blindness in 1976, and the goal of reducing the blindness prevalence 0.03% by 2020. Our government, led by Shri Narendra Modi, is instrumental in conducting the National Blindness and Visual Impairment Survey 2015 to 2019. Its main objective is to provide the evidence about the present status of the blindness and visual impairment in India. The survey was planned by the Ministry of Health and Family Welfare. Dr. Harshavardhan did a very excellent job in this. Avoidable blindness, how to prevent, that was the main purpose of that. One of the reasons of blindness is cataract and what is that? Refractive error. That was the intention, that was the purpose of this survey. And Dr. M. Joshi Institute of Ophthalmology Science is in the forefront in the field of avoidable blindness and engaged in various activities, especially in rural areas. I profusely congratulate this institute for taking up this large-scale exercise by the charitable trust and helping the poor. I also congratulate this institute for organizing this unique conference by its charitable trust and helping the poor. I also congratulate the entire team which has worked from last few days, because the Shri Srinivas Joshi told me, I think, month back, means by that time the preparation was on, everybody has put their own effort. अंत में मैं इतना ही कहना चाहता हूँ, भगवद गीता में श्री कृष्ण पूरा भगवत गीता उपदेश करने के बाद उन्होंने श्री कृष्ण परमात्मा को विश्वरूप दर्शन करवाया। तब उन्होंने कहा, नातुमाम शक्यते दृष्टम मनेनैव स्वचक्षुषा दिव्यम ददामि ते चक्षु पश्वा में योग मैश्वरम। अर्थात इट मीन्स, अर्जुना, you cannot see my cosmic form with your physical eyes, therefore I give you divine vision to see the experience of Vishwarupa, विशेष चक्षु। श्री कृष्ण भगवान ने अर्जुन को दिया, लेकिन मैं ये कहना चाहता हूँ, लेकिन इधर जो हुआ है, those days of Arjuna was fortunate enough not only to see the physical or material form of the God in the form of Sri Krishna, but also blessed enough to see the cosmic form of the God in the form of Vishwarupa by Divya Chakchu bestowed upon him and got enlightened. Today I can personify Dr. M.M. Joshi and his committed team as Bhagwan Sri Krishna in giving thousands of physical eyes to the thousands of people, enabling them to see and experience this beautiful world created by the world. For many angle, it is one of the greatest of the human service to the mankind of this region by these thousands of free eye testing and surgery camps, which I was lucky enough to be part of that. अंत में मैं इतना ही कहना चाहता हूँ, तो डॉक्टर M.M. जोशी जी ने तो ब्लाइंडनेस के लिए जो है गरीब लोगों को मिली एक सेवा का, कभी कभी हम दृष्टि देते हैं, जो दृष्टि सबको रहता है, थोड़े कुछ लोगों के लिए भगवान का दया नहीं रहता है, उनके लिए दृष्टि नहीं रहता है, दे विल बी ब्लाइंड। बट दिशा देने का काम बहुत कम लोग करते हैं। द वेरी फ्यू पीपल गिव द दिशा, विजन। दैट विजन M.M. Joshi has given to his team. That's why today also this service is going on, and that's why many times I quote one example. One blind person went to interview, and the person that was in Union Public Service Commission, the person who was taking the interview, he said, "Are you blind?" He said, "I am not blind, my eyes are blind." So that is the reply, and means your eyes may be blind, but you cannot be blind. That is the vision Dr. Joshi has given to this institute and this part. I congratulate entire team and I wish this conference a great success. Thank you very much.
Thank you, sir, for those valuable words. We will try to keep up the promise and definitely we'll work hard to serve better for this part of Karnataka and areas beyond that. Thank you very much for your kind words. I now request our Honorable Chairman, Directors Dr. Guru Prasad sir, Dr. Satyamurthy sir and KP sir to please honor our Honorable Union Minister Shri Prahlad Joshi ji.
We now request Dr. Abhishek Pavdekar to propose vote of thanks.
At the onset, I thank our chief guest, Honorable Union Minister Prahlad Joshi Sarji, to have come over here and graced the occasion. I extend my thanks to all the awardees, dignitaries on the dais and off the dais, and all the delegates, the outstation and local Karnataka delegates who have made an effort to come over here and grace this event. I also thank our entire team of the MM Joshi Eye Institute, right from the doctors, the postgraduates and the fellows, and the staff and the office and the transport department for making this event a success. I also extend my thanks to the media, the staff of the Hotel Denisons, the audiovisual teams who have traveled all the way from Coimbatore, and the press for coming and gracing this event. And last but not the least, I would also extend my thanks to the patients because of whom we are able to learn and for whom this event makes it a better world to live in. Thank you.
So we profusely thank our chief guest, the Union Minister, Shri Prahlad Joshi ji, for gracing the occasion and having the inauguration done. So now we continue with the main business, the scientific program. I hand over the mic to the chairpersons, Dr. Chaitra, Dr. Amey and Dr. Hanmantappa. And it's Dr. Chaitra Jaidev's turn to present her. Get the chairs off. Chairs off. Chairs are blocking. You can introduce Dr.
It gives me great pleasure to introduce Dr. Chaitra to the gathering. Everybody knows Dr. Chaitra is the face of IGO for many years now. She's also the head of Vitro-Retina Services at Narayan Nethralaya. She's done her PhD from Maastricht University. She's a healthcare leadership program from Harvard Medical School in 2019. She has over 130 PubMed index articles and contributed chapters in internationally renowned textbooks. She is the Joint Secretary AIOS and VRSI. She is also the Scientific Chairman for the Karnataka Ophthalmic Society.
Thank you, Mayor, for the kind introduction. And thanks to MM Joshi sir and the entire team and the Institute for having me here. I've been coming now for the past couple of years and it's a pleasure to be back. Today I'll be speaking on the clinical perspectives of DME management. I think all of us, irrespective of what specialty we are in ophthalmology, do face challenges in treating DME because it's literally a lifelong disease that these patients with diabetic retinopathy have, and we have to constantly ensure that their central vision is maintained. I want to speak about this particularly because if you look at the extent of the disease, it's so much more when you see. Yeah. So if you look at these numbers, the DR prevalence itself and the diabetic population itself is approximately 1/3, and 10% of them will have vision-threatening complications such as proliferative diabetic retinopathy and DME. If you look at India, there are 62 million Indians and living with diabetes as of now, and the average age of onset is a very, very young population, around 40 years of age, and nearly 1 million Indians die due to diabetes every year. So when we look at these high incidence, it's particularly attributed to the genetic susceptibility that we have, the high calorie diet and the low activity lifestyle. So now that we know that diabetes is a leading cause of new cases of blindness between 20 and 75 years, what are we doing? Even DCCT has reported that 27% of patients with type 1 diabetes will develop macular edema within 9 years, and other studies indicate that type 2 diabetic patients, the prevalence increases from 3% within 5 years of diagnosis to 28% by 20 years of duration. So like I mentioned, the duration of the disease, hyperglycemia, dyslipidemia, hypertension, other diabetes related complications are factors that can increase diabetic macular edema. So this is a picture of a patient with diabetic macular edema. As you can see, the hard exudates. Difficult to say thickening is there or not. Of course, we do have the OCT, which is pretty much, change the way we manage macular disorders, right from diagnosis to follow-up to response to treatment, everything OCT does help us. Now this is a gentleman with diabetic macular edema. You can see that he has bilateral edema, and there's a large edema plus 700, 800 microns. But if you see post-injection, one eye has responded beautifully whereas the other one has not. So what is the trigger? Why does this occur? Why is it that some patients respond and some not? We know that it is very distressing for these patients because those with DME cannot see faces. They cannot recognize faces of their loved ones. They cannot look at their mobile. They cannot do very important daily activities. And what do we have to treat these patients in our armamentarium right now is that we have steroids, we have anti-VEGF agents, we have surgical options as well for tractional components, and laser photocoagulation. Now each one of them have their advantages and disadvantages, and these are some of the drugs that are here. What is the surgery that we do? So what are the limitations for each one of these? If you look at the anti-VEGFs and the lasers, with anti-VEGF pharmacotherapy, we need repeated injections. You cannot give it in those patients with any cardiovascular incidents, those with strokes or pregnancy. Substantial group of these patients are non-responders, and the disease is also very recurrent and it's very dependent on their diabetes status as well. Because they have to keep coming again and again, they are unable to afford treatment and we lose compliance from them. As far as lasers go, the most important limitation of lasers is that you cannot use it for patients with center involving macular edema. Now this is a typical response to any patient whom we give anti-VEGF. So it reduces and there is a good chance that it will come back. And then when you keep treating these patients, it's a waxing, waning, recurrent, non-responding course, and despite treatment for 2 years, there is persistent DME. So why does this edema even occur in these patients? We know that there is both a vascular and an inflammatory component here. It arises from the breakdown of BRB and a consequent increase in the vascular permeability. And the intravitreal injections is therefore targeting at the intraocular and VEGF that is supposed to be responsible for the DME. Now if you look at it, inflammation is also a very, very important component of those with retinal diseases, especially the vascular component. So you have uveitis, you have retinal vein occlusions, whether it's wet AMD or DME, all of them do have a component of inflammation. And there has also been a very important paper that showed us about the diabetic retinopathy being an inflammatory disease. So when we know that inflammation is associated with DME and these are the different mediators of inflammation, we wanted to see how exactly these biomarkers can help us determine whether there is inflammation or not. So the purpose of the study was to evaluate the role of ocular inflammation in the pathogenesis of diabetic retinopathy. We collected aqueous humor from patients undergoing intraocular surgery, whether it was cataract, those with diabetes without diabetic retinopathy, those with macular edema, and those with advanced PDR as well. So the various soluble proteins that were there in the aqueous humor was measured. A stringent cold chain transfer was done at our institute's lab and samples were kept at -80. This is sorted out and then the aspirate is agitated and then sent in a phosphate buffer solution. So this is how the samples are collected and processed. And then finally we send it for a cytometric bead array method for simultaneously detecting and quantifying the desired study factors. So now what we actually found when we looked at it through the flow cytometer with our quantified composite report was that VEGF levels were higher in those with diabetic retinopathy compared to controls, but it was lower in patients who underwent repeated injections. So does it make sense to keep giving them injections? There was elevation of a pro-angiogenic and a pro-inflammatory biomarkers such as IL-6, 8, MCP1 in patients when non-responders to anti-VEGF. And there was downregulation of anti-inflammatory cytokines like IL-12, P70 in the persisting macular edema groups. So what we found was that the cytokines such as ICAM, VCAM, etc. were there increased in those with progression of the disease or who were resistant to anti-VEGF therapy. So this basic study sheds light on the anti-VEGF mediated angiogenesis pathway. So why not target the inflammation itself? It can potentially prevent an increase in permeability in these patients. And studies have shown that bevacizumab achieved less marked improvement in CRT for a shorter duration compared to its steroids. So there are several studies here which have actually shown us how corticosteroids target the inflammation, and they have shown that they target it at multiple levels. And how are they different is that while VEGFs target angiogenesis and do not treat the underlying inflammation, what corticosteroids do is that they inhibit the release of pro-inflammatory mediators including VEGF itself, and they stabilize the junctions preventing further increase in the edema. So these are the different drugs that are available, and they suppress inflammatory mediators. The DEX implant study itself, we've had several, be the Mead, Mozart, the Camplin and the Placid. I will not go into the details. But this particular is a real life, real world scenario paper which has actually shown us how steroids have been extremely beneficial in the treatment of DME as well. Now when you look at cataract itself, there is no major progression in the cataract observed, and you can even use it in patients who are expected to undergo cataract itself in the next couple of years. And lens opacification anyways is supposed to occur in these patients with diabetes. A couple of more studies again which showed that there was no major risk with respect to either ocular hypertension or with respect to cataract progression, and either which ways they could be easily managed with just medical or surgical treatment for diabetic for the cataract itself. So the cost benefit, if you look also, it's significantly fewer treatment requirement is there, and follow up also we pretty much follow them up only once in 2 to 3 months. So these are a couple of case examples. This was a treatment naive patient who responded initially, but then this is a non-responder who again required an Ozurdex and did very well. And what this study also showed us here was that the VEGF levels were very, very low in these patients who didn't respond to the anti-VEGF. So this is the quick injection technique. I think most of you would have already used it. It's a very brief video. You just, as with any other intravitreal pharmacotherapy, betadine drops are instilled, and we do, clean up. This is how the Ozurdex implant looks. We remove the safety valve, and you go in with a bevel. There you take the marking first. Again, the markings would change based on whether the patient is pseudophakic or phakic. So when you do it biplanar, there is a less risk of any vitreous prolapse or a vitreous bead occurring. So, so this is how the Ozurdex implant actually looks when you look at it on the indirect ophthalmoscopy. That's an old implant that was given a couple of months ago. Some of the complications that one should be careful about is not to inject it into the lens. Also, in those patients who are vitrectomized, again, you don't have resistance coming in from the vitreous, so you need to be a little careful as to which way you direct the implant, and preferably not to give Ozurdex in patients who have a single chamber, that is, who are aphakic. You can see it landing in the anterior chamber. So to conclude, DME is a visually debilitating disease. It needs repeated injections and is frustrating both to the caregiver and the patient. Local ocular factors remain poorly understood, but they do play a very, very important role in the pathogenesis of DME, and a good proportion of patients do not always respond to anti-VEGFs. So the key points is that it is very efficacious. It targets multiple, pathways in the causation of DME. It's fast acting, longer duration, low injection regimes, and we have seen pretty good safety profile in these patients. Thank you so much.
Thank you, Dr. Chaitra. I hand over the mic to Dr. KP for the next session.
I thank Dr. Chaitra for a wonderful talk, and thank the moderators, Dr. Amey, Dr. Hanumantappa, and Dr. Chaitra herself for moderating this session. Now I hand over the mic to Dr. Guru Prasad for the most awaited event, MM Joshi Oration Award, and the awardee and the citation reading, as well as the giveaway with the citation, followed by the talk by Dr. Debashish Bhattacharya.
I request all the delegates to please be seated. He's called as the management guru, and his Disha Eye Care is nothing but it's one of the example that how an eye care practice can grow. And with this we have the man from Disha, all the way from West Bengal, Dr. Debashish Bhattacharya sir, who will be delivering the Oration Award, followed by Dr. Amulya Sahu sir from Eye Care to Eye Care. And then we have Young Achievers Award being delivered by Dr. Kaushik Murli. We have three important talks now. I now request Dr. Debashish sir to please come up on the dais.
Next to him.
That's all that's going to come. Okay. So once again, I take great pleasure and consider it as an honor to introduce Dr. Debasis Bhattacharya read out his citation. Dr. Debasis Bhattacharya is an iconic figure in the field of ophthalmology. We all know that. With nearly 4 fruitful decades of experience and unconditional service to mankind, he has made a mark which every ophthalmologist would like to emulate. During his long and tireless journey, he has kept abreast with the rapid changes which every medical field is challenged with today. An important milestone is his chain of 17 eye hospitals all over West Bengal by the name of Disha Eye Hospitals, which he envisioned and established in 1997. Widely respected for his affirmed philosophy of affordable quality eye care for everyone, he is also one of the prime movers of the group practice model in Indian healthcare. Being a teacher par excellence and his strong belief that knowledge grows exponentially by dissemination and sharing has resulted in producing several hundred young ophthalmologists through training programs and fellowships. Dr. Bhattacharya's tireless service and tryst with quality is evident in the success of several hundred thousands of his cases. The smile on his patients' faces is testimony to his skill. Dr. Bhattacharya is a true leader. He has held many positions of authority, including the highest office of the body of ophthalmologists, that is the All India Ophthalmological Society, the biggest organization having over 25,000 members, the maximum number of life members in the world. He was the president of the AIOS in 2015-16 and is remembered for his proactive style of administration and his exemplary leadership. He is truly the pride of Indian ophthalmology. And therefore, for his excellence in the specialty of ophthalmology and selfless care of patients, for his passion for teaching, which has benefited hundreds of students, for being an inspiration with his exemplary diligence and brilliance, for being so humble in spite of being so accomplished, for serving passionately with grace, wisdom, and clarity the poorer sections of the society, and above all, for being a wonderful human being. And with all these, having made a significant contribution to the service of the suffering, we, the chairman and directors of the Joshi Eye Institute, are delighted to confer on Dr. Debasis Bhattacharya the Joshi Oration Award on this 24th day of April 2022. With this, I introduce Dr. Debasis Bhattacharya. Music.
Shri Prahlad Joshi ji said that we have to show the Disha. I think he is the man who will show the Disha, the direction to the ophthalmologist. His hospitals are also named as Disha Eye Hospital Group. So we request the oration awardee, Dr. Debasis Bhattacharya, to give away his oration lecture.
Sir, this side, this side. Please put up his presentation on the laptop.
Good afternoon, everybody. Truly honored and humbled by this and overwhelmed by this gesture. I'm very pleased to receive this Dr. Joshi Oration Award. Incidentally or coincidentally, when I was taking up the charge of the AIOS President, Padma Shri Dr. Joshi was being conferred the Lifetime Achievement Award by the All India Society. It was an occasion where we paid our tribute to the great man who, after his Mumbai education, came back to his roots in Dharwad and served the people and created this wonderful organization with such beautiful people and a wonderful institute where the new generation can learn and move forwards, which we have seen through the conference. The entire composure of this institution is available in this photograph, where the collective cheer of the entire hospital is in line with the organizational culture, and you can see individual faces. You can see every face if you want to. I mean, I can see it in the laptop. And that is the beauty of a creator of the caliber of Professor Joshi, whom I immensely respect. So in this context, let me present the Disha story. Columbus went and sailed out to discover India. He ended up discovering America. Little did he know that this is going to be the most resourceful country today. So much in life occurs more by default than by design. But if for the youngsters, if we follow these designs in the default, we can actually have successful practices. So don't go by the defaults, try to see the design in the defaults. So initial days for any youngster would be tough. And I also didn't get the conventional government job because I was overwhelmed by the hierarchical welfareism, obligatory commitment to welfareism by the bureaucracy. And the interview didn't go well. So we cannot really work for something that we don't agree. Let us, call a spade and decide. I would advise youngsters to be very sure of what they want to do in life. So then the next 6 months, I was designing a city clinic for free. And when the D-Day came, I was buying retinal lasers and all of that. And when the D-Day came, all the hobnobs of the city came and the big consultants, and they said, this guy can only be an RMO. I cannot practice as a full-time consultant there. So, be it, I just said, I got the kick in the back, and I said, I might as well, and out of a reaction, I said, I'll have a bigger hospital than this. So just understand, 6 months back, I was looking for a government job, but 6 months after, I had already promised myself a hospital. So these are the defaults, and you can trace the design. So back home in the spectacle shop, which were the only places of practice then in '84, there was the big optometrist who was there for 25 years, and my name small, but then I knew he was there for 25 years. So without my patience, I would watch Pani Puri wala who used to do brisk business, and he was a very good street educator. He told me about customer experiences, how to win their satisfaction, how to customize customers, how to promote things like बेटी आ रही है ना तो चलो घर में पार्टी करते हैं हम जाके पानी पूरी देंगे. So he is shifting his business to home events. So that kind of little things we learned, and it was all about distributing happiness. the way he carried out his business has nothing to do with pani puris. So essentially, we must also understand that today we prescribe a spectacle, the patient's happy. We do replace the lens with an IOL, we give refractive solutions, and anybody above the age of 55 is very happy. We have very, very happy products. We have excellent happy products. We give a retina injection, the patient's vision improves. A red eye comes, we give eye drops, the patient's fine. A refractive surgery, nothing can be more elating. So we have fantastic products. It is the way we distribute it, to whom what we distribute, and how we do it is what makes all the difference. It is the art of the science which makes the bigger difference. I became a doctor because my mother wanted me to be one. So when I started my first clinic, in a small lecture, she said 2 words, that please see that all patients around you can come to you. But the next words which were, so it was being inclusive. The next word was, don't charge so much, but charge every patient. So I didn't understand from her philanthropic ways that she had. And I asked, why do you say so? She said that disease means that you're not at ease. And this is a process of participation. The person must participate and contribute to become healthy in some way or the other. So definitely you should be charging, and we follow that in our hospital going forwards. So because I had this dream and I had already promised myself, so what happens with dreams is you are always seeking an opportunity. You are always collecting resources to move forward. Dreams are not enough. It must not let you sleep. I mean, it's not dreaming when you sleep. So I saw IOL before my peers, and I started implanting in 1988. And Appa Swami, he gave us free 30 lenses and the microscope, and you could pay as you earn. So, today we affiliate with financiers and other people, but I would say we better affiliate with people who are also in the business in ways that by developing, as our practices grow, they also grow. So, and by 1995, I was doing 2,000 IOLs. This was majorly because the place where we located in Barrackpur, which was just the outskirts of Calcutta. So the entire northern belt, like North Karnataka, so the entire northern belt had to go through Barrackpur to Calcutta. And rural people, they prefer to be in a suburban place rather than be lost in the city. So location is perhaps the best, is the one thing that decides who's going to be your patient, what are you going to propose to your patients, like what are you going to distribute, what are the services you would choose, and at which price per point. So in this busy practice, I had 4 friends from the same medical college, very much here in Joshi, Srinivas, Guru Prasad, KP, and Satyamurthy, yes. So essentially like them, they were just about a year junior to me. Dr. Basak is 2 years junior to me. He brought in discipline, he brought in academics, he brought in time management. He was a rigid taskmaster. Whereas Tushar on the left was like KP. He was a jack of all trades and a very extremely big hard worker. And Tushar Sinha, a vitreoretinal surgeon, he was the strategist. And I was just the man who would ignite things. So, but there was, though they maximized my practice, they wouldn't leave and start a full-fledged hospital. And the security of the government job, more from their family, was the objection. So how could we get over it? It's very simple that, when you have commitment, you do a little sacrifice. Sacrifice is not a big word. It is just that you give your initial position of strength for a more efficient future temporarily. That is sacrifice. And so I left my practice and they left their government jobs, and we started working for 10,000 rupees a month. That was quite something in 1997 though. And they were, again, by default, or you may say by design, because you get affiliated with whom you choose to be. So they were the best doctors who could be in West Bengal at that point of time. So this collegiality of doctors, this develops immediate faith, not only amongst patients, but amongst your peers. So huge young people, they started believing in us and they joined us. And patients were going to South India for treatment for every little reason. So we had the opportunity. So it was brisk training because we knew we had to grow, we had to reproduce and replicate very quickly. And we focused on super specialities, especially vitreoretina, because there were no vitreoretinal centers at that point of time in West Bengal. And we had an eye bank because Dr. Basak was a dedicated cornea person from the very beginning, and we are today the third largest eye bank. We do about 2,000 eyes every year. So essentially here lies our main theme, that cost is the first step to quality. Because if it is not affordable, it's not there. And then quality itself reduces cost. To better understand this, generally today is the day of, patient experiences. We don't we don't market treatments, we market patient experiences. So the obvious question comes, what does the patient want? What can we do for him? Well, the patient wants everything. What is important is to ask, what is the patient willing to pay for? If we find an answer to that, then we understand what we need to give, what we need to offer. So we didn't start with SICS. We did continue with SICS for a long time because the affordabilities were not there. Cataracts were hard, the machines were not good, lenses were not being available, good lenses. So then from 2004, actually, we switched mass scale. And when we talk about cataract packages, we start from the bottom, the counselors, not from the top. Because, if you start from the top and you end up somewhere in the middle, the patient feels I've missed so much more. Whereas you start from the bottom and somewhere the counselor feels that he's comfortable at this range, so you're buying the best for the patients. So incorporate technology as much as possible. So we picked up torics, we are doing trifocals as the multifocals were stopped, and we use OCTs. I think, any dull phobia is an indication for OCT in Disha Eye hospitals. And we market it for 300 rupees. So we also do Optos for 300 rupees. And the simple equation is that we need 50 Optos a day and a 500 OPD hospital can definitely do that. And so we have 6 installations. Same is with lamellar flow theaters. It may look out of the block, but if you are doing 2,000 or 3,000 surgeries, the OT costs 30 lakhs. So it is in 10 years' time, it's just about 100, 200 rupees per surgery. So we were in systems, and now we are on the AWS platform. So staff grows as they learn multiple functions, or they are trainers, or they take charge of departments, and that is where growth becomes so important. We incentivize on numbers and outcomes. So the doctor with an year-end fee for service is what we believe in, where compliance of the patients, the intervention ratio, how many did you advise, how many did comply, time, whether the service was on time, what is your brand value, academics, teaching, training. We're very frank on money. So, and this makes the system a little competitive. So we have AV recordings at every point, so there are no switchover glitches. And all these are strategies and feedbacks from patients, digital communications, evaluation of performances, designing new services, go around but what is more important is this collegiality. Many of these young children there are becoming doctors. So that's what I am looking forward to, because someday I have to do what I have been seeing Sir doing in this conference. So, we kept on follow the following, because wherever we saw 50 patients coming from a jurisdiction of, say, in a district, 50 patients, we knew if we open a hospital, it will become 150 in 2 years' time. And most of these infrastructures are our own, so and through internal accruals. So it is patients' money going to serving in their proximities. So this is what we have done over this, and we are 17 hospitals in 17 locations now. And we see 12 lakh patients. And so when we opened our flagship hospital in Calcutta, well, COVID struck, but things got better. And now we are doing well in this hospital too. It's an 80,000 square feet facility. And currently what we are doing is we are started 6 vision centers which has OCTs. And these are connected with telemedicine. It is just out of the block. We've started 2 months, and the response is we have to do more education there. So essentially, it's high-end, but we are setting up where probably we think we won't or can't, patients can't afford a hospital. So essentially, it has got a Topcon Mastro. So essentially, it can give us everything for the doctor on teleconsultation, and so everything, and I think this could be a game changer. So this is our services over years. In the last 3 years, this was the COVID year where we saw less patients. We did about 57,000 cataracts, but the rebound was there. We did 81,000. And we do a lot of cornea, yes, about 2,000. And so having said that, we shouldn't be stopping. This is a cuddly girl, I am an old friend whom I really used to enjoy hugging her and playing with her. But then she stood tall in front of me. We met after a long time, and I said, oh my God, you've become a lady. And she gave a very small, sweet answer. Uncle had no option. Yes, the fact is, growth doesn't have an option. It has to be relentless, and we have to keep on moving, otherwise we grow old. So this is how we have grown in our OPD as we have developed our branches, and this is our year-on-year cataracts. So you can see the dip of COVID here. Otherwise, it's all the way up. Good it is. And these are our revenues, so fairly good at this point of time after COVID. But all said, I mean, we have to look at the one point that all technology, all these combinations, all these various offerings, giving the right fair price, all has its advantages. But you know, you can see your person seeing a patient, and the stethoscope is probably not even in the ears, but this is the most familiar thing that a patient knows. That's how a doctor examines. That is the mindset and the psyche that a patient comes to us. And that human touch is so important. So we should be looking towards every thing that is happening around and try to assimilate, try to aggregate, try to curate and bring out the best that we can offer at the most affordable and the most reasonable price by merging, by working together, by affiliating and moving forwards. But we should definitely remember one thing, that there is nothing like being human. So, I mean, giving is the best thing. If for the youngsters I say, you know, you have time, so give your time. If your teacher, you feel your teacher's not teaching, just see what does the teacher doesn't have time for. So do that for the teacher. So if you have saved his time, he's out of human relationship, out of human conviction, he's going to give that time to you. You will definitely be taught. That's the way it happens in life. And this boy, you know, I went to Chaitanyapur, a very big hospital they have, and a blind school they have for vocational rehabilitation. So he stood by me. It was the next day before Diwali, and he was pulling my trousers, and he gave me a box of candles. And then he said, "We make this." So I just thought, these boys and girls who can't even see are making candles to light our Diwali. It was so touchy, you know. I spent the next day with them, and it was excellent. Thank you once again for all the honor. Thank you very much.
Thank you so much, Debashish sir. That was really an inspiring talk. The journey, how Disha Hospital, and can you imagine, it started with 0 and now doing around 81,000 cataract surgeries a year, which is really phenomenal. And not just that, they have a very good model as well of how to make a sustainability. They are in the 200-300 crore kind of business. So along with the giving them an affordable pricing to catering to all the economic sections of the society, and they are also able to make such large turnover and the margin, I think it's one of its kind in India, I would like to say, because me and Santosh sir were just describing how Arvind took up and McDonaldization of the eye care. I think it's a very good article for you all to read. It's a very nice. Similar way, I think I should say that Disha is no behind, and they have really reached to the higher scales. We look forward to have more growth in Disha, sir, and keep giving us Disha. Thank you, sir.
Now it's time to have another veteran, the star of our ophthalmology, the guiding light, probably the man who wears multiple hats, Dr. Amulya Sahu. As we have already introduced him, he is a man to look up to. He is a person who not only was a very successful ophthalmologist, he also took the leadership responsibility to make SICS a global phenomenon. He introduced India on the global platform, and now people look up to India for the complexity that we face in our day-to-day practice and learn from us. So he is the proud recipient of the Lifetime Achievement Award, Joshi Lifetime Achievement Award that we have bestowed upon him today. We deem it as an honor to have him here to give away this award. It's time to listen to Dr. Amulya Sahu. A very catchy title, From Eye to Eye.
Thank you, sir. And after this, we'll have another interesting talk of the growth of Shankara Eye Foundation by Dr. Murli Kaushik. And Dr. Sahu, sir, needs no introduction. I would like to call him as a holy man in ophthalmology. You should spend time with him where he starts giving how ophthalmology, how Gita can be practiced in ophthalmology. Over to Dr. Sahu, sir.
This is a humbling moment for me. I am really going to treasure this moment because this Joshi hospital is a holy hospital, as I will consider this is one of the examples that all ophthalmologists should keep it in mind. And before me was a person, Dr. Devashish Bhattacharya. You listen to his journey. Now, one thing in common in all these people, when the plant becomes full of fruits, it's bow downs. So this is the humbleness of these great people. You cannot make out them. They have so much behind them, and they have done so much. So I had the opportunity to visit Joshi sir in his house, thanks to Srinivas. And the way he explained his journey, it was really humbling. All those times in this part of the country, thinking of having a vision like this, but that started with the attitude of service, not in thought of becoming important or accumulating wealth or making big business, and that kind of thought was not there. It was service, and that service is the thing that materializes institutions, that brings in birds of same feather, they flock together. It is a well said proverb. So when you are a good human being, you will grow and you will bring institutions, and that institution will last. That is the operative principles of Tata Enterprise. The man has gone, but his name always reverberates, and people, one experiment, one little wrong person came in the form of I'm forgetting his name. He was spoiling something. So he was not understanding the ethos of the Tatas. So he wanted to bring it in the business module, and it was so much going wrong. Now see, Tata again has gone up so much. So what matters is your thought into the institution. What it is, the deeper you go, the higher you go. So here I am going to share with you that look at this lotus. Lotus is born in the pond, and the minister mentioned that Dr. Joshi was coming from a poor family. So that is the spur is there. Then where you are born is not important. How you express your life is what matters. Now this is the lotus prayer. That lotus is looking up always for the higher values things and higher pursuit, always cheerful, always, when you look at a lotus, you can't feel depressed. So that is the way the life should be. That is a symbol of lotus. Now I come from a village, 75 years. I'm 75 years with 3 stands inside me. So this is a village. Me and my young cousin brother, I am become a doctor. He become an engineer. So far, I am the only doctor from that village. This is a one family village. 1460, the Samsundar Sahu came to this place and made a temple, Radha Gopinath temple, and then this is now we have grown, and when I started studying, I didn't have a pen, and I had started with a Moirpunk. So that is the time I'm deep in the thing, and then pen came, then I become. So that time I was just thinking that how to make my village proud. That was the driving force at that time. So I came to a town where my father has a business, and then from there to the medical college where I experimented life in various ways. I became a mountaineer. I did basic course, advanced course, represented India in Scouts and became a best CSM in NCC. I wanted to know myself because I had a very running mind, which I was all the time getting puzzled why my mind is running and everybody is appreciating but not myself. So I was thinking that mind, that time I didn't know that mind is not me, but mind was definitely creating problem for me, and I thought I must know why these things are happening. So I became a president of my Silver Jubilee year of my medical college. Then that time I went to meet the minister and I said I want electricity for my village, and he agreed. So we got the electricity when I was the president of SC Medical College, the premier college in Odisha. So from there, when I came to Bombay, I took up a job, but then I found in Kashmir. Then I thought, this is not for me, and I am not here to have a straitjacket life. So I resigned from there in the CRPF. I was a medical officer. Then I came to Bombay, and 150 rupees night CMO job I started there. But that was okay. And then all the time I knew that I can do better. I can do better. So I also started from there, and I became the president of Bombay Ophthalmic Association. That time I was thinking that I will make my state proud. That pride is one thing we must have. That Indian as a pride, and that wherever you belong, the pride is the drive that takes you always up, not ahankar, but the pride of being yourself, accepting what you are. And the moment you accept what you are, then from there the journey, you have a choice at that stage whether to go down or go up, whether to go to the state of unconsciousness or you move in the direction of consciousness. Choice is yours. Now when you move towards the unconscious, you become a stone. But when you move towards consciousness, you become divine. So that is you have a choice. Now once in 2005 I started ISMS-ICS, I said that why the SICS surgeons are considered lesser gods. They were untouchable. People were not thinking they are not surgeons. 75% of the work was done by the SICS surgeon, but they were not valued. So that is the time I made this organization, ISM. I said unless we have a platform for them, nobody will value them. And that time, Aldipurkar and all those people they say, you are going against the tide. Even Amar Agarwal said, you leave it and come to our side, you become president. I said, no, there is something, I should follow this. And then I knew that we have a slave mentality. We have been ruled by others, and they have made us feel that we are inferior. They have divided us in the caste line, religious line. They have banned the Sanskrit as a dead language. And then, so they had made us to feel inferior, and that is the Macaulay gave us this English language. Once he said that once they learn English, they will be always our follower. So that attitude, I said, if I promote SICS here, nobody is going to listen to me. So I went abroad, Southeast Asia, everywhere. They were so much of, we got so much of recognition and other thing. Then I came back, then I thought that now that we have at least popularize outside, people will listen, because they said when we are appreciated abroad, then your own people listen to you. So with that, I thought one thing I said that we should have the world conference. We should not follow America always. Let America follow us. And that is the idea that propelled me to have the world conference. So far we have done 3 world conferences. 4th will be in Chandigarh, 5th will be in LV Prasad, and 6th will be in America. So we have planned out like that, and the organization is growing. We have got chapters in all the states of India and 14 countries abroad. More and more countries are joining. Now, looking at what the topic I have taken is not professionally what we are practicing and all that. That is okay. That is our external manifestation of. But what about me as a person? Do I know myself? The fundamentals, the most of the problems. How many of you can say you are always happy? How many of you people say you are temporarily happy, temporarily unhappy? How many people are totally unhappy? Now, when you look for the reasons, the reason is not outside. The reason is lack of self-understanding. If I understand myself, that I am a cosmic robot. I am a cosmic robot. We are making robots which are talking, which are, after some time they will have extend feeling to us also. We can stay with them. So this is a coming. We are creating our robots, and we are created by the Creator. So if you see the scientific way also, we have only two faculty in our disposal, coordination and programming. All the other things are governed by the autonomic nervous system. That means the switch is in his hand. Whether you know or don't know, but you try to understand that you are not the boss. So if you have come to this world for something, the purpose of coming should be questioned. Why I have come to this world? Who am I? Why I have come to this world and what I am to do? So that brings us the choosing the model of self-expression. I choose ophthalmology. It's a profession. What does that profession means? To profess, make a statement. But who is making the statement? That has to be understood. Now when you go inside, then you say that this body is a biological car. There is nothing more than a car. It is running by electric current. If I identified with the body, then I am going to suffer, because nobody can help me. Because power is limited. Its parameters are limited. So I am on a limited parameter understanding. I want to be unlimited. Not possible. Now this is a biological computer. Whatever programming you do, you get back. You say I am the best person in the world, you become the best person. So the programming has to be really proper. Most of the time we are doing this thing, they are programming wrong things and the wrong results comes. So this is an air conditioner. If your feeling is an air conditioner, if you have a loving heart, your life is cool. If you put hatred and all sort of nonsense, then you suffer. But who am I exactly? I am not this body, I am not this computer, I am not this air conditioner. Then who am I? I am just a visitor to this planet for a short time. Though that consciousness, that awareness must be there always. And if that understanding comes, then how am I going to know all these things? Because that is the source of knowledge. Is it telling me about my time? Okay. 2 minutes? Okay. So we go through Veda, Vedanta, Upanishad. I will run through this. The Veda means to know. The Vid Dhatu, it comes from Vid Dhatu to Janna. Manna nahi hai. Then you go to Mahabharata. I will tell that example of Mahabharata is what it happened. We say it in Haryana and all this thing. This is Dharmakhetra, Kurukshetra, Idam Sariram Kwanta. This body is the Dharmakhetra and Kamakhetra. The Dharmakhetra means whatever we are dharan karenge, wahi kharcha karenge. If you are having a good thought, you will do a good work. So Arjuna is brain, Bhima is physical power, Yudhishthira is judgment, Nakula is farsightedness, Sahadev is intuition. 5 attribute to all of us. The body is the chariot. And the 5 senses are 5 horses which making us run. Now, Kaurava means Kurava. Bad forces are hundreds. The fight between your senses and this distraction is Mahabharata. Then Arjuna becomes despondent. How am I going to win this war? Krishna means Karsati iti Krishna. The one who attracts is Krishna. What is attracting in me? My 4th state, that is Turiya. So, and make it in the driver's seat. Put it in the driver's seat. The moment you put your consciousness in the driver's seat, then you cannot go wrong. Then you have won the Mahabharata. Gita, the same thing that Krishna is telling to Arjuna, and all of us are facing the same thing throughout our life. Now, once you, how you are going, first you are mumukshu, that should be how you are starting. Janne ki ichha hona chahiye. Shishya, then you become a shishya. Then you become a yogi, you try to join with your higher self. Then you become muni, you have a choice. You want to use your computer always for these things. Then you become muni, the manan. Then you become sant, santata aa gaya. But we have the rishis, that means the drashta. Then that is like Einstein, we had so many drashtas, sapta rishis and all these people they were given. They were drashta, they saw the principle in the space. E is to mc square, Einstein saw, and all these rishis, they saw the principles like that. How they saw it? Because they move into the higher dimension. So now when you are moving, please go inside. Go inside and seek your higher dimension. The dimension speaks, not you. If you are on the fourth state of the Turiya, then you talk in a language which is universal, which is something different. And there the creativity happens. M.M. Joshi's journey is one of those examples of a person who started in a humble beginning. The only thing, for the last 30 years, I have never stopped yoga. Every day, anywhere in the world, I will get up and do my yoga. And with that, what has happened is that my mind has become totally quiet. So that means that thing which was troubling, maybe was pushing me, as Dr. Bhattacharya said, by default, towards the path of self-seeking. So I can be silent, I can be happy, anywhere I am happy. Now I have more energy than my people, and I am working throughout the day. I will never feel tired. There is nothing, no conflict. I accept suppose the contrary opinion comes, you accept it. You develop that kind of thing within yourself. The yoga is the thing. Now the family is the laboratory. Then you experiment, whatever you do with your self journey, you experiment in the family, in your profession, in your society, everywhere. This is the inner journey, and don't underestimate it, because the deeper you go, the higher you go. Thank you so much.
Thank you very much, Dr. Amoli Sahu, for that wonderful talk on the philosophy of ophthalmology. Yeah. Thank you, sir. Thank you very much. It was a pleasure having you here and listening to you. We now have Padma Shri Dr. M.M. Joshi Young Achiever Awards winner, Dr. Kaushik Murali, to speak to us on ensuring quality, surgical quality in camp patients. We've already heard about Dr. Kaushik Murali's achievements, so we'll straight away delve into his talk. Dr. Kaushik Murali, please.
Thank you, sir. Truly, it is humbling to be recognized with this award amongst this august gathering. And my warm wishes to M.M. Joshi, sir, and the entire M.M. Joshi Institute for the hospitality and warmth. It was almost like being at a family function the last 2 days. I don't think anybody here can complain about any aspect of the entire event that we've witnessed here. I take this opportunity to acknowledge some of our colleagues, Dr. Sheena and Meenakshi, and our staff Sheelabai, who helped with some of the pictures and videos that I'm showing here. And of course, my teacher, Dr. J.K. Reddy, who has been instrumental in a lot of the innovations that we've been actually brought out at Shankara over the years. What we have believed in terms of the high volume is our founder's vision, Dr. Ramani and Dr. Radha, who started Shankara with the first savings deposit of 5 rupees. And neither of them are ophthalmologists, but they believed that there was a necessity for eye care to be grown or spread across the geography that they were presented. And with this vision of working towards freedom from avoidable blindness through a very strong service-oriented team, we have grown over the years. The philosophy remains saying that eye care should not be determined by where we stay. India is a world of diversity. The cities have some of the best hospitals, the best clinicians, but it is not so in rural areas. You move to 20, 30 kilometers away, the entire canvas completely changes. What have we done? We've walked the talk. Since inception, we've done near about 31,000 outreach screening camps continuously across the various hospitals that we have. We've screened about 5.59 million fellow underprivileged Indians and performed over 2.16 million free eye surgeries to those underprivileged unable to access eye care. Now, when you talk of quality, you get reminded of the blind man and the 5 blind men and the elephant. What is quality? All along the last 2 days, the discussion was saying, oh, we shouldn't have residual astigmatism. The patient should see 6/6. It is very critical that the lens is in the bag. But is that what the patient cares about? The patient honestly cares about saying, can I get back to my work? Do I have to again go back to the hospital, or just one visit more than enough? And I don't want to have another eye surgery. So the entire quality outcome is very different based on whether you view it as a patient or whether you view it as a surgeon. And both these perspectives are very, very critical. So when you look at it holistically, the outcome essentially has 3 factors. We as ophthalmologists think that we are the most critical element in the surgical outcome, but honestly, we are probably less than 20% contributing to it. More important are the consumables that we use, because one contaminated consumable and whatever years of practice and reputation you've built goes down the drain. The instrumentation. Are you using the correct instrument for that correct procedure in the correct environment? That makes it very, very critical. This is one of our OTs. We switched from the large halls, which we had multiple tables, to today modular OTs. Like Dr. Sahu mentioned, it does not add too much to your cost, but it definitely gives you an environment where you are very comfortable operating. All our OTs today are NABH compliant. We have independent AHUs, and we've also kind of hooked up that little TV that you see behind that allows us to do some fun stuff. In terms of consumables, again, reach out to the trade. They are extremely obliging. So every batch of BSS that we get comes with its own toxicology report. We know what is going in. If there is a batch that has a problem, we call it back. The groups like the KOS and the BOS groups do highlight whenever there are any problems that fellow ophthalmologists face. If you have the record of the batch number, pull it out of your system. Once it comes into the hospital, again we quarantine it for a week where we culture one, and then physically it gets inspected at every stage. So we put a little sticker right from the store to the sub-store to the OT. There is somebody who ticks off saying that they've inspected it. That brings in some responsibility. This is done for all the intraocular consumables, which are the most critical elements that could prevent an infection. Then we've also over the years learned to do things a little differently. We are probably among the first across the country to use the simple Raja blade pretty much for every step of the cataract surgery. So it sounds like sacrilege today when we are talking of flax, but honestly this is what I was taught how to do. My first crescent and keratome I touched when I went for my fellowship at Shankar Nethralaya, and I struggled with it. With the blade, we do everything from the groove to the tunnel to the entry and pretty much everything else. We have published this. We had we presented this very early at the AOS as early as I think in 2011, where we did an OCT to show how the blade was equivalent at sometimes even better than in terms of opposition compared to a crescent. Dr. Soumya, our colleague, has also published this in the Kerala Journal of Ophthalmology, where we showed that it is almost equally safe and of course much more cost effective. Unfortunately, our students today are a little scared to use this instrument, and we try to motivate them to switch to that. The iris claw lens is again something that we adopted very, very early. Dr. JK again innovated in the design to make it slightly larger than what was available. So we looked at a 9 mm overall diameter because a lot of these patients would require a retinal exam, and we've been using this almost as a primary implant in a number of patients who have complications. You can't wish away complications. Again, the outcome depends on how well you are able to handle your complications. So this video is from 2012. So we've been doing this again for a very long time. We've also had some of our colleagues from our hospital in Guntur publish this in the IGO. We've also looked at iris claw in the pediatric population going forward. Again, for the teachers here, invariably we teach them the way the steps of the surgery are conducted. Some of our colleagues have again looked to innovate in terms of how we teach our students, and what we've realized is that it's probably easier to teach them not necessarily one after the other, but look at it from the complexity. So today, this is kind of something that we're piloting, where we first teach them how to take the suture, then the tunnel, then they do the scleral incision, then the hydro, so that they understand how the anterior chamber depth is, and then they actually go on to the next steps of the surgery, where we get them to actually dial the IOL so that they get a hang of how to handle the capsular bag, and then they prolapse, deliver the nucleus out, and almost towards the end, we kind of teach them how to do their X's. This kind of puts a method to the madness. Sometimes going straight is not smart. I've had a chat with some of our fellows who've had different paths. The kids who are able to follow this kind of a deviated zigzag pattern, their outcomes are much more, and their productivity once they complete their training is much, much better. So we need to see how differently we can also teach our students. Again, there is a learning curve. In any student's life, you start doing your surgeries, you switch from ECC to 3-plane through SICS, you suddenly become very confident. Then you have a spur of complications, you completely become despondent, you're borderlining on depression and anxiety, and then you mature over a period of time. This was again a score that we adopted pretty early. It's called the Najarawad score. This has been published for phaco, and it kind of gives you the parameters for every factor, right from the age of the patient to the type of anesthesia to the cataract density. So when you actually adopt it to SICS, you suddenly find that anything above a score of 7, you're more likely to have a complication. Where this helps you as a PG when you're selecting your cases is pick up those cases which have a lower score so that you're less likely to have a complication and not lose out on your confidence. So this is again somewhere where we match it. Again, in terms of outcomes, periodic review is very, very critical. Each one of our students and fellows are tagged to a mentor who reviews their performance. We use the ICO Oscar for SICS as well as for all the subspecialty surgeries, where we monitor them quarter on quarter with some qualitative feedback from the doctors. We've now looked to, since we use an MIS system, we are now able to pull out student-wise dashboards. So this is one of our primary DNB candidates in the 3rd year of her training, where we are able to track saying what are the complications that she's had, what is the outcome of those complications. We know they will have complications. You can't wish that away or stop them from operating because of that. But how well have they handled it and what has been the outcome of those complications? That becomes very, very crucial when you're handling very large volumes. Again, what we've tried to do differently is we've now filed for a patent for this system, which is an integrated self-recording system, where the video gets recorded and streamed and archived. So this allows us to almost real time see what is happening in all our operation theaters across the organization. And it also gives an opportunity for the students to go back and view their own surgeries. So the little snippets of the surgeries I saw were what the doctor had actually done over the last 2.5 years that she's been with us. And she was able to cull out those steps that she was doing and share it back with us. So today technology is available. It is very easy for you to incorporate all of this as a part of our practice. It is not very expensive. And what I've tried to show here as a part of our journey at Shankara is to kind of reignite why we do what we do. Invariably, we look at every patient through a slit lamp as a cataract or as that complication or as that first phaco case we did. We invariably forget that human being for whom whatever we do is probably the difference between literally darkness to light. So once again, I'm humbled by this opportunity of being recognized with the Young Achiever Award. Probably Srinivas and the team here wanted to give it before I lost any more hair on my head and would not qualify to be called young anymore. There are achievers who have done much more in this audience, and I again acknowledge that fact very humbly to be here, and thank you so much for having me here.
Thank you so much, sir. So now we go on to our last talk before we break for lunch. It will be given by Apurva ma'am on the real world evidence for aflibercept in diabetic macular edema.
It's a talk of just 5 minutes. I request everybody to please bear, and fortunately today we are on time. In the history, we are on time for the first time. So it's not of this thing, it's just 5 minutes talk quickly by Apurva, and then we quickly break for lunch. I request Zeiss team and the IOC team to be, please be seated forward.
So this was a really illuminating series of cases and studies for me. I hope it's the same for everyone in the audience. We talk about international guidelines and real world evidences in DME. So I'm going to talk about the international guidelines on the use of aflibercept in diabetic macular edema. So there have been various guidelines for the management of DME, right, by the European Society of Retina Specialists, that is EURETINA, which stated that aflibercept is the drug of choice in DME eyes with baseline BCVA which is slightly lower, that is below 69 letters, and it shows superiority over Avastin over 2 years and over ranibizumab in the first year of treatment. So what does the recommendations for Asian countries say? So again, they say that the choice of anti-VEGF depends on the baseline visual acuity. So in patients with worse visual acuity, that is any worse than 612, aflibercept may result in a more rapid visual acuity improvement than ranibizumab. And early intensive anti-VEGF treatment is important, especially for patients in Asia. So there is a Cochrane meta-analysis. As we all know, Cochrane meta-analysis represent level 1 evidence-based review and of various things in the study of medicine. And here in the review of anti-VEGF agents in DME, they included 24 randomized control trials in as many as 6,000 patients. And here the DME patients had vision which was worse than 20 by 40, but better than 20 by 200. So here also the efficacy outcomes favored Eylea over ranibizumab and bevacizumab. So you can see here that the gain of letters is also much higher than bevacizumab and ranibizumab, and look at the central retinal thickness which is in 3 digits, just to give you a rough idea. So the aflibercept patients were more likely to gain more than 3 BCVA lines on Snellen's acuity. So even at year 1, patients receiving ranibizumab or bevacizumab had a smaller change in the central retinal thickness, as I already said, compared with aflibercept. So the Cochrane meta-analysis in a nutshell said that aflibercept confers an advantage of 0.5 to 1 Snellen's line over ranibizumab and bevacizumab at year 1. So according to a survey, which is the PAT survey, aflibercept is considered the treatment of choice for new onset DME, and this included almost 1,000 participants in the US and outside of US. So it is an amalgamation of 40 societies across the world. So what basically they are saying is, if cost is not an issue, then aflibercept trumps other anti-VEGF agents in the use of treatment-naive DME, especially who have a baseline visual acuity that is worse than 20 by 40 or 6 by 12. So these were trial situations, like randomized control trials. Now if we look at real-world evidence, and we all know how real-world is vastly different compared to trial situations or trial scenarios, here the emerging real-world evidence demonstrate, just like RCTs, that gains can be obtained in routine clinical practice with aflibercept. Apollon is a study that showed that gains with aflibercept in patients with DME were consistent with those reported in VIVID, which also used aflibercept in DME. So, okay. So look at the mean change in BCVA from baseline to month 12. This is VIVID and this is Apollon, and look at the similarity in the bar charts. Again, in treatment naive patients with or without 5 initial monthly doses, so you can see that the mean change in the BCVA is really remarkable with aflibercept. Again, reductions, see, all trials talk about visual acuity and reductions in the central retinal thickness, And here also CRT reductions were similar to clinical trials in ILIA patients. So Lukic et al. Is another study where they also showed meaningful visual acuity gains and avoidance of vision loss in DME in clinical practice, not RCT. So there were robust vision gains that were maintained up to 3 years in patients with DME in clinical practice. So FRB registry is one more where again they studied baseline visual acuity of less than 68 letters, and again it showed very significant visual gain. Look at this, plus 10 letters in aflibercept compared to plus 7.6 letters in ranibizumab. So Campos, although studied lot fewer patients than the clinical trials we spoke about, they also said that in these 29 eyes, there is an effectiveness of aflibercept when administered. So I just wanted to show 2 cases and I'll finish my presentation. This is a 41-year-old male who has both eyes lasered, proliferative diabetic retinopathy, right eye is vitrectomized, right eye vision is slightly better than the left eye. This is the left eye. We started giving him bevacizumab injections. Here this is, one second, yeah. So you can see then we started giving him Ozurdex, with which we did see a remarkable improvement, and this was post the first Ozurdex. Then we gave the second dose of Ozurdex, again he improved, but this was again a temporary reduction. Then we gave a Lucentis injection. There is a massive edema that recurs and it continues to remain pretty much the same post ranibizumab. So this time we decided to go ahead with aflibercept, and you can see that this was the pre-aflibercept edema, and post 1 dose it showed, at least in the central macula, it showed some reduction, although in the temporal macula the edema did persist. But look at this post second dose. What is remarkable is that the outer retina, are you changing my slides there? Okay. So this is the post second dose of aflibercept, where it shows a remarkable improvement in the central macula, and you can see that this was maintained for 3 months, and this vision was 6/6 and N6, and you can see the integrity of the retinal layers, which are so pristine. So this is the second case. Look at this. This was a vein occlusion, interestingly superimposed on a macular edema due to diabetes. So this is pre-ranibizumab, post-ranibizumab, not bad, good improvement, but again recurrence is a huge problem in these patients. So this time we gave Ozurdex. Note how the patient has already developed some central macular thinning. This is again another, we gave an Ozurdex which flattened the macula. Now there is a recurrence. Rebound edema is a big problem in these patients. Post-ILIA at 1 month, you can see that the foveal contour is restored. And surprisingly, at 3 months, the patient continues to maintain this, and at 5 months, this is how the patient looks. You can even see on the clinical picture that most of the hemorrhages have resolved. So let me just summarize that aflibercept has been shown to be the drug of choice in DME, especially in patients with baseline BCVA below 69 letters, according to the EURETINA guidelines. It has shown superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. For Asian countries, again, same thing, patients with worse visual acuity than 612, aflibercept may result in a more rapid visual acuity improvement than its comparators. This difference was not significant in the year 2 of the DRCR.net protocol T study. Cochrane meta-analysis, which was compiling the data of more than 6,000 patients, here also patients receiving aflibercept were more likely to gain more than 3 BCVA lines at first year compared with ranibizumab or bevacizumab. And real world studies I showed you, Apollon, Campos, etc., where they have shown that even in real world settings which are not simulating trials, that aflibercept leads to good visual and anatomical outcomes consistent with those reported in clinical trials. So my take home for this is that I am definitely going to use aflibercept where cost is not a constraint, and they have come up with some strategies to even combat cost considerations, and I am going to use the aflibercept more frequently, and since I have the evidence to back up my choice. I hope this presentation helped people in terms of understanding the science and the evidence that aflibercept is based on in DME. Thank you.
Thank you, Dr. Apurva, for giving an idea about the role of aflibercept.
Stage light on, please.
Before we break for lunch, Dr. Srinivas has a very important announcement. And I would like to just tell there's a very interesting session post-lunch called the rapid fire session.
Convey the stage light on.
2-minute, well-edited video which has a clear-cut take-home message, a complication or a step or a compilation where the surgeon wants to convey a message to audience, and it will be discussed by the panelists. So please stay over for probably the most important and the most informative and the time-worthy session of this IFES, that is the rapid fire session post-lunch, immediately post-lunch.
And if the presenters can please come and give your videos, we'll have them ready for you.
It's a very short video, rapid session of 2 minutes each about a very important and commonly done mistakes and how to handle those complications. Very 2 minute videos, they are going to be real fun watching those videos. So quickly in 2 minutes before we break for lunch, can we have the moderators? Dr. Vijay Nagraj, is he here? Dr. Vijay Nagraj, Dr. Vishwanath Reddy. We have Dr. Shivkumar Hiremat, our Director for Medical Services from Bagalkot branch of MM Joshi Eye Institute, to please receive the honor from Dr. MM Joshi sir. We also have Dr. Sushil Kakanki. Dr. Abhishek, to please come on the dais. Another promising man who has established so well in Ilkal, Kushtgi and that part of area is our own alumni, shining star, Dr. Sushil Kakanki, to please receive the honor from our chairman. And we have another eminent guest faculty from Belgaum, Dr. Sachin Mahuli. Not only in Karnataka, but also he has spread his wings in Goa as well. None other than Dr. Sachin Mahuli. Thank you so much. If I have left out any names, please pardon me, please forgive me. It was not intentional, and definitely we will try to send back the mementos by courier.
And one last thing, Dr. Amulya Sahu, I told you he's a man of multiple hats. He has penned a very important philosophical musings, a book called Journey to No Thing. We are not just things. So it's a collection of poetry, and that he wants to present his book, his literary piece, to Dr. M.M. Joshi. Thank you, sir.
Yeah, we'll have a lunch break, and then it's a last session post lunch, 2 minutes video, very interesting. Please don't go anywhere. Abhi scientific program baki hai. Sorry. Zeiss. Please. We have two set of awards still left. Is Industry Trailblazer Award to the Zeiss. So I request the Zeiss team to please come over on the stage. KP sir to please come over on the dais. Can I get the memento please for the Zeiss? They are more important than us. Thank you, Team Zeiss, for your immense contribution. And we have Care Group. Mr. Lal Dave actually had to come, but because of his few personal reasons, he was not able to attend. So I request Ashutosh and Havaldar to please receive the Industry Trailblazer Award to Care Group on behalf of Mr. Lal Dave. Thank you very much. No more. You can break for lunch. Good job. Nice. Vinita? Organizer of the event. You are last session you were the moderator. Hey, sorry, one more. Sharif, Gilbert, one in the last. Whole Gilbert and team, Anand Peter and team. You are the unsung heroes. And because of you all, I think this 3D program was so successful. Please convey our regards to Anand Peter, Babu and team, whoever are listening from the OT, Gilbert, Babu, please come. Whoever are there on the AV side, audiovisual side. Yeah. So we present the Sanjoy. Sanjoy. So this is the Synergy Award presented to AV team led by Anand Peter, Gilbert, Babu and everyone. Thank you very much. Thank you Gilbert, thank you. ನಂದೆಲ್ಲ ಏನೇನು ಮುಗಿತು ನನ್ನ ಶಕ್ತಿ ಪೂರ ಹಾಕಿದ್ದೀನಿ ಸರ್ ಇನ್ನು usually thank all of you all who have tolerated me. But it could have been a little well organized. Even we should run the trial run. A room ball hinda chairs in horage haki set up ಮಾಡ್ಕೋಬೇಕು ಯಾವಾಗ. What should be kept here? If you keep inside, you will not. Because most of these are unorganized. Some of them come, some they don't come. So. Yes, sir. It's okay. Who will be there for our session then? We'll only go.
Stage lights off, please. So we'll start with the final session of our conference here. It's a rapid fire video session. So we'll have a display of various surgeries condensed in 2-minute videos. And the first video we'll be starting with is going to be by Dr. Rupa Hiremat. So if you all can all settle in. Stage lights off, please.
A kind request, people who are sitting at the back, I know you will definitely blame me. Please, people who are sitting at the back, please can you please occupy the front chairs? Just a request from our side. We can have this side, madam, because the 2D event is more on this side. The screens are more on this side. Thank you, thank you.
And this will be followed by Dr. Abhijit Kakanki. So if you can be ready. So this session is going to be chaired by Dr. Shankar Gowda Patil, Dr. Shiv Kumar Hiremat, and the moderators would be Dr. Milind Gargari, Dr. Sanjeev Kulkarni, and Dr. Deepak Meghur. So if I can please have you all come to the front row, that would be great. Yeah.
So good afternoon everyone. So this video is on powered endoscopic DCR. Start. So the endoscopic DCR, we do it in the middle meatus. So these are the various structures which you find it there. So after local infiltration, we raise the mucosal flap. It's a inverted U-shaped flap with 2 anterior and 1 horizontal incision. So the mucosal flap is reflected on the inferior turbinate. After the mucosal flap, we start the bone punching. It started from lower side. So as we go up, because of the angulations of the bone punching become difficult. So these burrs, they come in various sizes and shape. So they come into our rescue. So because of the angulation, these burrs, they help us to resurface the bony surface. The burr should be done after clearing the bone from the nasal mucosa, and there should not be any vascular perforating vessels. So these burrs, they help us to enlarge the bony ostium. As they resurface the bone, they help us to have a firm grip. So here you can see the bone, the resurfacing is done. So after that, we can have a firm grip. So you can see a large chunk of bone is removed. So by this we can enlarge the bony ostium. So as it said, the external DCR is 100%, like 95 to 100% success rate. The endonasal also can have a same success rate with all these techniques. So once we open, we can identify the sac here. So the sac is opened in a vertical fashion. It's marsupialized into the nasal mucosa. This is a sac flap. You can see a Bowman's probe into the nasal cavity. So after that, we replace the nasal mucosa back. So this powered endonasal DCR, it helps us to remove the bony bulk, improves the bone punching grip, and smoothen the edges. It reduces the surgical time and increases the success rate of endonasal DCR as good as external DCR. Thank you very much.
Thank you.
Thank
Dr.
you,
KP, any questions or your thoughts on endonasal DCR, this modification versus external?
See, I think let me just start by telling that it's happening that when I see my postgraduate, they say in the medical colleges, most of the DCRs are done by the ENT department. So we have just been pushing away all the dacrocystitis cases to ENT department, and we're not really seeing much of DCRs nowadays happening by ophthalmologists. I think Dr. Rupa Hiremat is an exception. She's an ophthalmologist. We're doing endonasal DCR. I think that is the thing.
I think congratulations. You deserve a good round of applause.
And probably, as our knowledge goes, as Cyrus Mehta said, in my experience, she's the only ophthalmologist in Karnataka doing endonasal DCR.
Again, a round of applause for her.
Thank you, sir.
So, I think actually videos look good, but sometimes when you start doing it, for a beginner, it can be very tricky. Even external DCRs can be tricky. Internally, you are going through a very small opening. Obviously, there is no exposure, and the bleeding will completely, make you go mad. But the modification that you have used, because it's very difficult to put those bony punches into that, especially the upper part. So to make a proper, having a proper edges as well as not having too sharp edges, at the same time having the optimum size. Because even in endonasal DCR, the size is important. The bony opening, that principle remains the same. If you make a smaller opening, it will heal. So it has to be bigger. So that is the whole idea. And so having these power drills probably will make things much easier, because you can negotiate a small cavity and try to get an opening of this size. I think I really congratulate Rupa for thinking of this and trying to incorporate instead of just using only the punches, in which you may not be able to get the right kind of opening.
Thank you. Thanks a lot.
So before we go on to the next one, just a gentle reminder to Dr. HMR, if you can come forward, and we don't have your video, sir. Is he here? Okay, in the meantime, so we'll move on to the second video by Dr. Abhijit.
Dr. Abhijit Kakanki is a very prolific surgeon practicing at Ilkal. He looks very smart and young, but he's actually very experienced in cataract surgery. So let us see his 2 minutes video.
Lights.
Thank you, sir. Good afternoon, everyone. Hi, I'm here to present a horizontal chopping technique. I think most of the people are well versed with vertical chopping. Somehow I was quite comfortable with horizontal chopping. I have two points here. One, I usually end up making around 5.5 mm rexes. And the second one is I use a ball chopper. I don't know from where did I get it, but I somehow saw one of the videos in YouTube, and I shared it to a vendor and he got me that. It's a ball chopper. What I usually do here is go deep into the nucleus, and once I hear the occlusion sound, I end up going behind the equator and then tracking towards the phaco tip. And definitely blue staining the anterior capsule plays a very important role here. I'm quite used to making a proximal trenching, and I go ahead and I just drag it here, and it makes two halves, and then the things are very simple here. By making bit bigger rexes makes horizontal chopping quite easier here. I am just asking if anybody knows the name of this horizontal chopper.
It's the Siebel chopper. It's a Siebel.
S-I-E-B-E-L.
The author of the phaco-dynamics book, no? That is named after him. It is a Siebel's ball chopper.
Okay.
With Abhijit's modification.
No, I don't know.
So Abhijit, as you're doing,
Yes.
what are the two prerequisites you feel for a person to venture into horizontal chopping? It is the most physiological way of cracking a nucleus, because the forces are very physiological,
Yes.
you don't require much of a stress or anything. But
Yes.
what concerns are there for you?
Sir, usually my only concern is it should not be a small pupil, because it will be very difficult for me to visualize the anterior capsule. But for that I have taken one solution of using a pupil dilators. So I use it left and right. So whenever I have a problem, I use a pupil dilator. That's Gupta ring. I find it quite convenient.
I think a bigger rexus is a prerequisite,
Yes,
better,
sir.
because you're going to cause less of a stress.
Yes, sir.
But I think this technique of learning horizontal chop is must for most surgeons, because in soft cataracts, you can't do vertical chop at all in very soft cataracts. So that's the reason you have to, you resort to horizontal chopping.
Yes.
And as a phacosurgeon, we need to be equipped with both the styles of chopping.
Sure, sir.
Thank you so much.
Thank you,
Anybody has questions, please?
Anytime have you perforate, I mean, have you encroached on the PC and caused a PC red with this?
Never, sir. What I do is I glide along the surface of the anterior surface of the cataract, and then it slides down the anterior capsule. And
Saw you going away and then coming back to the same place.
yes, sir. That is, I'm inspired from Dr. Sanjay Russell's video. So he goes, once he gives the first crack, then he keeps the chopper right below this thing only, in the anterior margin. He keeps doing it like this.
Okay. Now at the same time, lifting the nucleus helps to find the plane?
Yes, sir.
Yeah. I think after the first crack, it becomes more easier?
It is just of, your tactical feedback of your instruments. Once you do a few chops, I think once you start doing horizontal chop, you don't feel like doing any other chop.
So exactly.
And you have to have the tactile feedback because the pressure which is required is very minimal. The only, the significant advantage which I feel of a horizontal chop, there is no nucleus torque. Which can be seen when you're trying to push a vertical movement with your vertical chop.
Yes.
That is a significant advantage.
Yes.
The scare is you may rupture the anterior capsule, you may touch the posterior capsule. But once you're aware that you're beyond it and you lift up the nucleus a little bit and then push it, you should be comfortable.
And the reliability on the machine will also be less. You have to hold that perfect block there. You have to hold for that suction.
Yeah, and the
go
thing
for
is,
vertical chop.
the difference between vertical and horizontal chop is that the grip of the nucleus has to be very, very perfect when you're doing a vertical chop.
Exactly.
Because the maneuvers are lateral.
Yes.
Here, the maneuver is facing towards each other.
Yes.
A little bit of a suction loss is all right still because they are not going to, we don't get a torque in this. That's a significant advantage of an
And
horizontal
another
chop.
advantage, like the Sanjay Russell sir does, is once he goes behind the equator, he'll never lift it back till all the quadrants are broken down. That's
Yeah,
also
sure.
quite
See, you can break it all the quadrants, and some people do remove one pie out, and then which creates more space in the bag.
Yes.
Both the options are there. Sanjay sir is expert in that. We have all seen. He does for even hypermature, whatever epinucleus law, he still does there.
Yeah, thank you, Deepak. I fully agree with you. Every surgeon should learn and master the technique of horizontal chopping, which is invented by none other than the master Nagahara. It's a classical horizontal chopping technique, and the main advantage, all the forces, they act towards the phaco-tip. That is, all forces are centripetal forces. Even this technique is very useful in subluxated cataracts or say zonulodialysis. Even blunt chopper doesn't, even it touches the posterior capsule, it protects the posterior capsule coming to the tip. Even I have videos where accidental zonulodialysis or subluxated cataract, either blunt chopper or that ballpoint chopper, you can insert in the fornix and support that zonulodialysis area. Okay. And as Abhijit has rightly said, once you are on the equator of the lens, means once you master this, you get that feeling. Even in semi-dilated pupil and small pupil, you can do it.
You get the drop once you
It is
go
a
beyond the
totally
equator.
it's a left-hand job. It's a left-hand mechanical energy that is used in each and every cataract, irrespective of hardness, because your manual forces act more than a ultrasonic energy. It's an energy-saving technique.
Thank you, sir.
Thank you, sir.
Thank you, sir.
So next we have Dr. Shilpa coming in, and if I can request Dr. Shiv Kumar to be ready with his video after this.
I would request audience to come up to these mics and ask questions if you have any. Please do participate. I think discussion is going to help us, everybody.
A very good afternoon. Since we've been speaking about the pupil expanders, this is one which I have used and I find it useful. It's BVI ring. I have no financial interest. This is the ring which is retracted into the injector system. Once it is inside, it goes through very easily through a 2.2 incision, and slowly this ring is inserted into the anterior chamber. It's very similar to a Malugin ring, but with a few differences. This is the hook that pushes it, and with a Sinskey hook, you can just engage those holes which are well away. First the distal, then the proximal end of the iris. And this is where, which I found very useful, that they have holes which are well away from the iris, and that is why you don't really have any injury, inadvertent injury to the iris. You can also use another instrument to manipulate the iris, and this expander gives you about 6.5 to 7 mm of dilatation, because of which your future procedures of phacoemulsification becomes very easy. Now while removing also, it's quite easy. This material is polyurethane, because of which it is very, very soft on the iris. And it's very similar, but with a few differences to the Malugin. And you just disinsert the iris from there, and with the help, you release the iris in case it is caught up anywhere, and the injector itself, the hook comes out and it is brought out through the same incision, and you have a clean, nice surgery. Thank you so much.
Excellent demonstration, ma'am. The color is very attractive, you know, with the difference between other things, they mimic the iris colors and this stands out, the fluorescein. I think that helps us to see well, especially when the cornea is not so great. Sometimes we find it difficult to identify.
Yes.
Which company makes this? Is this the Oasis? The device is called Oasis or what?
BVI Visitech.
How much does it cost?
It is very similar to the Malugin, which is around 8,000 to 9,000.
9,000 rupees. It's
yeah, 8,000 to 9,000 rupees. But what the company says is, at least the representatives say, that you can ETO it and use it up to about 10 times. So it then becomes cost effective.
Excellent. Any questions from the audience or
Don't you think
panelists?
it's more bulky in the anterior chamber?
Yes, it is a little bulky, but what I liked about this particular, after having used the Malugin also, that because of the holes which you can engage very easily, and they are quite away from the iris. Sometimes when you are using the Malugin, you go very close to the iris, and when you are trying to manipulate it, you can injure it. This is one advantage that I thought, in my hands, I thought it was more useful.
In very shallow chambers, there was no issue of handling it? Because the pseudo exfoliation case, sometimes you have a very shallow anterior chamber.
Yes.
Because of the bulkiness.
Yeah, probably in shallow anterior chambers because of the height of that particular ring as compared to the Malugin, Malugin would score over this.
Any questions from the audience?
Any problems in the beginning, say, the first 1-2 cases?
Well, initially when I had, in the first case of mine, I was not very sure where I should hold the hook while while pulling it out. It's very important that we don't go at that point where the holes are. Next to the holes, there are some, there is like an edge which you can hold next to that V-shaped thing. And that is where you hold and pull it out. That's important, because if you try to hold where the V-shaped, where the hole is, it will not come into the injector at all. That's what will be the struggle.
Any chances that this ring can get cut while getting engaged or while being released?
Any chances?
Of the ring getting cut while inserting or while retrieving it back?
No, it has not cut really.
So is the material so malleable kind of thing that it takes up the shape just as soon as you inject it out? Yeah, memory, exactly.
No, it is malleable, but as you saw in the video, it can be pulled very easily, but it will not lose shape. You mean to say memory?
Yeah, no, memory in the sense like the kind of expansion that you expect Will it happen in all the cases in the same manner?
I have not used it much. I've used it in about 7 cases up to now. Because the first one that I have used, I'm still ETOing it and using it. That's how I know it's not 10.
No, the first case, the case you showed, it was a rigid pupil. And
Yes.
it was 3 millimeter and it became 6 or 6.5 millimeters. So that was a reasonably good expansion. So the case which she showed was a rigid pupil one. So we should think that, it will work.
Yeah. I think besides the bulkiness, the device is fantastic.
Yeah. Yes. Yes.
Correct.
But what I have heard, I don't know, I would like you all to throw some light on this. Even the Malugan ring we can ETO and use. But what they say is the Malugan is a little more friable or fragile. Whether you can keep using it many number of times.
Yeah, it is definitely much more, looks friable than this. I have used it 7 to 8 times, not more than that. So I really can't compare with this.
Okay. Thank you.
Thank you, ma'am. So now we go on to Dr. Shiv Kumar, and then we will have Dr. Sachin Mauli. So if you can be ready, that would be great.
Hello, good afternoon. I hope all the phaco videos have been seen. Now we'll move on to dislocated lens management through pars plana vitrectomy and then fragmentation and then M&A technique SFL. 25 gauge ports are made, then pars plana vitrectomy done, then nucleus is freed of all the vitreous. Then you have to make another port for fragmento. Then doing frag is almost similar to that of phacoemulsification. Only advantage of doing frag is we have larger space compared to the ACUA where there is only a small space. Again here also foot pedal same thing, press one, aspirate the nucleus, bring it into the mid-uterus and then start emulsifying it. So as you people use viscoelastic to protect the corneal endothelium, we use PFCL to protect macula. So similarly, piece by piece you emulsify. We also do it in a piece by piece and then remove all the nucleus. Now coming to the SFIL technique, there are n number of modifications and n number of techniques for SFIL. This is Yamanese technique. 2 millimeter from 1.5 to 2 millimeter from the limbus. You have to mark diagonally opposite, a bent 26 gauge needle to beveled entry. First you go horizontally into the sclera, then enter into the eye. This is done on both the sides. Then the 3-piece lens, leading haptic is dialed into that bevel of the needle and taken out of the eye. This is similar to what Guru sir has done in the morning, but it's a slightly different thing. Once you exteriorize it, cauterize it. You have seen Guru sir doing this cautery in the morning. Similar procedure is repeated on the other side. Most important thing in this technique is you have to be exactly at the same point on the other side at 180 degree. This is trailing haptic. This is the most difficult part in this surgery. Once you exteriorize it, then again do a cautery to make a flange. Okay. So this completes the SFIL procedure. After that, we have put we have to remove that PFCL whatever you have put. Check for the centration. So pretty well centered lens. Remove the PFCL and look for any fragments. and then do fluid air exchange. That completes my surgery. Thank you.
Concern regarding the extrusion of those haptics over a period of time and risk of infection, or is it a concern, or?
No, not much, sir. Usually it will be buried under the conjunctiva. So we usually do the cautery, so will not come out.
Actually, those cauterized haptics, no, balls of the cauterized haptic, they get exposed over a period of time. That is the area of concern that Deepak has rightly pointed out. I would suggest to make a small pocket. While you enter the from 2 millimeter away from the limbus, no, just go obliquely and then go inside, just like a Hoffman's pocket or say groove, scleral. That groove is sufficient to engage, keep that haptics hidden in the pocket.
This is the original M&A circuit. There are a number of modifications. Sir, what sir has done, sir has, in the morning he has done a pocket, and under that the haptics were there. So that modification is next. Yeah.
No, but only thing is it's a flat thing under conjunctiva. Why will it erode conjunctiva and come up over a period of days?
There are reports the haptic gets exposed.
I just want to add a point here. So when it comes to the Yamane technique, see what it has been shown in the video, it's not a bulb. What we have done is, on the forceps, we try to press that Bowie heat cautery. It flattens there. So it flattens. See what happens when we try to do a tunnel, and then there are chances that it might slip off. Especially the Yamane kind of thing, where we try to flange this thing. When we try, that's why what we have used the needle is what he has described it, a 30 gauge thin bore needle. If we take 26 gauge needle itself, it will slip many of times. So that's why we use the 30 gauge thin bore needle, so that making even a smallest flange will not allow it to slip for the haptic to go inside. So what we can do is make a flap. Instead of making a Hoffman's pocket, you can just make a flap, or even Hoffman's pocket also, rather than making a scleral tunnel in the same area where it has come out. Otherwise, there are chances that it might skip out back. Otherwise, make a two small scleral flaps, and under the scleral flaps, if we try to do it like the regular SFIOL, I think the problem of conjunctival extrusion doesn't arrive at all. Yeah, so that can be buried under the scleral flap in case we have, but we don't have a long-term reports of these showing how many cases have really caused the conjunctival extrusion. Yeah, so that's what, sir, applying the heat cautery is very important here. Sometimes if it is very sharp enough, we just try to leave it off. That is where it tries to come out of the conjunctiva. But if you make a flat bed while applying the heat cautery, that's why what we do is hold the forceps and then apply it. So on the forceps, if you try to press it, heat press it, it becomes flat bed. So flat bed, there are less chances that it might extrude. Just a modification of the thought. That's my suggestion. Yeah. Yeah, how you creating a flange is very important.
How you create that technique has to be, I think, elaborated for many people.
Correct. And even we should not touch that with the heat cautery. Otherwise, you feel that jelly kind of material which comes out. Just from far away, it goes very nice, and holding the forceps and then trying to do that, it becomes definitely something like a hot compress. You press it, it becomes flat.
Nice, thank you.
Yeah. Yeah, so madam is asking another question, how much do we cauterize it? It's a very important question. That is why it has failed. Yamane technique has failed when you try to replicate it other than Yamane. Because there is no guide for these lenses. If we had the guide for these lenses, then we will know how much amount of this thing we have to do it. But here generally you do it an equal amount of heat cord, especially you can say 1/4 of the haptic. That is good enough.
Thank you, sir.
This can be. We don't do any marking. I don't do any marking.
So we'll move on to the next video by Dr. Sachin Mauli. And we'll follow this up with Dr. Ameya.
Good evening, everyone. Thank you, Srinivas, Guru sir, full entire team of Dr. M.M. Joshi Eye Hospital.
Today I wanted to share this video. Actually, Srinivas asked me to share something sensational, so I thought I'll share this. This case had presented to my OPD with fish hook in the eye. A small boy, 8-year-old, he had gone fishing with his father. So the fish hook, you can see that had stuck in the cornea. See, this is an earthworm. The one which you are seeing there, this part is a dead earthworm which is tied to the fish hook. So the concerns of infection, and there's a barb. If you see here, there's a barb. If you see the anatomy of fish hook, there's a barb which is very difficult, which will not come through the entry wound. So it was very challenging because this particular earthworm also could not be removed. It was tied so tightly, and it could not be cut open. And this end there was a barb removing. So it was like if I pull it out, the whole cornea would tear. So what I decided to do was I started extending the entry wound, thinking that this barb can be engaged and then pulled it out easily. So that was my thought process. So it's a phakic eye, so I didn't want it to touch the lens also. After this is an edited video, of course. After a lot of attempts, I tried to manage that barb in the section which I had extended, and it was pulled out quite easily out. Then with one shot it came out, then formed the entry chamber, sutured the section, and removed all that organic matter which was stuck in the entry wound. So this patient did quite well. He is still under follow-up. He has regained around 6/9 vision with the sutures in place, and the lens is clear. I'll show a picture later on. So this is a post-op picture of the same patient, lens being clear and the patient. So it was a different situation for me because I had not done this before any time. So the important thing was to understand the anatomy of the fish hook. In case what learning experience I had. This barb is a dangerous thing. Once it enters the cornea, it hooks on to the entry wound, and you will not be able to pull it easily. Had I pulled it completely, the whole cornea would have cut through and through. So later on I understood, and on table I decided all these maneuvers, and I thought it would be interesting to share this video with you. Thank you so much. Any inputs? It has nothing to do with the retina. Just
I think when they probably throw it into the water, that is the time it probably ricocheted back into the eye. Normally they just throw it into the water.
Yes. No.
To get that distance.
No, his father. The story was like his father told. He threw it, and then when he thought he's caught something, and he did it back.
Okay.
His son was
Well, he's
behind.
taking it back.
Yeah.
Okay.
He did not catch anything, but the only hook flew, and his son was standing behind. It went and hit him.
Oh, the son was standing behind.
Yeah.
Okay. The father fished the eye of his son.
No, the best part was he did not try to remove that from his eye. He just cut that thread and brought him directly with the hook. Had he attempted to remove it or something, the whole cornea the results would have been totally different. He would have ended up in a PK and all that.
Were you aware of that anatomy of that barb before, or you just
I
googled
decided
it before?
on table. I decided on table.
Because that widening, creating that extra corneal tunnel to fish it out, I think that was a take-home message from this.
That was the main thing because
unless he knew the anatomy of it, it's very difficult. I never knew that it had an extra hook barb there.
Yeah, it's a long video. I edited my earlier manuals I had to edit because of the time limit. I tried different maneuvers. I thought I'll extend that section. Then I actually tried to cut the earthworm through and through, and I thought the other end could be pulled because it has a hook there inside. I thought, can I pull it reverse? All that was, on table I was thinking, and it was very difficult. Then I decided this would be the easy way out because the entry site was anyway big. Entry site, the first point of entry was anyway big. So I had to just extend the second point where it had entered. So that is how. Thank you.
Which place is the patient from? Because rarely.
Patient is from area of in Maharashtra. This is Savantwadi site.
So basically towards Goa side.
Towards Goa side.
No, it was oblique entry, no? Why you had to put that many sutures? I mean, there were more sutures actually. Corneal suturing was, Was it required that many?
It was
Oblique entry?
yeah.
You could have put a bandage contact lens and then got away with
But it
that.
was quite big opening, sir. Two here, I had put corneal sutures because it was not very even. So I thought it might post-op leak and Anyway, more than 2 millimeters, I feel it's safer to put. And post-op, if it leaks or endophthalmitis and all that issues, it would leak.
So there was a track, a circular track at that. And how about making an incision along the track anterior to the metal? You could have just lifted it off, a clean incision on the surface of the metal in the cornea.
Through and through.
Through and through the cornea.
Yeah. But then the visual axis, it would come through the visual axis.
No, but then even this metal which was there for some time would have caused an opacity. And
No,
a
it
clean
didn't.
wound would not matter much, it would not add much to the opacity. So I thought
No,
that was one way of
my
removing
point
it without traumatizing the cornea. Because the way you pulled it out probably would have caused damage to the track itself and maybe cut through some areas of the corneal tract. But if you had incised in a very more controlled manner, probably it would have been possible to lift it out straight away and then if necessary suture it. I think that was one way.
No, there was only 2 entry points.
Definitely a good idea.
But it's gone in the AC and then come out, sir. It's not only in the cornea.
It's a full thickness.
It's a full thickness.
That means
Both
it needed
were full-
suturing anyway.
Yeah, needed suturing anyway.
It needed suturing anyway.
So I didn't want to suture in the pupillary axis. I wanted only these 2 ends to be sutured so that at least pupillary zone is clearer.
I was just worried about removing it in an uncontrolled manner rather than making a good clean incision and removing it in a more controlled manner. That's what I was thinking.
Other option of removing it. Excellent.
Thank you.
Thank you, sir.
I think ultimately he has bonded the relation back between the father and the son. Otherwise, the son would have cursed the father lifelong, and I think giving a 6-9 vision in various possible ways, I think was good. Thank you, Dr. Sachin. Yes, Dr. Ameya.
Yeah, thank you for this opportunity. Today I'm going to show a video of the ICL. So basically, all of us believe that the visco is a friend of ours when we are doing surgery. Here I am to tell you that in ICL, visco is not your friend. So I've stopped using visco. What I do is I only use fluid. The trick here in loading is not to use much visco because the surface tension will push the lens out. And then once you catch hold of the haptic, you keep that particular hand stable and you pull the cartridge away. That is the easier way of loading this particular lens. Once we do that, some amount of visco for it to flow in the AC. Here you will see I'm using continuous irrigation and I'm putting the lens under irrigation. Now you have sufficient bottle height, you will have a deep anterior chamber, so there's absolutely no need to worry about what happens to the lens or what happens to the endothelium. This way, what I've realized is you avoid most of the problems that you have immediate post-op in a case of ICL. That is, the visco retains, the patient gets uncomfortable, the IOP rises. You can see all these things can be easily done under hydro without much of a problem. And the trick here is to not put pilocarpine. What I do is, this particular IA, while I'm doing, the irrigation is infused with adrenaline. Once I have put the lens in and the air bubble in, I'll change the bottle without adrenaline and wash everything out. That ensures that I have a small pupil at the end of surgery and you don't have to put pilocarpine. Thank you.
Do you prefer to put air at the end of the surgery?
Because I'm using fluid here, I have no other option but to put air, because the moment I take it out, it's going to collapse. Because there's no viscoelastic, I have to put air.
No, Amay, what problems that you have faced with visco?
Sir, with visco,
There will be initial slight, rise of pressure, but that you can take care of, no? With the mannitol, with this thing, something like that.
Sir, I'm not very comfortable taking the visco out from behind the lens
No, you
in
need
a
not.
young patient.
You need not take young patients
Yeah.
with a good USL outflow, good trifocal measure. Eye will take care of itself. Only thing is initial that maybe first 12 hours.
That initial rise in
yeah.
IOP that occurs, we've had patients come back in the evening saying they have pain, headache, and of course there is some haziness afterwards. So that wow factor that you should have after an ICL surgery is probably blunted a little bit because of the experience. So this is what I thought would take everything out of the problem. You're asking what about the lens flipping? Yeah, if the lens flips, unfortunately, then you have to put visco. There's no way you can readjust or cut the lens under hydro. No, then you have to put visco.
No, usually lens will not flip unless you want it to flip. You just keep on injecting in jerks, allow it to open up slowly, then definitely.
No,
so far
I do have a video where the lens is flipped, sir, and I assure you I do not want it to flip, but it can happen, and yes, we do need to use visco once it flips. There's no other way of unflipping it. So.
One more point.
Yeah.
One more point.
Yeah.
Did you use iris repositor for tucking in the lens?
No, it's the same repositor that the company gives us.
Okay.
It's the same thing. Okay.
Thank you, sir.
Thank you.
So now we'll have Dr. Deepak Megur to present his video. And we'll follow that with Dr. Sushil.
So my video is just very basic. It's about PC tear, which all of us encounter, nothing very dramatic. So I just like to highlight few basic take-home points that whenever we see a PC tear like this, our goal in subsequent manage is to ensure that we don't enlarge this PC tear. There is, and how can we manage to put the IOL in the bag even in such situations. So whenever we notice, the first thing we put is always a dispersive OVD, then we try to delineate the vitreous prolapse by putting in triamcinolone acetate. And then the first important take-home message before we put in your vitrector inside is to lower the bottle height, because when we're doing your cortex aspiration, the bottle height would be around 90. So the first thing when we want to do, if you want to preserve the tear from opening up, is to bring down your bottle height. So I typically keep it at just 30 centimeters when we start the irrigation with the vitrector. That is the first important. When you immediately irrigate, open it with 90 centimeters, the first reason why the PC tear suddenly blows up, and you lose an opportunity for that. And sorry, what happened? Okay, now the second tip would be to place the vitrector behind the level of the posterior tear, and then you take care of the prolapsed vitreous. The positioning of the vitrector is essential so that you can control the turbulence apart from your the irrigation force which you have put in. And once you're sure that the vitreous is there, then you manage the cortex. The cortex cannot be managed with the vitreous still inside the antechamber. And whenever, of course, there are situations where you can still notice that some vitreous fibrils will be coming out, and you have to again resort back to the cut mode. So you can use the same cutter to aspirate the cortex as well. And next, once you're sure that the bag is bag and the antechamber is totally devoid of any vitreous, I'm going to inflate the bag with a cohesive OVD that creates enough space. And then you're going to manipulate the single piece lens into the bag itself, the original planned single piece lens. And we can still go ahead and remove the viscoelastic also, which is gone behind the lens. Again, the take home message here would be just to ensure that the bottle height is maintained appropriately. So initially you start with very low, 30, and then you gradually increase once you feel that the chamber is shallowing. If you can maintain this principle, most often than not, you can continue to do the surgery without extending the PC tear, and you have a great opportunity to put the lens into the bag. The message why I'm trying to tell you here is one of the reasons why the pars plana approach for performing antivitrectomy is to prevent the PC tear from enlarging. But if we follow certain basic principles, even through a limbal route also, you can perform antivitrectomy without enlarging the postcapsular tear. So that was the message from this video. Thank you.
The message is very clear and taken, Deepak.
But how do you ensure that it doesn't enlarge?
Yeah, two things. No? First thing, the most important reason is raised irrigation pressure. So usually the bottle height will be set for say 90 centimeters when you're doing a phaco or IA, and you continue with the same irrigation bottle height when you start doing vitrectomy. So suddenly when the fluid enters with that much pressure, that's the only reason why the PC tear enlarges. And second, if you're holding your vitrectomy cutter above the PC tear when you start to do the vitrectomy, it is going to suck and aspirate some of the vitreous from posterior. That is when vitreous prolapses more out of the posterior chamber across the PC tear, that is going to enlarge it. So these two are the primary reasons why the posterior approach was thought that was better, and which we can mitigate both these things even with the anterior route as well. So that is the idea.
You are trying to do the same thing but not going through the pars plana.
Yeah. See, the basic principle of pars plana approach, which was popularized by Dr. Chang and Dr. Basavada, was it's going to decrease the chances of enlargement of PC tear if you do it from posteriorly. So if you understand the fluidics properly and use similar principles, even the anterior limbal route, similar results can be got. That was the idea. So lower irrigation pressure and placing the vitrector below the level of the PC tear when you start your vitrectomy.
Thank you, sir.
Direction of that irrigation.
What if your PC tear still extends in spite of all your maneuvers?
Of course, then you are resorted if your PC tear is still not small enough for you to consider implanting the lens in the bag, then you have to implant the lens in the sulcus with optic capture.
So you are using Helon the moment PC tear happens?
No. When PC tear happens, we are using dispersive OD, that is chondroitin sulfate or viscoat-like. And after vitrectomy, you are trying to put in the lens. That's the time I'm using Helon-like thing, that is cohesive OVD, sodium hyaluronate.
So why would you not like to consider Helon in the first place as soon as the PC rent occurs?
Both functions are entirely different. The viscoat property or the dispersive OD property is it acts like a more of a barrier. It is difficult to remove it out. It acts like a barrier, contrary to the Helon, which comes out in bulk. So the cohesive OVD property, that's the Helon property, is to create space, not to create a barrier. The barrier effect is got by the chondroitin sulfate content viscoat-like substance. So both have got different functions, and you can't switch them, their role.
So
No,
direction of that
second
irrigation.
reason is why you should use cohesive is removal becomes easier.
Second thing also, the PC, tendency of the PC to come up when you're trying to implant the lens, that is not there. So when the PC comes up, the chances of that rent again increasing become high. To maintain the space and the position of the PC in its place, use the cohesive OVD. It says, and then second advantage, it comes out easily, relatively easily. So if you use HPMC that time, what happens? The chances are PC might come up during that time and the tear can enlarge.
Comment about the direction of that infusion.
Yes. Usually, you advisable to keep it as away from the postcapsular tear as possible. You keep it at the limbal and direct it towards the angle. In this case, it was towards my right hand and my irrigation was to the left hand. It is not an issue. But there are certain situations where the PC tear happens to your left hand irrigation side as well. But still, if you can, it is not so much critical as is maintaining your bottle height. If you are able to control your bottle height and reduce it, that is more important than the position which you place your cannula.
If this had enlarged, like it happens in most of the cases with us, what you would have done?
Obviously, if the PC tear is big, you have to abandon the idea of putting the lens in the bag and then use a multi-piece lens, place it in the sulcus and optic capture.
Do you do any power modifications?
But If you're doing optic capture, I don't do any power modulation because it's ultimately the position is going to be in the bag. If the rexus is so large and you're not able to push it back behind the anterior capsular margin, then I will be undercorrecting it by plus 0.5 diopters.
And what will be the orientation of the haptics in a thing like this?
In this case, it was in the bag. It has to be...
No, not here. Like if this had enlarged,
Okay.
you would have kept your haptics.
The haptic question does not arise here because haptic is now in the above the anterior capsule. So if you're not putting it in the sulcus, it doesn't matter because the rexus is intact and the PC tear has enlarged already now. So it doesn't matter where you put. If the rexus extension is there, then you have an issue of orienting the haptics. Here it is not an issue. Because if you're putting the lens above the anterior capsule, it doesn't matter where your PC tear is, how big it is PC tear, you can, doesn't matter. But on the, if you want to put it in the bag, then obviously your haptics have to be away from the area of posterior capsular tear.
Deepak, when you are using the contracting sulfate and this combination dispersive viscoelastic, right? So you are doing vitrectomy in the plane above the tear, or you go into the anterior vitreous and you remove that vitreous also?
No,
because once the vitreous prolapses through the rent, as long as rent is intact and there is no vitreous prolapsing through that, it is fine. Your scenario looks very good. But by chance, if there is vitreous prolapse through the rent, that itself will try to enlarge the tear irrespective of the...
No, you're absolutely right. The tear has enlarged only because the vitreous is prolapsed out now. The tear has enlarged. The shape of the tear has become round.
No. I think you are not getting my point, because tear can expand even without the vitreous prolapse.
Posterior capsule is more forgiving than the anterior capsule.
No, I do agree with you. No, I'm talking about the PC.
Because of vitreous, the enlargement will not occur.
No, the PC rent, the tangential forces are totally different. You might still not have a vitreous prolapse, but still your rent increases.
So, okay, I got your question. Now, where do you place your vitrector? The vitreous is already there in the anterior chamber, and there is a PC tear.
Yes.
It's already enlarged.
Yes.
Now, where do you place your vitrector?
Yes.
So, the vitrector has to be placed, I place it at the level of the PC tear or behind it with the bevel up, then start the cutting. The prolapsed vitreous, which is anterior, first gets dealt with by the vitrector. Then only I deal with the vitreous which is behind the posterior capsule.
Okay.
So I'm not placing the cutter in the anterior chamber and then sucking it out, because that time it will bring more vitreous out.
Exactly.
That is the reason. That is the place when you have the expansion of the PC tear.
Yeah.
So the same principle of a posterior approach can be got by the anterior approach as well. Just you have to go behind the PC tear, turn the port upside, and then start your cutting.
Yeah, because why I am referring to this was because when Dr. Abhay Vasavada, he presented his technique of doing pars plana vitrectomy, he was showing a cotton wool.
Yeah, same thing, no? So you're pulling it from down.
Yes.
Why you have to go from pars plana to place it down? You can always go through the limbal approach and place it below the level of the posterior capsular tear and then do it. That's the whole idea.
So at the end of this, again you put triamcinolone and check whether there is any vitreous there in that area?
Yeah, I do that.
Okay, you confirm that there is no more prolapsed vitreous there in that area?
Yeah.
Okay.
Always.
What happens for a beginner is, the moment they see the PC rent, they take out the probe. Panically they take out the probe. They don't inject the visco and then stabilize it and take out. So what happens is the vitreous comes and sits even in the wound. That, how do you manage it now? Because just with a vitrectomy probe, that stuck vitreous will not come, and you keep seeing that kinking of the capsule every time.
Yeah, I think it becomes a very elaborate vitrectomy discussion. Yeah, I think whenever that you see in the wound, I think I would first clear the wound first before introducing my probe into the anterior chamber. First clear the wound, we see. And when you use triamcinolone, you can clearly see where the vitreous is. Once you clear the wound, and then again you go through the limbal route and then you start. See, there is one problem where you have one or two strands itself coming out. And this is the time when I use the IA cut mode. Usually we have irrigation cut and aspiration mode. When you're dealing with one or two single fibrils which always cross to come to the wound and they're very difficult to access. This is the time when I use this IA cut mode, where you just catch hold of that one fiber and then cut. Otherwise, it should not be a problem.
Because taking the vitreous out of the wound is important. Otherwise,
no, you have to first do it. First do that part from external and then enter inside.
Shankar Gada, I would like to take your point very well, because each time when a PC rent happens, it's a natural tendency that you want to get your instrumentation out. So you want to be playing safe. But unfortunately what happens is the sudden shallowing of the antechamber will increase the size of the rent and there will be more vitreous prolapsing. It may come all into the wound also. So the best option would be that as soon as you notice the rent, okay, even if there is no vitreous prolapse, so don't try to bring the instrument out of the antechamber. So from the side port you inject your say dispersive viscoelastic or even HPMC, anything that is at hand where you can still say form the chamber. You may not be having access to heal on it at the immediate setup, but at least even if you are using an HPMC, and that can be removed anytime immediately after once you start, but you can still maintain the size of the rent to the same extent and manage the case better. So this is my another point I wanted to come.
Thank you.
Thank you, sir. That left us with a lot of pearls.
I think Deepak had the maximum. The rapid fire became a prolonged firing. Not sorry, that's the beauty of the topic that you presented.
Yeah, good afternoon everybody. I am Dr. Sushil Kakanki from Ilkal. I will be showing my videos on my complications, zonal dialysis. So I feel complications are known to happen, and for a beginner like me, it's important to record our surgeries. That helps us to recognize our mistakes and that makes our surgical skills better. So it's very important to record our surgeries. I'll be showing two of my videos where I have done a SICS and ended up with a zonal dialysis. So this is the first case. This was a mature cataract. The sound. So this is a mature cataract, fairly good rhexis around 5 to 6 millimeters was done in this case. This much of rhexis was enough to prolapse my nucleus out of the bag. So I did a hydro dissection, and with a hydro cannula only I tried to prolapse the nucleus out of the bag. So you can see the pressure that was exerted on my bag. So in this case I did a visco expression. Usually I do a visco expression only. So there was a zonular dialysis 2 o'clock zonular dialysis from 12 o'clock to 9 o'clock position. I do a temporal incision regularly. So you can see a zonular dialysis here. So it was a mature cataract. This is the first case which I have shown. So adequate size of rhexis was done. Probably the handling the nucleus with a single instrument added the pressure on the bag by one pole of the nucleus, and along with the forceful expulsion of the nucleus into the anterior chamber gave a way for zonular dialysis. And probably I feel visco expression also added a pressure on my zonules. So there was no vitreous disturbance in this case, and the case was very well managed with iris claw lens. So the pupil was dilated with a pilocarpine and iris claw was implanted. There was no vitreous disturbance. So I will be showing a second case. Even it was a hypermature cataract. So it was an intumescent cataract. The intralenticular pressure was high. So it was reduced to, I did a rhexis, primary rhexis and secondary rhexis. A fairly good rhexis was done in this case. This much of rhexis was also enough to prolapse my nucleus out of the bag. So in this case there was the proper staining was not done. So you can see my dialer is going more periphery and near the capsular margin. So it was placed more on the capsular margin only. So again with a single-handed instrument, manipulation might have led to a zonular dialysis. So same visco expression, and you can see around more than 180 degrees zonular dialysis was there. So it is exactly on the area where my dialer was there. So again the pupil was constricted and iris claw lens was placed in this. Yeah, again my manipulation with a single instrument, because of improper staining of the capsule, the dialer might have got hooked into the capsule margin, and this may be a reason where I ended up with a zonular dialysis. So, and there was no vitreous disturbance, and it was very well managed with iris claw lens. See, and how better I would have managed in this case was, like instead of using a single instrument in first case, with iris repositor and a dialer and cartwheeling the nucleus slowly into the anterior chamber would have prevented the zonular dialysis. And instead of putting iris claw, since the dialysis was quite small, PC lens would have been placed in the back. Thank you. And in second case, I didn't remove the capsular bag, which was of no use, because in future if he develops a posterior capsular opacity, doing AG becomes difficult. So now I remove, if the dialysis is more than 180 degree, usually I remove my capsular bag and I place iris claw lens. Thank you.
Well done, Dr. Sushil. I think Dr. Sushil Kakand is a very good phacosurgeon, and he records every surgery. He has hundreds of surgeries, but I requested him to present an SICS case from his formative years. So he has selected this for us, even though he is a phacosurgeon. He has selected because we know that in today there will be a lot of phacos. I wanted an SICS case to be discussed. Thank you, Dr. Sushil.
Thank you also for showing the complications. We learn more from the complications than the good surgeries. So I really appreciate that. And you analyzed all your mistakes very accurately, and you pointed out all your mistakes. The questions which I had in my mind that, why didn't you put a CTR, you already analyzed that also. So
one thing I would like to differ is, it's not a good idea to remove the capsule unnecessarily, even though it was almost nearly 180
that's
degrees.
True. That's
because
true.
Have a PC, it's always a physiological barrier. Even though incomplete, it's a physiological barrier. To completely make it bereft of all the capsular thing is not a great idea. Maybe now there are techniques to, even if it is 180 degrees also, we can still probably put a segment and still keep the bag properly stretched. But even then, even if you are putting an ACIOL, you seem to be an expert in ACIOL, iris claw. Fantastic
iris claw lens though is superb.
Yeah.
You
So, I don't think even if the capsule is intact, we'll be putting it. It's so good. But I think not a good idea to remove the capsule if it is almost intact in almost 2-3 quadrants. Better to leave it. PCO may not be a very important complication, but the physiological barrier in most times is always better to keep.
Thank you, sir.
Sushil, you have presented your complication very well, but the thing is, in that second case which you showed, your axis was quite large, right?
Yes.
It was nearly more than 8 millimeters. So in an 8 millimeter axis, you would definitely not encounter this problem, because even if you do not have the proper staining of the capsule also, probably what I felt is that you have missed the proper plane of the hydrodissection. Okay, when hydrodissection was not complete, then your nucleus rotation, when you tried, has probably pulled the zonules out or made zonules more tremulous. And finally, when the nucleus is already into the AC, significant zonular dialysis had already happened.
Yes, sir.
That could have been prevented had you checked whether your hydrodissection was complete. If you are rotating the nucleus within the capsular bag at the end of hydrodissection, it will remove all the nuclear adhesions, whatever is there, because of the fluid in that space. And once the nucleus is freely rotating, okay, and if you use your cartwheel technique with your 2 instrument technique, definitely the nucleus would have come out without causing any zonular adhesions, unless there was some pre-existing problem. Had it been a case of pseudo-exfoliation, I do agree. But for any SICS surgery, when you are doing such a large rhexis, and I see some people, they would prefer to do an oval rhexis, okay? Oval rhexis will definitely help, because when you are trying to tumble out one end of the nucleus, it comes out more easily when you do an oval rhexis than a complete large 8 mm rhexis. In that second scenario, this event should not have happened. I think you have to have a little, you should keep your mind. It does happen with everybody. And it is very nice that you are presenting your complications and that too in front of such a big audience. And so many critics are there to criticize you. But it's always nice that you have presented this. But this thing you should keep it in mind to ensure that the hydrodissection is complete.
Okay. Thank you, sir.
Well done, Dr. Sushil. Very well done.
So with that, we come to our final video by Dr. Sanjay Rasad. Sorry, we have 2. Dr. Shivaji, and then we'll come to, so Dr. Sanjay Rasal first.
I think at the end of the day, when you are through with your phaco and you are doing last case and your coffee is ready, you are done fantastic phaco, you are about to implant the lens, you think you are coming out of the theater for a nice coffee break and your IOL opens like this. This I wanted to share and just wanted to know the reasons behind crushing of this IOL. Why this happened? Panelists, please. How we can prevent this and what can be done next? Please start the debate.
I don't think it is reproducible. Even if you want it also, you can't.
You think your day is over, long day is over, this
No.
is your last case?
Rewind the video, that's all.
That's a good one. What could be the reason behind this? Yes, mics are there, please.
Spiked plunger, something like a spiked shoes.
Okay, what can be done? Now, you have it.
Sanjay, what was
Your coffee is ready, you can go and have it.
Sanjay, how was the tip when you were injecting the?
It was beveled down.
It was beveled down.
Yeah.
Okay. Anything had been done to the?
No,
tip?
no. I will show the loading of the lens. I will show everything. Initially, I forwarded. You saw the video.
Yes.
Initial few minutes, I forwarded it and then played.
Okay.
I wanted to skip the loading of the lens.
No, I
will show that.
I have seen the haptics getting cut, but the optic portion.
But I
getting
wanted
cut
to
like
know
this.
what is the reason behind. What are the your like how you imagine what could be the could have gone wrong loading the lens or
the plunger has injured the optic.
I will show the loading. Just see again. Anything wrong here you feel? Visco is there, the lens is picked up nicely, that is loaded onto the cartridge. Okay, it is pressed well in the groove. The distal and the proximal haptics are well approximated towards the haptic. The half moon sign is correctly there. The lens is nicely moving forward. Okay. Now what I did, I had no option but to cut this IOL with the crocodile scissor or a IOL cutting scissor. The IOL is aligned in such a way that the cut ends are brought in the line with the tunnel. With the copious use of viscoelastic above and below the IOL to ensure the protection of the endothelium, the IOL is divided in two halves. One proximal haptic is already cut. These pieces are removed. The last piece is difficult to remove through 2.8, so I have to divide it again in two pieces. The distal haptic is brought in line with the tunnel. It is brought outside with the McPherson forceps or IOL holding forceps, and this piece is again cut in two pieces. Every time when you try to cut the IOL, support this IOL with the Sinskey hook or other instrument. Otherwise, it just flips and may damage the endothelium.
No, I carry everywhere, wherever I go for leisure.
So this piece is divided in two small pieces. And another IOL is loaded and it's implanted into the bag. And this is how I manage this case. Now the reason behind I could find out is, nowadays or for several years I am hydro implanting all the IOLs. So we always try to save the time, surgical time, and try to finish the surgeries as early as possible. So while hydro implanting the IOLs, means once we finish the phaco, we come out of the, means we are off the microscope. We have to remove the phaco probe, remove the IA, join the bimanual, and then again start the bimanual. We start from the left hand irrigations, right hand aspiration, again exchange the hands, and again load the lens, again enter the entry chamber. So I was thinking, why not to load the lens and keep it before the IA? And once I finish the IA, immediately I can put the lens inside. So that time spent for doing the IA made this lens very stiff, because hydrophobic lenses, they become very stiff, and your theater is air conditioned, it's very chilled in the theater, and that acts as a stiffening factor for the lens. This is the second incident I faced. Since then again I switched back to my original technique. Rather than saving time, which landed in spending more time for me, and extended my coffee break. So that is the take home message. Other factor could be the wrong selection of the cartridge. Means the company provided one cartridge and your assistant opened other cartridge. Because nowadays almost all companies have same type of cartridges, barring some Alcon or AMO. So that is the point I want to highlight here. So don't keep lenses loaded unless it is a phakic IOL, that you should load the phakic IOL well before you open the eye. But here in intraocular pseudophakic lenses, you load just before the implantation. Thank you.
Very great point brought out, I think, Sanjay. Because it's very difficult to find a complication in a man's like Dr. Sanjay Russell, but still he has picked up one. I think this is a point, this is very important, but I may not agree with you completely. I load the lens before IA. And knowing Sanjay, he wouldn't have taken a lot of time in the IA. So it's very unlikely that the lens would have hardened to the extent that it has gone through the, probably it must be a cartridge malfunction. It's a cartridge malfunction, maybe some kind of an internal spur within the bore of the cartridge, some manufacturing defect or malfunctioning. Then it would have probably the smooth, the egress of the IOL, it would have probably met with some kind of an obstruction or some spur inside, which would have caused this. Because I don't think any kind of waiting with the loaded lens.
Did you find much of a
Resistance, that's all.
Yeah.
If this is a double speed video,
then
this is a double speed video. I could literally feel the resistance, that the lens was not moving.
I know, that resistance could be also because of something inside in the exit, during the passing
the
of the...
cartridge was absolutely normal.
KP, that OT temperature in
Could
your
be
OT
that-
and his OT is different. So your lenses don't get hard.
But I think
Another reason I could find out is the size of the cartridge.
Yeah, maybe that's it.
Could be.
Yeah, that could be.
And this being a very new lens from
Yeah, it
IOC,
happens. It
I don't
happens.
want to disclose the name, but could be that is a factor.
No, I think many company can have a
it is
wrong
possible.
manufacturing defect, it is there, but it's less with the better brands. Obviously, I think the point here is, because why I'm trying to empathize with him is, we had made one thing on IOL implantation blues. We collected a lot of unthinkable possibilities of problems with IOL, because the moment we finish phaco, like we all showed how to remove the cataract very easily. But once that thing is over, we always give less importance to loading and implantation and what damage we make it to the eye. Capsular zonular apparatus or to the IOL itself. I think this is a very important point. So we always have to go on one step higher.
Yeah.
Like, I don't want to have this complication in my eye. I may have an IOL finally in the end of the surgery, but still I don't want the crocodile forceps to go into the unnecessarily. So that's probably we are breaching the quality.
I think,
somewhere.
That's
two important take-home messages.
I always stress, being a surgeon, we don't have any option but to learn all the tricks or all the methods that these companies are coming, fancy loading techniques, some front loading, some back loading. All IOL companies, they come with the fancy different videos that as a surgeon we have to remember, learn, get used to that particular technique and pray that your IOL goes smoothly in the eye, because that is beyond our control.
I think the two take-home messages from your presentation, sir. First is whenever you feel something unusual resistance, just abort it.
Abandon, yeah.
Abort it and load a new
I thought
lens.
exactly same.
No,
I would have,
we are
yeah,
so,
yeah.
what do you say, greedy to save some time. I said nothing will happen. Chalta hai, and फिर it takes half an hour for to deal.
Yes.
The first thing. And second thing, which I always tell myself and all my fellows, picture abhi baki hai mere dost. Until the patient gets up and goes. Remember, keep telling yourself, the loss of attention is the single most important reason all these avoidable mishaps can happen.
Mistakes happen.
This was, you know that it's getting hard, pushing, something unusual happening, just come out.
The same thing I felt immediately after surgery. I would have stopped there only when I felt that resistance. I was pushing and pushed and crushed the lens.
Yeah, I think just remember this one phrase, picture abhi baki hai mere dost.
How
Until
many
your
people
patient gets
the
up.
assistant loads the lens?
Yeah, for my time it happened.
I don't believe anyone. I do personally everything from K1, K2 to doing scan and loading IOLs and finishing surgery, everything I do. I don't believe anyone.
No, I have got lot of lens breakages and lot of videos only because my assistant loads and he doesn't use a microscope. So the chances of that is more.
Not presbyope, no?
No, he's presently not presbyope.
No, because I still remember 2 years ago, I think when Dr. Deepak Megor was doing a live surgery, he was given a very new lens. Like we kind of experimented with that lens and the lens broke. Because it was, see, it's always that we do not know what is the amount of pressure we need to put. And Dr. Megur very elegantly showed how to manage it. How to manage a cut lens. It was not a planned one. It was a complication that happened during a live surgery. So probably since then, and the only thing is he always carries all his instruments including the crocodile forceps. That day he had not got his osseous forceps, that is the crocodile forceps, and it happened. And since then he's carrying it, even today he carried it, but we gave him a Clarion lens, which should not break.
No, even hydrophilic lenses, they are very quick. Some lenses are very fast. So we have to be really careful injecting the lens. If you apply undue pressure now, it will go through and through in the vitreous. I have one video. I will share some other time, but that is how it is.
Dr. Sanjay, one point I want to clarify. Because whatever the IOLs that you were talking about, that the hydrophobic lens became stiffened.
Yes.
Okay, the moment you open the lens case, you will automatically see under the air conditioning that the lens does show that signs of stiffening of that hydrophobic lens. But all these lenses, blanks, whatever they are there, they go under stringent quality control situations where these situations cannot be anticipated unless you are doing something mechanically. So what has exactly happened is, everybody has pointed out that when you felt the pressure within that plunger, cartridge, exactly, okay. So probably either the visco was not, well coated in all directions in the front as well as at the back.
No.
Some people
visco is not an issue. Most of the times we don't use visco for the loading of the IOL nowadays.
No, see, actually,
you must have seen surgeons putting all way hydro. Just Ame has shown, he has shown literally time-saving procedure, but it is a little risky in a phakic eyes. But loading lens without visco is also possible.
No.
So visco is not an issue. And I have shown the video. The visco is copiously used. The IOL is totally covered by totally from front surface and under surface totally coated with the visco.
Yeah,
so visco is not an issue. Only issue I could point out is the temperature, stiffening of the lens, and I could have abandoned the procedure when I felt that resistance while pushing the lens. I could have stopped there. But as Deepak said, we are always in a hurry to finish the things and
Yeah, picture abhi baki tha. Okay.
So that coffee break, this complication made to wait. Almost I spent half hour exchanging.
No, probably there was some fault in that plunger.
One more is what Deepak told was right, because you must load under microscope. Yes. And another thing is that presbyopic edge, just that crossover edge, even I had a couple of problems. I was reluctant to do it. Usually I used to do in a bare eye, but I had a couple of problems like this. And then I started, okay, let me do it under a microscope and other things.
No, moral of the story is, somehow the lens breaks for 101 reasons. You should know how to explain it.
One more point That's why I don't believe any preloaded lenses. I open up them, I realign them, I see the alignment is satisfactory, and then I implant.
I think one about preloaded is some of the Indian brands, they are stuck to the base of the cartridge. If you just put visco on, just close it and start pushing, you will get resistance. Make sure that you dislodge them. Okay, slightly just push it front and back so that it gets dislodged, because some of the especially hydrophobic lenses, they are stuck to the base and they are totally immobile. So you first wash or slightly dislodge it and then put visco and cover it. I think Shivaji.
Yes, sir. So before we start with the final presentation for the 3D Live Wire 3.0, I just want to make a small announcement. For the 4.0, we have given you all these feedback forms. So we'd really appreciate it if you could fill them out. And as you exit, Vinita ma'am will be standing with your certificates. So if you can just drop that off with her, that would be great.
KP, do you really need
4.0.
feedback from us? KP?
That'll do. Okay, sir. You can proceed.
Hello, I'm Dr. Shivaji Parvaki. I thank KP sir for giving me this opportunity. I'm going to show you two cases of opaque IOL explantation, which I did recently, 15 days back.
Shivaji sir, sorry to interrupt.
Okay.
The forms are being given by the Chetan Business School, and they are doing a small survey about the marketing in ophthalmology. Various questions, I think you might have gone through it. It's done by the IIM as in collaboration with the business schools management of how to improve the ophthalmic practice for the doctors. So if you can really fill that form and send it back to us. If at all you are not able to fill it now, you can just share it with a soft copy to one of the numbers. That will really help us, and they will analyze it. The experts in the business management, they are going to analyze it, and we will share you what they have analyzed through all these process. So that will really help all of us. That's the reason why they came with the whole team and they try to do that. And also a few reputed B school professors are also involved in this, just to make our practice more and more better. So that will really help us. So please fill the form. Thank you. Sorry, Shivaji sir.
This is the first case. I'm going to show you the explantation of the opaque IOL. After making all the incision, some IOLs, they come out very easily. Like this haptic came out very easily. The other haptic is firmly other end at the capsular fornix. I thought it will come out with some manipulation. While bringing it out, I ended up in some journal redations as well as a PC rent, which I will show you later on. So here I ended up in PC rent here. Next case, this is also a 7-year-old opaque IOL. This is a one-night patient. See, it is firmly other end here at the fornix, in this place. Any further attempt will definitely lead to general adhesions. So what I did was, I just cut the optic-haptic junction with the 1/2 scissor. These are very soft lens you can cut with 1/2 scissor. You don't need any special instruments to cut these hydrophilic lenses. And the other other haptic also very much firmly other into the capsular bag. So similarly, it was the haptic optic junction was cut with a 1/2 scissor. And it was taken out to the scleral root. And I am further trimming the haptic which is left there. Once you wash the posterior capsule, you can place sulcus lens. You should place sulcus lens, preferably 3-piece lens. You cannot place the lens in the bag because it is irregularly fused bag. Any attempt will further injure the bag and make it displaced. This is a one-night patient, and she is very happy now. So my take-home point is, if the lens doesn't come out that easily, you cut the optic-haptic junction, leave the haptic there only in the bag, then implant lens in the sulcus. That will be the safe and easy method. Use copious amount of visco, either cohesive visco or dispersive visco, whichever protect the endothelium, protect the PC. Use two instruments to bring out the lens out of the bag. If it is not coming, don't force it, don't excessively move it. Just cut the optic-haptic junction, bring the lens out, only optic part. And you can leave the part of the haptic there in the bag.
How can you actually reduce the size of the incision if you are planning a foldable lens implantation?
No, I usually go with scleral incisions. I do all my explantation with scleral incision.
No, KP was meaning that, can you cut the lens and remove, because it's a hydrophilic lens, no? So
from the corneal incision.
You can make a corneal or a scleral, whatever it is, just reduce the size of the incision.
Yeah, you can do that. You can do that.
You can just, because it's a hydrophilic soft lens.
But I usually implant the time-tested PMMA lens only. Okay. But in this case, patient choose imported 3-piece lens only. That's why I use the foldable lens.
You have a package for lens exchange also.
Otherwise, sir, otherwise
if it becomes white,
I don't believe these hydrophilic or hydrophobic lens. The time-tested PMMA lens only I implant in the case of opacified IOL.
Thank you, Shivaji, for sharing your experience.
Deepak, this we should discuss. See, I think we have been always, revolving around IOL polymer, costing, putting the IOL as the main marketing point. I think it's high time that we think, after doing such wonderful surgery, are we really compromising the final outcome, the long-term outcome for the patient by resorting to IOL just by looking at their cost?
The time-tested PMMA IOL which is very cheap, excellent optical quality, excellent biocompatibility and excellent clarity,
Yeah, that is
and very long track record.
Yeah, that's unarguable, Shivaji, but now they can't be folded, no, that's the whole issue now. They can't be folded.
That can't be folded, cannot be used in the routine cataract surgery, but I use only
in these cases.
In these cases. That's why I make.
But your take-home message was very excellent. If you're finding it difficult to negotiate the haptics out of the fornices of the capsular bag, just leave them and cut them and remove it out. Excellent point.
And place the lens in the sulcus, either 3-piece or rigid lens.
Yeah, sure.
I think whenever I'm supposed to replace a 3-piece lens in the sulcus, in the bag, 3-piece lens, if you are trying to do an IOL exchange, I always cut the haptics as a rule. Because many a time, especially long term, there will be so much, there will be capsule adhesion around it. So you always end up, because the whole bag starts moving out. So best would be, these are bulky haptics. But if there's a single, the 3-piece lens, I think as a rule, you just cut at the haptic optic junction, leave the thing there, and I think here making it an atraumatic surgery is probably more important.
Yeah, more atraumatic surgery. First of all, patient undergoes one surgery, another traumatic surgery, visual recovery will prolong. So best is cut the optic junction, remove the optic out, place the lens in the sulcus, reduce the surgical time and trauma to the eye.
Now, what was the brand of the IOL? In both it was same?
We call him freedom fighter. He's freedom fighter Shivaji. He's been awarded that.
Thank you, sir. Thank you, sir.
So take-home message is avoid this brand.
No. The thing is, why those lenses? I don't know about this particular thing. Earlier, this hydrophilic acrylic. The first generation was like this. The lenses used to become opaque very often. That's why now we have third generation, fourth generation probably. Now we don't face this problem. Probably this particular company.
Recently, I am facing one opacification with some APA lens, hydrophilic lens. Hydrophilic lens are notorious, I feel. They maybe over the period of time, sometimes, especially the thin lenses get opacified. I feel.
I told you is like, I just told my PGs, whenever they're doing an ACT capsulotomy, just look at the fact that what is the IOL. So over a period of 3 years, they get an idea. Because the surgeries have been done maybe 10 years ago also. So you just, how many, this IOL X, you do ACT cap, IOL Y, how many ACT caps. So what is the lens in the eye for which the patient has actually lined up with an ACT capsulotomy requirement. I think that is an eye-opener. That that the case is absolutely for choosing hydrophobic lenses over hydrophilic, because hydrophilics are cheaper. Obviously, they fit into the lower package group, and we normally, normally resort to that, looking at the cost. But a long-term thing, what the patient pays later in terms of PCO, in terms of loss of contrast. Patient may not even come for a capsulotomy, may leave with that poor vision, subnormal vision. Yes, I think many a time the second eyes, it gives a drop in the second eye rate. You got a PCO 2 years ago, they say it was done, it was okay for 3 months, now I am not seeing, so they will change the doctor. So well done surgeries with PCO with a hydrophilic lens probably is a case for not choosing them or maybe reducing its usage. Probably that should be the message for youngsters. Yes, Dr. Sanjay?
Yeah, of course. Material of the IOL makes difference a lot. And as Shivaji has already made us aware on the social media by sharing his lot of exchanges and opaque IOLs, we should take every lens with a pinch of salt.
Fighting group against.
Right, sir. Thank you, sir.
Yeah, I think this section was the most important part of this 2-day program, because entire 2 days we learned how a good surgery to be done. But nobody does the CME to make a complication and then do it, rectify it. And probably like Deepak Megor, where he broke his lens and he managed, that's a bonus. Okay, I call that as a bonus for the CME. Okay, so here we can't come and discuss most of the people don't discuss the problems. But this is one section where they have come out and discussed. This is going to happen even in the expert hands also. Take it from us. This is going to happen even in the expert's hand. So you learn from this, and this is what it will help you. All the good, yes.
Any comment or any final questions from the audience? Because this is the ultimate part of this 2-day program. And we are very happy to have this active participation from all the delegates turning up in big numbers and also sitting through the program till the end. So we are very overwhelmed by the response, and that we are meeting after 2 years. We really brought back all the old memories, and we had a fun time yesterday night in the banquet. And a lot of ideas have been exchanged, a lot of knowledge sharing, a lot of networking. So we really thank everyone wholeheartedly from the team MMBJEI for the support that we have, the affection that has been showered on us. And I thank the panelists for probably the most successful session of the 2-day, Dr. Deepak Megho, Dr. Milind, Dr. Sanjeev Kulkarni, Dr. Shivkumar Hiremat, and Dr. Shankar Gowda Patil for moderating and discussing every fine aspect. And I really thank all the presenters who just had such crisp, well-edited videos carrying such takeaway messages, which led to a lot of discussion and interaction. So thank you so much, all the video presenters.
Okay, so as KP sir said, this is the last session. So before we close it, I would like to thank the people. I request them to please come up here. They are our backbone. Who made this program successful is Dr. Abhishek Baudekar, the organizing secretary, the organizing chairman, Dr. A.S. Guruprasad sir, Dr. K.V. Satyamurthy sir, Dr. Priya Shah has done a stupendous work sitting here all the day for 2 days. Dr. Rohan Dedeya, he has put a Fevikwik on the chair and he has managed it so well. And Dr. Mayank, please come up. And another lady who was stuck in the OT all the time, was an outstanding surgeon. Standing outside the OT is Dr. Rajashri Salvi. Please come up. And Dr. Nitika, our cornea fellow. Dr. Navya, another Bond personality. Where is he? Dr. Paras Khatwani. And then we have Dr. Rutuja Kandale, very slowly and meticulously and steadily she carried out the work. And Dr. Stuti, I think new introduction is Dr. Stuti, and if you don't know Dr. Stuti, if you have any problem in English or phrasing the sentences or the words or this thing, I think we should contact Stuti. She's a wonderful grammar, wonderful vocabulary, and wonderful English she has written. Dr. Mansi, is she there? Dr. Ashwini, I think the tall girl, you all might have noticed, yeah, she's here. Dr. Arya, UV, most dangerous name is UV. That's the ultraviolet. She only has framed it, not me. So we require Dr. Arya to please. And Dr. Renju. Renju is here? Yeah. They are our two Kerala girls who have just recently passed out with flying colors. I think they need a round of applause. Please come over here. And of course, how can I forget our own Dr. Abhishek Dandekar from the Transport Committee. And Dr. Sidling. Sidling, are you there? He was our transporter. Sidling and Dr. Abhishek. They have really done a wonderful job, kept all our guests happy. Dr. Aili. Aili, are you there? Vikas? Vikas Aili. And of course, how can I forget our own staff? Vinita. Vinita, are you there? Please come over. I think she has done most of the work. We all should really appreciate her. Mr. Kutbuddin Mullah. Mr. Mullah, are you there? Mr. Sanjeev Kulkarni. Deepa Dhongadi. She has come all the way from Koppal to make sure that the program runs smoothly. Not there? Okay, they are in the registration. Are they coming? Huh? Tejaswini, correct. Tejaswini? Yeah, Deepa. Sanjeev, but Mullah. Bama Tejaswini, please come. Anybody name? I have forgotten. Oh, sorry. Sudha Patil, are you there? Sudha Patil. Mr. Nagraj. Viresh. I think from past 2 days, Viresh and Vishwanath are sleeping at around 2 or 3 o'clock early morning. They have really been working hard. And most importantly is Mr. Kiran Malwade. Where are you, Kiran? Kiran Malwade. He is the man because of which this conference was free for the delegates. And he bought us a lot of sponsorship. Kiran Malwade, the golden man. Platinum. Okay, it's been upgraded to platinum. Okay, one more DNB student, Kiran Kamath. Kamatre, Banri. And also the photography team, Sanjoy. Where are you? Sanjoy is here. Thank you, Sanjoy. You have done a wonderful job. This is the first time we are collaborating with Sanjoy, and hope so that we keep continuing you, and our association and collaboration will keep growing. And anybody have left? Dr. Nidhi. Nidhi. And of course, how can I forget the video man? Not Dr. Deepak Megur this time. It's Dr. Giriraj. Vibhute. Entertainment. The best comes the last, sir. And of course, Dr. Manohar Puttanna. So for the rest of the delegates who are happily drinking coffee there, I think Dr. Sanjay Russell must be there. He was always in need of coffee, and somebody was telling me what, Dr. Sanjay Russell, what was the culprit? The culprit is not the lens or the surgeon or anyone. The culprit was the coffee break. So I think this is the team who have really worked hard and make this IFEST 2022 a great success. We all directors are really thankful. We are just the face of the event, but I think you are the people who did it and made it possible. So I request each and every one of you to please give them a standing ovation. If it might not be wrong. Meghna also please come up. Meghna Niralgi, who held the fort when we were busy working here. She was working way back in the hospital. Please come, Meghna. That's also an important job, handling the emergencies. Anybody want to say something? Organizing secretarial, chairman or? New Barri. Anybody wants to say anything from the delegates' point of view? Yes, Shafekar sir? No? Yeah, one or two. Where is Dr. Satish Sheth? Sir, you only told about the problems. Now, we want you to appreciate also. You can take any of the mics, sir.
Everything was just wonderful.
Sir, you have been called to feedback about this conference. Yes, Shafekar sir first.
Everything was just wonderful and everybody has worked hard and they all deserved it. Thank you.
No, there is nothing that I need to talk about Joshi team. See, if you see this big group of people here, so many hands that is serving, and Srinivas Joshi is there, he's just all remote controls, He says, you do this, you do this, you do that. At the end of the thing, you get...
I asked you to compliment, sir.
I'm telling you, it's a compliment only. So ultimately what you see is the camaraderie, what you call a symphony. So that's what is happening now. Whether it is Saturday Night Fever or say Sunday Night Fever also should be there actually. So why don't you have it? We'll make it complete. So that people will not leave early in the evening. They'll stay on for the night also. Excellent teamwork, because I've been observing all your, the newer things that you have been doing. So 3D is not the real thing that everybody would like to say, operate in their setup and all that. But when it comes to viewing, you really get the depth perception. And especially the vitreoretinal surgeries and the oculoplasty surgeries, I have been consistently observing Srinivas's work and Dr. Santosh Annavar's work, that these things should be seen in 3D only, nothing less than that. A cataract surgery in a 2D, no problem. Okay, but the depth is very small there. But when it comes to a VR surgery, you know where, at what level you are touching. You feel that you have a surgeon's feel when you are watching a 3D surgery, especially vitreoretina or oculoplasty surgery. So nothing less than that. And I am sure that no one in the country so far has done any event like this consecutively for about 3 years. I think third time, right? Yes. Third time. Fourth time. Because of COVID, even I am forgetting things. So let this saga continue, okay, in future, and come with something higher than this resolution what you are already doing now. Thank you so much. Thanks for giving the opportunity.
Last sentence, that we got fed up at the Zoom meetings. To have a physical meeting after 3 years is an achievement by itself. Keep the flag flying high. And for the state conferences we'll be having, I think we can do impress more about this meeting. Thank you, Team MMJ.
Just like to add, Srinivas, why don't you add 3D in the KOS this time? If it'll be a value addition for our conference, which even AIOS hasn't done so far. Yeah.
The cable will always be there, sir. We will do it. And thank to Ish Kohli, the cable man. I think he connected it at last at 2 o'clock in the midnight. And I slept at 2:30 until I got a call that the cable is ready and we are receiving the signal. Otherwise, this conference would have been a really great challenge if the cables were not connected. So, unfortunately, because of heavy rains the day before yesterday, and most of the areas the cable was cut, and they really worked for 24 hours to restore the cable connection. So once again, I thank our entire team. I think one last round of applause to the entire team who have really worked hard, burned their night oil, and really are the main pillars of the success for the story for the conference. Thank you very much. Thank you. And of course, thank all the delegates, and I request everyone to please enjoy the tea. all MMJEI staff, fellows, alumni, consultants. No, last photo for the day, sir, for the day.